the Masterclass one-day event, and it's lovely to see you all here. Quick show of hands, who's from the north of England? Yeah, about a third. Who's from central England? Yeah, and about down South London, down south, more people. Okay, good. So how many dermatologists in the room? Yeah, and GPs? Good. Nurses? Yeah, look at that. Scientists? Oi! Very good. Welcome. Okay, that's wonderful. And it's wonderful to have you all. Wonderful to have you all here. My name's Chris Boberg. I'm a GP skin cancer doctor from New Zealand, and in collaboration with my partner Andrew McGill, we run a full-time skin cancer clinic in Auckland for about 10 years, which has grown hugely because of the skin cancer issue. We're GPs that have upskilled advanced skill sets, dermatoscopy and surgery, so we do surgery every day, flaps, grafts. We're mentored by plastic surgeons, and it's a wonderful setup. And in New Zealand, we can do that. I know you can't here, it's difficult. So that's us, and we've set up symposiums to teach our GPs in New Zealand and some in Australia, and grow that whole ripple out there with the stethoscope of the skin, finding melanomas in situ, the non-invasive time with the dermatoscope, 100% survival. What a wonderful thing, and I tell you, it's taken off, and our GPs are really going for it, and they are in Australia. So that's us. This is Symposiums. We're looking to come back next year, if you want us to come back, to run a full 2-day course for all the GPs upskilling, and for dermatologists, surgeons to revise. Taught by Cliff and Amanda Oakley. So you can go on our website and see that. But today's the masterclass. Today is when we have some fun and some creativity. We have world experts here who are going to share some magic with you all. There'll be lots of discussion. We're live streaming, so this is what we were doing at the start, just sorting all that out. So as the day goes, this will be live streamed. We're going to use the cases to teach our young GPs back home and everywhere else we go. So it's a learning magic moment from today. So it should be a lot of fun, and have a lot of fun. So without too much further ado, a quick bit of housekeeping, Cliff, and then we'll move forward. Just got to make this work somehow, and it doesn't look like it wants to. So we've got, there it is. So that's today. You guys will have that already. We'll run through that and try and keep the time the best we can, but we do want some flexibility. If there's good discussion, I'll let things run a bit, and we'll use the moment and the magic, hopefully at the end of the day we can have a panel discussion to iron out things that you might want to talk about with everybody. So that's us. So Wi-Fi is the front desk. Health and safety is important, of course. If we have an emergency, I'm the guy that starts running. You follow me. We had to go yesterday, actually, a dry run. So we go out of here, we turn left, we go out the main doors you came in, those doors at the front, the revolvers, 3 of them, turn to the right, and the assembly point is on the street, straight across. That's where we head, okay? So they tested us yesterday, and we had to go and do it at lunchtime. So there you go. The toilets are out here to the right, the stairwell, straight in, and there's toilets all underneath the theatre. Catering will be out the door, and around the corridor and around the corner towards the front of the building. That'll all be set up there where the cafes are for lunch. Morning tea will be in the aisle here as you come out. Just turn left and get a coffee or a tea, okay, and relax. It's all pretty visual, so when you're out there, network and think and talk, because you're doing all the visuals in here. You know, our visual cortexes are great, aren't they? And we visually learn well as doctors and nurses and specialists and things. So that's it. And we will send you PowerPoints of the course. It's been live streamed. So it's quite easy to send you a copy of that. So you don't need to sit and take huge amounts of notes. You can take some if you want to, of course. We won't stop you. Very good. Okay, so, and there's our lovely sponsors. We must say thanks to a lot of them. Without them, of course, we can't be here. It's a long way to come from down under. It's a big trip. We don't mind the jet lag because we love coming here. But we do need the sponsors, and we're looking for next year as well. And we're looking for you to help us network these courses and masterclasses amongst your colleagues. You go back and get on the website and watch out for it, and it'll be great. So there we go. So we're going to do what Kiwis and Aussies like the most. We're going big game hunting, okay? Because we're quite wild people down under. We go out and shoot things and fish for things, and we're quite outdoorsy people. And Cliff, it's great to warm welcome to Professor Cliff Rosendale from University of Queensland. Now he runs the Masterclass Skin Cancer there. It's a fabulous course, and he'll tell you a bit about that as he goes, I'm sure. But Cliff's one of the co-authors of Chaos and Clues, and I'm sure you guys all use Chaos and Clues every day and Blink and everything. And Cliff and I go back a bit, and we've had a wonderful time and fun teaching our younger colleagues and being with them and helping and mentoring, getting all this ripple going. So without further ado, Cliff, it's wonderful to introduce you and have you here today and to kick off the inaugural Masterclass for Symposiums.
Thank you, Chris, and it's great to be here. Thank you. And it's great to see some familiar faces. Margie, hello, how are you? And Finbar, and Stephen, and Lisa. And this is a great chance for us all to get back together because it's a long time between drinks for people like me and Finbar, but we go back a long way. I'm a general practitioner, okay, GP. And I'll get you to turn the lights down, please, so we can see the screen. We're going to talk about hunting for big game. Now, you have a lot of talk about overdiagnosis, the diagnosis of real melanomas that will probably never kill the patient in their lifetime. And that happens. But the problem is we can't prospectively tell which ones are the ones that won't harm the patient, so we have to cut them all out. But there are a particular subgroup of melanomas that are extremely dangerous and that if you don't diagnose them early, they will kill the patient. Now, when you're hunting, you need a manual, okay? And this is a great read. This is one of my favourite books. So if you've got nothing to do for a few hours, I highly recommend it. And this is the hunting manual that you can use in your offices every day. Now, just going back to a study from the Skin Cancer Audit Research Database, which was published just recently, and this is a snapshot of 637 melanomas treated by 27 Australasian GPs in 2013. And there are a lot of authors because all the doctors that contributed data got to be a co-author of this study. And there were 3 different papers in this study. Now, we're looking here at the subtypes of melanoma and the proportion of those subtypes in green that were invasive in this study and the proportion that resulted in metastasis. So, for example, you can see 67% of superficial spreading melanomas, they made up 67% of the invasive melanoma in the study. Lentigo maligna made up only 15.9% of the invasive melanomas, and nodular melanoma only 12.6%. But of the metastases that occurred in the study, nodular melanoma made up half, 50%. So they were the smallest subgroup of invasive melanomas that were responsible for 50% of the metastases in the study. So looking at the adverse outcomes, as far as death is concerned, metastatic specific death in the study, you can see there were 9 deaths, melanoma-specific deaths in this year in the study, and 2/3 of them, 66%, were due to nodular melanoma, which only made up 16% of the actual invasive melanomas. Just making the point that one of the deaths from melanoma in the study was from a thin superficial spreading melanoma with a breast thickness of 0.5. So every invasive melanoma is dangerous, but it's the nodular melanomas that will kill the patient predictably if they're not diagnosed early. Now, looking at my own particular data, for the 17 years from 2007 to 2023, 1,032 melanomas, of which 210 were invasive and 29 of those were thick invasive. Looking at the nodular subtype in my study, 2% of the melanomas were nodular, 8% of the invasive melanomas were nodular, but they caused 60% of the adverse outcomes in my study. And you can see there the 10 adverse outcomes, and of those, now in this particular graph you can see the 10 patients and adverse outcomes. The ones that were pigmented are brown, the ones that were amelanotic are red, and the ones that were nodular have a black border around them. So you can see 20% were amelanotic, 60% were nodular of the ones that had an adverse outcome. And the ones that died with a black dot, 2 out of the 3 were pigmented, 1 was amelanotic. They were all nodular, all nodular. So nodular melanoma is the one that when you find that subtype, that's the one that's really important not to miss. Because if you diagnose it before it's a millimetre thick, there's still a 97%, 20-year disease-free prognosis. Okay? It's the same prognosis, Breslow for Breslow, as every other melanoma, but it's diagnosed later because it starts invasive. It starts in the dermis. Nodular melanoma doesn't mean there's a nodule in it. It means that there's no in situ component spreading more than 3 redo ridges beyond the invasive component. So for all intents and purposes, it's all invasive. A superficial spreading melanoma might get a nodule 10 millimetres thick. It's still a superficial spreading melanoma. It doesn't become a nodular melanoma. Nodular melanoma is a particular subtype from the very start. So, big game. We're talking about nodular melanomas, thick, non-nodular melanomas. They're also very dangerous. We're talking about melanomas that metastasized and melanomas that killed. And that's what I'm going to show you now from my practice. And the first one is a 87-year-old man who has presented here with a lesion, getting some feedback there, is that okay? With a lesion on his arm. Now, what you're going to see here is what I recorded on my SCAR database. And you can see that I recorded here that I thought this was a seborrheic keratosis, and I did the procedure for the declared intent to exclude non-melanoma skin cancer. I wasn't thinking of melanoma, okay? Now, I can't change this. Once you put this data into SCAR before you cut it out, it's preserved permanently. So it came back as a nodular melanoma, sorry, as a superficial spreading melanoma with a Breslow thickness of 1.3 millimetres, but I had not even considered melanoma when I cut it out. So why do we cut things out? We cut them out because we can't give them a specific benign diagnosis, okay? And having decided we can't give this a specific diagnosis because we don't know what it is, I can't say it's a seborrheic keratosis, I can't say it's a nevus. We then put it through a method, and the method for non-pigmented lesions that I use is prediction without pigment. And the first thing you look for in prediction without pigment is ulceration. And if there's ulceration, you cut it out with a provisional diagnosis of BCC. If you can't see ulceration, you look for white clues. And in a flat lesion, that's white lines. And in an elevated lesion, it's keratin clues of surface keratin, white circles, or white structurous areas. And this didn't have those. And then you look for a benign vessel pattern, which is a centered pattern, as in a centered pattern, a clods-only pattern, as in a hemangioma, a reticular pattern, or a serpiginous pattern. And if it doesn't have one of those 4 patterns, you've got to cut it out. You don't know what it is, but you've got to cut it out. It's a decision algorithm. So I cut this out, and it came back as a melanoma. Now, I thought it was a small nodular melanoma. You can see the nodule there clinically, but you can see here with these filtered images prepared by a colleague of mine, the true extent of this superficial spreading melanoma. The nodule was just a little part of the centre. This patient was lost to follow-up a few years later. He was already old. I don't know if he died from that melanoma or not. I doubt it. Now here we have a 42-year-old male, and he's presenting with this lesion on his areola there. And it's a new lesion. That's the history. He's been to another doctor who told him it was a dermatofibroma. And you'll notice looking at the clinical, there's a bit of blood there. When I put the dermatoscope on it, it bled. Now that's not normal. You don't expect that. So this was immediately a lesion of concern. You can see the polarised dermatoscopy. It's got polarising specific white lines. And it turned out to be my provisional diagnosis was that it was an invasive melanoma, thicker than a millimetre, and I did this to exclude melanoma. And it came back as a nodular melanoma with a Breslow thickness of 1.35 millimetres. It's arising in a nevus, a Clark nevus. And that's what the pigmented area is around it that you might think that made it a superficial spreading melanoma, but that wasn't melanoma, that was nevus. So disease-free survival current. So that was back in about 2013 or so, 2008, sorry, and he's doing fine. So that's an example of a nodular melanoma, a little bit over a millimetre thick, but he's doing fine. I've just moved back because of the feedback, so if I'm getting some of the dates wrong, that's because I'm back here. Now this is a young lady, she's only 29, and she's being referred by another doctor for this lesion on her arm. She has an interesting history, and we'll talk about her later in the family history. She's a twin, and her father died of melanoma a week before she was born. So this lesion, my prediction on SCARD was that it was a nevus, but I did it for the purpose of excluding melanoma. So looking at that, what do you think about the morphology of that lesion? Is that something you would regard as a normal nevus, or something that you'd expect to see, or something unusual? Yeah, it's not what you normally would see with a nevus. It's the dermatoscopy is unusual. See the square shape? Geometric cutaneous melanoma sign. See that angulated square shape in the lower half of the lesion? We don't know why this happens with some melanomas, but it does. And this was a nodular melanoma in a young person with a Breslow thickness of 1.4 millimetres, a 29-year-old. This is a person with multiple nevi, a couple of hundred nevi. And so this was in amongst all of those, but the geometric cutaneous melanoma sign is something worth noting there. She's fine. I've been looking after these girls from 2009 through to the current time, and they've had quite a few melanomas, but she's fine. So this is a man, he's 85. He brought this to my attention. I predicted a invasive melanoma, a thick invasive melanoma, and I did it for the purpose of excluding melanoma. And at this stage of my SCARD reporting, we'd introduced where you actually put the percentage likelihood of melanoma on the SCARD database when you entered the lesion. And I gave this a 20% chance of being a melanoma. I don't know what else I thought it was going to be, but I gave it a 20% chance of being a melanoma. And did an excisional biopsy, and it's come back as a nodular melanoma with a Breslow thickness of 4.6 millimetres, and he had a right inguinal lymph node metastasis in 2014. So that was after an interval of 2 years. So he died of other things. So the adverse event was the metastasis, not melanoma-specific death. So a lot of people actually get a melanoma. If they're old, it metastasizes, but they die of something else, not from the melanoma. And non-melanoma specific death in 2021. So he survived quite a long time. Now this man is 58. And he's come in for a 6-monthly skin check 6 months after his first melanoma was diagnosed as a lentigo maligna on the side of his nose. So because he'd had that melanoma, he was being seen every 6 months, because when you've had a melanoma, the relative risk of another one is 10 times higher. So anyone over a relative risk of 5, we see every 6 months. So he was coming in every 6 months. And he came in and he had his skin check, and the skin check, as I do it, starts with the patient sitting up, and I'm at the front, they go around the back, then they lie down, and I start at the top and go down on the front part of their body, then roll them each quadrant like a pig on a spit until they've been 360 degrees. So when I put him face down, and I came across this, I said, "How long's that been there?" He said, "About 6 weeks." I says, "Why didn't you tell me about it when I said, have you got anything new?" He said, "I wanted to see if you'd find it." And I did. Isn't it beautiful? Like that rich blue colour. Like when you see that sort of colour, you'll only see that in non-polarised mode, because polarising filters degrade the colour. They give you the very important polarising specific white lines, but they degrade the true colours. So I examined by default with polarised, because you can go a bit faster, you don't have to use fluid. but I always examine any lesion of concern with polarised and non-polarised. Because grey, for example, is one of the most sensitive clues, but it's not all that well seen with polarised dermatoscopy. So to see the true greys and the true blues, you need unfiltered light, and that's non-polarised with fluid, contact fluid. So this was a nodular melanoma. There's no invasive component, and it's a Breslow thickness. I predicted melanoma again, and I said certainty of melanoma 100%. I had no doubt this could not be anything else other than a melanoma as far as I was concerned. Had a Breslow thickness of 0.8. Now that was 2012, and he's fine currently. I still see him every 6 months. He's had more melanomas, but that, when you diagnose a nodular melanoma less than a Breslow of 1 millimetre, the patient has a very, very good prognosis. Now this lady, and those of you who were here yesterday, you've seen this image. She came in with something on her hand, and she's 63 when she presented, and she's got something on her hand which was nothing. I finally excised it last year, but it was nothing, she just didn't like it. But I did a skin examination which involved my patients wear their underwear, but I retract the underwear and check under it. Here, when I retracted the bra strap, this lesion was under the bra strap. She was not aware of it. I'd never seen her before, but I said on SCARD, Spitz nevus, which is crazy because she's too old, right? But that's what it looked like to me. And I had a certainty of melanoma of 10%. I said exclude melanoma. That was my previous, the purpose of the procedure, but I only had 10%. But I was thinking Spitz nevus. And it came back as a nodular melanoma, Breslow 0.9. It actually came back as a Spitz nevus from David Whedon. Who's heard of David Whedon? #1 dermatopathologist probably in the world at that time. It came back as Spitz nevus, and then he rang me up the next day. He said, sorry, I've had to think about this. This is not a Spitz nevus. But because I had said query Spitz nevus, that has influenced him in his reporting. And as you know, Spitz nevus can be difficult to differentiate between that and a melanoma, a nodular melanoma or spitzoid melanoma. But when he went back and looked at it, he was quite sure it was a melanoma. And of course, at 63, Spitz nevus is very, very unlikely. And this lady likewise is fine, because this was less than a millimetre thick. She's fine. Now this young lady, she's 35, she's come in with this lesion because it's bleeding. She had had a well woman check here in the United Kingdom a month before she came to Australia. She had to have a well woman check, and they hadn't even commented on this lesion. I don't know if the person doing the well woman check even would own a dermatoscope back in 2013. But this is the lesion. It was bleeding. So that was the dermatoscopy. You can see on the left the beautiful polarising specific white lines. And you can see on the right, which is unusual, and that part at the bottom there, you can see non-polarising specific white lines correlating with the polarising specific white lines. That's incredibly unusual. But that's and I said on SCARD, melanoma invasive, greater than a millimetre, exclude melanoma, and certainty 100%. I had no doubt that could be anything else. Now, when you see any sort of reticular lines, even if they're white reticular lines, that rules out BCC and anything else and makes it specific for melanoma if it's malignant. Now, it came back nodular melanoma. Again, it looks like a superficial spreading melanoma because it's broad, but there's no in situ component. That's a true nodular melanoma, which has just got a slightly different morphology. So it's a histological diagnosis, nodular melanoma. You can't make the diagnosis clinically. And she had metastasis in 2016, so it's 3 years later. She had metastasis to the axillary lymph node and to the breast tissue. This is a distant organ metastasis. Now, this lady runs marathons. She is into being very healthy lifestyle, and she has declined any adjunctive therapy, no checkpoint inhibitors, and she's doing fine. 10 years after her distant organ metastasis, no further metastatic disease. That was excised, that metastasis, no further metastatic disease. Melanoma is unpredictable, right? you can't tell if someone's going to die from melanoma just because it's metastasized. Even without treatment, some people do extremely well. And I guess that's maybe a function of our immune systems, that they can do very well. And then very thin melanomas can kill the patient, as we saw with the SCARD study earlier. So she's doing fine. And I guess if she gets metastases now, she's got the checkpoint inhibitors. So that's 50% of people with distant metastases go into a permanent remission with checkpoint inhibitors. So people like this, it's not like it used to be. It used to be a death sentence when people had metastatic disease, unless they were like her and came into spontaneous remission. But now there is a much better hope. But she's had an adverse event, but she's doing fine. Current survival. Now, my data, as far as the identifying individual, right, for melanomas. Now, I might have to put my glasses on here, but in all of my series of melanomas with data of identifying individual, we identified 92%, and the patient or relative identified 8%. Now, over on the top right, with thin invasive melanomas, the patients identified a little bit more, 12%. With thick invasive melanomas, the identifying individual was the patient or relative for 43%, nearly half. So once a melanoma becomes invasive, it's more likely to be reported by the patient. As far as the melanomas with adverse outcomes, the patient was identifying individual at 80%. 80%. So the dangerous melanomas are more commonly identified by the patient or relative, and the less dangerous ones are picked up by us being clever, picking up in situ and thin invasive melanomas. When a patient reports a lesion to you and it turns out to be a melanoma, it's more likely to have an adverse outcome. Always listen to your patients diligently and take seriously what they report. So here we have a young man. He's 32. Got a family history. His brother had a melanoma on the sole of the foot, and he presents with this lesion. What do you think? Well, I said dermatofibroma, exclude melanoma, and I put certainty of melanoma 30%. This has come up very quickly. He said 2 weeks, and I suspected that was longer than that, but that's probably when his wife noticed it. So what do you think? What do you think it's going to be? Stephen, what do you think?
I doubt that it's come up as quickly as 2 weeks. But I don't know, I used to see a lot of insect bites and pimples.
Insect bites and pimples? Yep. Anyone else? When the patient says 2 weeks, that's how long the patient's noticed it. It might have been there a bit longer. Okay, it was a dermatofibroma. And the thing is, I'm telling you this now because not all the things I've put here are melanomas, right? I've thrown some other stuff in to make it a bit more interesting. So you can't assume just because I put it up there it's going to be a melanoma, right? But I gave this a 30% chance of being a melanoma. And I said dermatofibroma, but I gave it a 30% chance of being a melanoma. So it's interesting because, for example, with my melanomas, I can tell you now, because I use the SCARD database, that 10% of my melanomas, I predicted they'd be a BCC. And for a lot of those, I didn't even put a percentage likelihood of greater than 0% of being a melanoma. Okay, so that's in my practice, and it's similar with the SCARD database. When we looked at that, about 10% of the melanomas on the database were predicted to be BCCs. In this case, it was a dermatofibroma, and that was great for the patient. So, female age 70. So this is a lesion which is mainly non-pigmented. I said BCC. I did it to exclude non-melanoma skin cancer. My certainty of melanoma was 0%. What do you think? The vessels aren't right for a BCC. They're more like a SCC in situ. So that was a superficial spreading melanoma with a Breslow thickness of 1.1 millimetres. And this is the beauty of scars. You can learn a lot because you can see your thought process when you encounter this lesion. Okay, and you can learn a lot from that. This is one of the examples of one of the melanomas that I predicted BCC and didn't even consider melanoma as a differential diagnosis. And she's doing fine. A thin melanoma, around 1 millimetre, you know, around 90%, 20-year disease-free prognosis, and she's doing fine.
Excuse me. Applying your rule from before, isn't there the negative network in that says it's not
A negative network in this one. Negative network is when you've got pigmentation with hypopigmented skin separating the pigmentation. There's no pigmentation apart from to one side. So I wouldn't call that negative network.
the white particular pattern?
Well, what you're seeing there is vessels with some whiter area in between them, but it's not a pigmented lesion. So you wouldn't call that inverse network. But I see what you mean, but I don't think that's a clue, but I'll have to think about that. Now, if you're putting that through prediction without pigment, first of all, it's not ulcerated, so you're looking for white lines. And there are white areas there, but there's no white lines, okay? And then if it's a raised lesion, you're looking for the keratin clues for SCC. There's no keratin clues there, and it's not raised, it's flat. Well, it's slightly raised, but then you're looking for a benign vessel pattern, and there's none of the 4 benign vessel patterns there, so you've got to cut it out because it's a lesion of concern. And I was thinking BCC with unusual vessels, but it was a melanoma. Now, this one here is a female aged 61. She has a family history of her brother having had multiple melanomas and her father dying from melanoma at age 72. And I've identified this lesion. You can see this little lesion here, very tiny. What do you think of the dermatoscopy? Okay, well,
Cluster of dotted vessels.
yes. I couldn't give it a confident benign diagnosis. There's no nevus that looks like that. There's no seborrheic keratosis that looks like that. There's not a dermatofibroma, hemangioma, or sebaceous hyperplasia. So it doesn't qualify for any of the 5 common variety of lesions. So I had to cut it out. And this is with scarred. I can look back at my thought process, and I was thinking melanoma in situ exclude non-melanoma skin cancer. Right? I did it to exclude, I preferred non-melanoma skin cancer, but I did give it a certainty of melanoma of 20%. So you can see some scrambled thinking. I didn't know what it was, so I'm covering all the bases. And this is a superficial spreading melanoma with a Breslow thickness of 0.5 of a millimetre, so it's a thin melanoma. Yep.
Cliff, could you say a few words about scarred? Because people might not know.
So the Skin Cancer Audit Research Database is a database that anyone can use free. You just have to Google SCARD, or Skin Cancer Audit Research Database. And when you encounter a lesion of concern, you enter that lesion. So you have to put the patient's demographics in, and then certain things about that lesion. And you can do it when you encounter the lesion even before you cut it out. And it goes in as a yellow entry on the spreadsheet, and it stays yellow until you do something with it. When the patient comes back to get it cut out, you just hit proceed, and it becomes an orange entry. Now you've put in at this stage the patient's details, you put the location of the lesion, you put your predicted provisional diagnosis, why you're doing the procedure to exclude melanoma or to exclude non-melanoma skin cancer, or not applicable if it's a cosmetic thing, right? And you put in the percentage likelihood that it will be a melanoma, no matter what it is. So it would be 0 for a BCC. When the result comes back, you enter the histological diagnosis and whether the margins are clear. And then it turns either red if it requires further treatment, or green if the treatment is completed. So it tracks your lesion right through to completion, And until it becomes green, it still hasn't been completed. So nothing falls off the back of the truck. You don't lose specimens to follow up. And you can go back and analyse your data in any way you want it. And this is how we, for example, calculate how many things we cut out to find one melanoma, whether it's 30 or whether it's 3. The percentage of things that we suspect to be BCC that are BCC. Your diagnostic accuracy metrics, you can track them and you compare yourself to 1.5 million lesions that are in the pool. Okay, so it's a really good way of tracking your performance and tracking your lesions, and it's free, totally free.
Was this lesion picked up by yourself, or was it history of patient gave any history of any concern about this lesion?
For this particular lesion, she came in for a general skin check. So in Australia, lots of people have a general skin check maybe once a year. They have 15 minutes and we examine them from top to bottom, inside their mouth, eyes, everywhere. And this was just part of that. When she rolled over, I saw this little thing, she wasn't aware of it, and I cut it out. Now, this is a really important case, right? Because this lesion metastasized. This tiny little speck you can see there was cut out and then re-excised as appropriate for a melanoma. And it was done in 2017, and in 2021, it metastasized to her axillary lymph nodes. And that metastasis was excised, and she is now on checkpoint inhibitors, and she's doing fine. So that's an example of someone with a thin melanoma that metastasized that is doing fine on the modern therapies. It's still early days, but so far she's doing fine. Now, I make the point here that her father died from melanoma. Now, I'm just thinking, this is a thin melanoma, you don't expect a bad outcome for this, right? But maybe the fact that her father died from melanoma, maybe there's a biological, susceptibility to melanoma genetically for her.
Would you mind showing the dermatoscopic image again, please?
Sorry?
Could you show the dermatoscopic image again?
Yeah, sure.
There was a small, it's almost like a comedo-like opening over there. So
Yeah, it could be. But one comedo-like opening doesn't negate the fact that you can't give that a confident specific benign diagnosis, does it? You can't tell me that's a STEB K because of one comedo-like opening, because the borders aren't right for a STEB K. So you don't want to be missiled by one clue to something benign when the whole thing screams that it's not a seborrheic keratosis.
Sorry, one of the very early slides you showed was a second scan from the melanoma, which looked like a dark sort of. I don't know what the scan was. There was a melanoma and then a darker scan picture, which showed a more extensive. It was ultraviolet, was it?
Oh, ultraviolet, I don't use that.
Is that any use?
Yeah, Nisha will tell you all about that. She knows all about that. I don't use that at all. Sorry, I'm very basic and simple in my approach. So this is an important case, and this is another important case. My patient is 2012. This happened in 2017, and every time I've been seeing him, like I do with everyone, I say, do you have anything in the genital area that you're concerned about? Because I don't look there routinely, but if there's something you want me to check, I will. And he said, no, because in 2011, before he came to me, he'd shown this to someone and they told him it was nothing. But obviously it didn't look like that in 2011. But because of that, he just kept saying no. And then finally it started bleeding and he showed it to me. That's a mucosal melanoma of the glands, which is spread onto the shaft. And I obviously predicted that as a melanoma. It couldn't be anything else. And his ultrasound of his lymph nodes was clear. It's at 1.15 Breslow. And it metastasized 2 years later. He's on checkpoint inhibitors and he's doing fine. So it's, we don't routinely look at the genitalia, or I don't. But I do routinely ask about it, but I ask about it more and more now because of this. Because this was a tragedy that I didn't know about that until it presented bleeding. He's doing fine at the moment. Now this guy had a perfectly good ear until a magpie attacked him on Christmas Day 2018. And the magpie came in and took a piece of his ear and drew blood, and it never healed. And this came up within 5 months. And he was being treated at the hospital with antibiotics and all sorts of things. And there it is. And obviously, no one had thought about malignancy. They all thought granulomatous infection or reaction. But when it presented to me, it was easy because it was ulcerated and it wasn't healing. So I said, I thought SCC with the history. Certainly in melanoma, I had 0%. And I can't deny that because you can't change what you put in scarred. And it came back as a melanoma with a breast thickness of 9.5 millimetres. Sentinel lymph node biopsy negative. It was 3 centimetres in diameter and 1 centimetre thick melanoma. And sentinel lymph node was negative in 2019, but within 4 months he had clinical lymph node metastases and spread to his parotid glands. And he's on immunotherapy and currently surviving without any further recurrence.
Is there any evidence that trauma can be the precipitating factor developing a skin cancer? Because it's very common. I see people with skin cancer who claim that they've had bumped their head on the cupboard or something beforehand.
Yeah, well, this melanoma was caused by a magpie strike. And I can tell you that because you think of the odds. What are your odds of being hit by a magpie from 30,000 feet in one ear, right?
Our magpies are very
And what's the odds of a perfectly good ear having a melanoma arise at the magpie strike site within 5 months?
So also then, can kitchen cupboards cause skin cancer?
Undoubtedly. Yeah, I don't know. It's a good question, and I can't give you the answer to that. But I think in this case, just the mathematical odds tell you that the magpie caused that melanoma. And you can't prove I'm wrong. Now, how am I going for time?
You've got about 5 minutes if you want questions.
5 minutes. Okay.
5 minutes.
What do you reckon that is? What do you think it is? We've got to speed up.
Adnexal tumour?
Adnexal tumour, okay.
Good guess.
So I put BCC, certainty of melanoma 0%. Came back as a nodular melanoma, 2.6 millimetres breast line. Hey, it doesn't matter whether you get the diagnosis right, it matters that you get the decision right.
Can you repeat what are the benign patterns of the vessels?
The benign patterns of the vessels, clots only, which is a hemangioma, clots only. It's all, it's centred, which is either a seborrheic keratosis or a congenital nevus, centred pattern. And it's all in my book, by the way, which is available out there. It's all in my book. And then a serpiginous pattern, which is a clear canthoma, and a reticular pattern, which is sun-damaged skin, and telangiectasia. The normal vessels of the dermal plexus showing through on sun-damaged skin. So it's clots only, centred, serpiginous, and reticular. They're the 4 benign patterns. Now, lots of other things will be benign, but if it's a lesion of concern, because you can't give a confident diagnosis or the patient's worried about it, and it hasn't got ulcerations and it hasn't got white clues, it's got to have one of those 4 benign vessel patterns or you cut it out.
Got to be kidding me. Okay, everybody, looks like we're going to go. No, it's gone off. So that
No, it's turned off, so there's no, the persons of smoking in the toilets has been caught.
I'm not going to run.
No. Okay. So this is just to show the exclusion options for melanomas. In 822 melanoma in situ with data, 94% of mine I said exclude melanoma, and 6% I said exclude non-melanoma skin cancer. Of the thin invasive melanomas, a number that were exclude non-melanoma skin cancer increased to 10%. But in the thick invasive melanomas, I said exclude non-melanoma skin cancer for 1/3 of them. Right? This is just to show that the thought process of things that turn out to be melanomas, of the thick ones, are more likely to predict a non-melanoma skin cancer rather than a melanoma. Okay, it's interesting because the thick ones are often amelanotic because amelanotic things get thicker before they get diagnosed. And just pointing out here, the ones with adverse outcomes, the amelanotic ones make up a proportion, nodular ones make up the greatest proportion. And the ones that are green are things where I said exclude non-melanotic skin cancer. Okay? So for those ones that are green that were melanomas that had adverse outcomes, 3, I predicted non-melanoma skin cancer. And 2 of those were amelanotic. That's the guy with the magpie. And the percentage that I thought they were melanoma is written in the bottom. So that one on the left, that lady with the thin invasive melanoma, I said 0% for melanoma. I said 20% for the one that was half a millimetre thick, and I said 0% for the one on the ear. So these things that show that I'm very prone to making the errors, I can't hide because I record them on SCARD, which is fantastic. Now, this one here, I'll move past. It's we're running out of time. It's a melanoma, which I thought was a melanoma, obviously, and it had a Breslow of 2.4, and it caused, the patient died of other things, didn't die of that melanoma, but she was an old patient. Now, this is one that presented in 2020. I said certainty of melanoma 10%. I thought it was a nevus. You can judge for yourself what you think, but I couldn't leave it there because I couldn't give it a confident diagnosis of nevus. And it was a nodular melanoma, Breslow 2 millimetres, and he's doing fine at the moment. This is just showing with the green, the disease-free survival of thin nodular melanomas. So these are all my nodular melanomas, 16 of them. And you see the thin ones, the patient's doing fine. This is why it's important to diagnose nodular melanomas, preferably before they're a millimetre thick. This lesion here, I said SCC, and I put certainty of melanoma 0%. And it came back as a melanoma, desmoplastic. Breslow thickness 7 millimetres. Now, who's had a desmoplastic melanoma that they've diagnosed? They look like scars. This one was ulcerated, so it was definitely going to get cut out. But lesions like that aren't ulcerated, they're often regarded as scars. This one had signs of SCC. They can be very, very tricky to diagnose. They're often very thick, but because a big part of the thickness is scar fibrous tissue, like desmoplastic, they don't have such a high mortality Breslow for Breslow. Because the thickness is not all cellular melanoma, a lot of it is scar tissue. Non-melanoma death. Now this is another one. This is a thin melanoma. It's an invasive melanoma. I predicted that. I said certainty of melanoma 40%. And this one was only 0.9. It's thin, and it has had lymph node metastasis in 2022. That's after 2 years, and now cerebral metastases from a thin melanoma, which wasn't a really remarkable lesion, really just under the ear there. He's on checkpoint inhibitors, and he's doing fine. And now this one, age 41, you can see a scar from a previous melanoma up there. Okay, she's only young. Provisional diagnosis on SCARD. Now I'm getting pretty good at picking amelanotic melanomas now because I've had a few, right? So I've said here, melanoma invasive greater than a millimetre, exclude melanoma, and I've given it a 30% chance of being a melanoma. What do you reckon? BCC, okay? So, can't win. But the important thing is not the diagnosis, the decision. And it was cut out for all the right regions, polarising specific white lines, and I predicted BCC, I predicted melanoma, and it was a BCC. So it works both ways. This is a what? Pigmented invasive SCC. And of course, I thought melanoma for sure, 100%. Got it completely wrong. Pigmented SCC, extremely rare. That's what it is. This is on the scalp. Predicted seborrheic keratosis, gave a certainty of melanoma 20%. It's a melanoma superficial spreading, Breslow 1.1, sentinel lymph node biopsy positive. Right, so Again, cut out for the right reasons, the right decision, but not quite spot on with the diagnosis. Immunotherapy and its early days. So this just goes to show, again, all of the patients, the ones that were amelanotic, the ones that died, all nodular melanomas. Now this guy here, this came up in 6 weeks. 6 weeks, back in 2009. I knew it came up in 6 weeks because he'd seen my colleague for a skin check 6 weeks before. There was nothing there, and he said it came up just after the skin check. So within 6 weeks, it's a melanoma, nodular, Breslow thickness of 5 millimetres in 6 weeks, a millimetre a week. You can't predict melanomas. You can't. And he died in 2013. I'm showing you the ones that died. Long-term patient. That's what he had in the first period of time, 2011, 2013. And from 2013 to November, he's had 5 invasive melanomas, 2 nodular, 4 in situ melanomas. That's one of his nodular melanomas. And I predicted that to be a BCC, instead of exclude non-melanoma skin cancer. 1.25 Breslow, amelanotic melanoma. That's his second melanoma. The worst melanomas don't look like melanomas. That looks nothing like a melanoma to me. So I predicted IEC, but in retrospect, I was seeing him every 3 months, and that came up between skin checks. So IECs don't grow that fast. That was a nodular melanoma, 20 mitoses, and he died from melanoma a few years later. So of my pigmented melanomas, 92% are pigmented, 5% are hypomelanotic, 3% are amelanotic. So here we have invasive versus melanotic status. The all melanomas, only a small percentage are invasive. With the hypomelanotic melanomas, half are invasive and 8% are thick invasive. Of the amelanotic melanomas, more than half are invasive and a quarter are thick invasive. So melanotic status, as they get less melanotic, they're more likely to be thick. So here's a case of a melanoma which presented in 2015, predicted as a melanoma, and nodular melanoma 4.85, and she died from melanoma. So they're the ones that died, the 3. They're the melanomas that killed them, and that's the time to death for each of those people. So this is big game hunting. We shoot a lot of rabbits and foxes for each bit of big game we get, but the big game is important if you can get it before it's metastasized. Thank you very much.
Thank you, Cliff. Superb presentation and a wonderful sharing of knowledge. We're running a bit behind time. Is there any burning question? We'll have a panel at the end of the day with all the speakers.
Yeah,
all good. So, Cliff, would you like to come down here and introduce our next wonderful speaker from Turkey? Cliff,
yes,
Cliff's
so
honoured for you to do that. Yeah.
Great pleasure to introduce Nisa Akay from Turkey. I've known her since 2015, and we've published quite a few things together. And she is, as far as I'm concerned, and maybe with the exception of the dermatologists that are here, the best dermatologist in the world. And you know, for Turkey, you wouldn't expect to get a lot of melanomas in a place like Turkey. She's giving me things for the next edition of my book that you wouldn't believe from her database. She gets a huge amount of stuff because she draws from the whole of Turkey. She's very respected in Turkey, and it's a great pleasure to have you here, Nisa. Thank you.
Thank you for the nice presentation, Cliff. I'm really very honored, and thank you so much. And thank you so much for the invitation. It's a great pleasure for me to be here with you. I tried to show my cases to you. Pediatric dermatoscopy is really very challenging because the lesions look really very weird. When we see the lesions, we always consider at first glance a melanoma, but the result is generally benign because melanoma, especially before puberty, is extremely rare, extremely rare. Now let's see the cases, and I will ask your opinion, and I try to be interactive during the presentation. And if you also talk with me, I will be really very grateful. Now, this is a 10-year-old girl, and there's a lesion on the nose, and history 5 months. 10-year-old girl, and skin type 2. She has blue eyes. And here is a dermatoscopy. What do you consider with these findings? There is not a family history of non-melanoma skin cancers. And what's your first impression on this lesion? Is it benign or malignant? Would you like to do a biopsy in this case? For sure. Because we have a nodular lesion, the background is white structureless, and we have vessels. And vessels are clustered, coiled vessels, branched vessels, serpentine vessels. So we need to take a biopsy. And what's your provisional diagnosis here? Who says this is a basal cell carcinoma? And who says this is a squamous cell carcinoma? Or who says this is a melanoma?
It'll be benign because she's young.
But it's melanoma? Okay. If this is an adult patient, what do you consider here? Basal cell carcinoma? SCC? Perfect. And so we have also a structureless yellow, right? This reflects that this is a keratinized tumor, probably, most probably in the squamous cell carcinoma spectrum. But also we have findings of basal cell carcinoma, right? So histopathology is here, basosquamous carcinoma, a mixture, basal cell carcinoma and squamous cell carcinoma. Is it normal for this age? No, it's not normal. Let's have a look at the other parts of the face. There's 2 more suspicious lesions I marked. And let's have a look at the dermatoscopy. What do you consider here? This time we have light brown structureless background, and we have coiled vessels, right? So where do we see coiled vessels? Bowen's or intraepidermal carcinoma, right? So we need to take a biopsy for this lesion as well. And histopathology is Bowen's disease here. And let's have a look at this one. This time we have pink structureless and central ulceration, and there's blood crusts on the ulcer. So this should be a high-risk basal cell carcinoma, or again, squamous cell carcinoma, right? So biopsy confirmed that this is a micro-invasive SCC. So we have 1 Bowen's, 1 SCC, and 1 basosquamous carcinoma. The patient is 10 years old. So what should we do here? There should be something genetic here, right? Because this is not normal. The patient doesn't have any family history of these syndromes, but there may be new spontaneous mutations. So we have to ask for genetic consultation here, and we did. And the patient is diagnosed with XPE. This is a very rare variant of xeroderma pigmentosum. Just 30 cases have been reported so far. The main difference of this variant from the other xeroderma pigmentosum is the lack of sunburn and freckles. And generally, carcinomas, non-melanoma skin cancers develop at the age of 20. So we don't have freckles here, but carcinomas develop at the age of 10. But the main point is we need to ask always for genetic consultation in cases like this, okay? Now another case. This is a 2-year-old girl. There is a nodular lesion on the anterior aspect of the leg. And this is 3 months later. And this is 6 months later. It's rapidly growing, right? A pink nodular lesion, and it's growing. Actually, I would like to excise the lesion at first visit, but the parents do not want the lesion to be removed. So we follow up in a very short period of time, in every 3 months. So let's have a look at the dermatoscopy. You see the change. What's your provisional diagnosis here? What can be this lesion? It's rapidly growing and changing, and the patient is 2-year-old. Spits. Our main differential diagnosis here should be spits, non-pigmented spits, right? Because we have pink nodular structureless lesion, we have white lines. The pattern at first visit was brown clots and white lines. This is a very common feature of Spitz nevus, and it's growing and changing, but in 6 months, a pink nodular lesion. So I recommend excision, and the patients this time accept excision. And histopathology was here atypical Spitz tumor. This is a benign thing, but histopathologically, the pathologist cannot decide what it is, a melanoma or a Spitz nevus, because it combines features of both spectrum. But generally, these lesions are benign. The approach here should be re-excision with 5 millimeter safe surgical margins without performing a sentinel lymph node biopsy. Because if we perform a sentinel lymph node biopsy, the false positivity is very high. Okay? So for not to make a confusion here, just re-excise the lesion with 5 millimeters without doing sentinel lymph node biopsy. Now, here's an approach for the spitzoid-looking lesions during pediatric period. If the lesion is looking symmetric, then no need to excise this. And age factor is very important. If the patient is older than 12 years of age, we should excise every spitzoid-looking lesion, even they are symmetric. But during pediatric period, before puberty, if it is symmetric, and if it is not nodular, you can follow it up. Because we know that spitzoid lesions tend to regress over time, totally regress. For example, if I follow up that pink nodular lesion, there is a probability of being total regression in that lesion as well. But we shouldn't take the risk because it's a pink nodular lesion and we have to excise it. Every nodular lesion should be excised. But if it is flat and symmetric, you can follow them up. And yeah, this is the whole algorithm. Now let's have a look at another case.
What's the mean regression time you
Lost. It will be lost totally, completely.
and how many years roughly?
We don't know the exact time. Maybe it takes several years, maybe 1 or 2 years, but we don't know the exact time. IDEA is now doing a study on this subject. We will see the result. Yeah. Okay. Again, a young patient and 7-year-old both. There is a nodular lesion on the arm, forearm, and there's dermatoscopy. Another dermatologist examined this lesion, and he thought that this is a wart. Do you think that this is a wart, viral wart? Is there a possibility? No, this is not a wart. This is a nodular lesion, and we are not sure what it is, right? So if you are not sure about a nodular lesion, we have to excise it, right? And we do it. And the parents show me the photos. The first photo is 1 year ago, and now you see the change? Right. Unfortunately, this is a, okay. Unfortunately, this is a melanoma. And you see the histopathology, and even there is lymphovascular invasion here. And breast of thickness is 3.2 millimeter, ulcer positive, a number of mitosis is 10, lymphovascular invasion is positive, sentinel lymph node biopsy is also positive. So melanoma is rare during childhood, but it can happen. So we should excise every nodular lesions, even they are looking quite symmetric. For example, this is a 4-year-old girl, and the parents told me that it's a congenital and grew and changed in the last 3 months and started bleeding. And here's the dermatoscopy. It's very chaotic, right? Yeah, it looks like a melanoma. We have white lines, we have thick reticular lines, we have pink structureless areas. This looks actually terrible. And if we have to say a breast of thickness, this is definitely bigger than 1 millimeter, right? But fortunately, histopathology was consistent with Spitz nevus. And here you see the symmetry. There's no chaos in the histopathologic sections. And P16 positivity is a marker for Spitz nevus. In melanoma, it's heterogeneous positive, but in Spitz nevus, it's homogeneous. Okay? So this is Spitz nevus, good for the patient. Now, I'm gonna show you some cases. They are all red or Spitz nevus or melanoma, and I will ask you which one is the melanoma. What will you do if you were the doctor of these lesions? Let's have a look at the age factor because it's very important, right? So the first patient is 44-year-old. What's that? Is it a melanoma? Yeah. The second patient is 35-year-old. Would you excise or follow up? Excise. Okay. That was read news. Okay. And how about the patient who is 31-year-old? Is it a melanoma or a Spitz nevus? It's a melanoma. And how about 50-year-old patients? It's a melanoma. And how about 7-year-old? It's a Spitz nevus. But we excise it because it looks chaotic, right? Mm-hmm. And how about 7-year-old? There's no chaos. We have circumferential radial lines. So you can follow this up, right? But we excise it because the parents didn't want to come to the follow-up visits. It was read nevus. And how about the other one? Again read. And how about the other one? Again read. So age factor is really very important, right? And how about 21? It's a melanoma. It's a spitzoid melanoma. So, but remember the algorithm, yeah? If you see a spitzoid looking like lesion after puberty, we have to excise it to exclude melanoma. This is the algorithm. So all these cases fit well with the algorithm, right? Because all lesions after puberty are generally melanoma here. And 14-year-old is a read nevus, and 43-year-old is a spitzoid melanoma. So here's a comparison of two cases, 21-year-old and 13-year-old. The first one is a Spitz nevus, the second one was the melanoma. So you see the resemblance, but age factor is very important. Now, this is a very interesting case because I would like to show you how sometimes it's very difficult to diagnose a lesion. This lesion was consulted at 3 dermatology departments, and let's see what they say. A pink nodular lesion, and the patient is 8-year-old girl. According to the algorithm, this lesion should be excised from the first visit because it's a pink nodular lesion, right? But my colleague chose to follow up the lesion. And in 6 months, it's growing, still looking like a Spitz nevus, but according to the algorithm, we should excise this. But at this point, she excised it. And report is Turkish, but I translate it. and 2.A. And this was the first pathology report from the first institute. And you see the details of the report. And then she asked me what to do. And I told her that we have to re-evaluate the lesion, another pathologist, because she's 8-year-old and it doesn't look like a very chaotic lesion, just a pink nodular lesion. And another center evaluated, and they detected a dilation in this chromosome. This is very quite typical for Spitz melanoma. In Spitz nevus, there is no dilation in this spectrum, okay? And here you see the findings that are consistent with melanoma. ALK positivity is a very important immunohistochemical marker to show that the tumor will show aggressive behavior. And another center, the third center, again, it's melanoma. And again, I summarized the findings consistent with melanoma here. This is very important. When there's absence of maturation, when there's superficial erosion and crusting, when it's asymmetric lesion, when there is mitosis in the deeper part of the dermis, not superficial part, because in Spitz nevus, we commonly observe mitotic figures, but if it is located in the deeper parts, this is consistent with melanoma. And again, P16 negativity, ALK positivity, and loss of P16 expression in the fish analysis is also very important findings for melanoma. So PET-CT was performed, and there was some lymph nodes looking atypical. The lesion was excised, and lymph node biopsy showed that it's metastatic. Unfortunately, she has also a metastatic lymph node, and PD-1 inhibitor therapy is planned for the patient. The patient is so young, but I just want to show you how it's very difficult sometimes to give a diagnosis of melanoma. Now I'm going to show you another very interesting case. The patient is a 12-year-old male. He had an injury from the abdominal region, and during exploration by abdominal ultrasonography and CT, multiple metastatic liver lesions were detected incidentally in the patient. And biopsy from the liver showed that it's metastatic melanoma, by chance. And they asked me to examine the patient because the oncologist would like to learn the primary of this metastatic melanomas. And during examination, some palpable masses came to my hand on the scalp, and I shaved the hair, and you see there's a congenital nevus there. So in the scalp, when it is larger than 9 centimeters, it's accepted that it's a large congenital nevus. And we know that there's always a potential of metastasis if you have a large congenital nevus, giant congenital nevus. And generally, the metastases are from neurocutaneous melanosis, not from the primary congenital nevus. So we perform MRI examination, and you see the lesion there in the parenchymal region, and it's invading the bone as well. So probably the reason for this metastasis is neurocutaneous melanosis, and the patient died 6 months later. Even though he was BRAF positive, the therapy was not effective because he has a lot of metastasis, and the patient was just 15 years old. Yeah. And here's the dermatoscopy of the congenital nevus. And now, another interesting case, 9-year-old. And this is the back of the patient. History 2 years, and it's growing and starts bleeding in the last months. And here's the dermatoscopy. We have several dermatoscopic photos The first one is with photo finder. The second one is polarized DL5 image. And here, Dermalite photo images, polarized and non-polarized mode. And here, this time, Casio dermatoscopy. We have polarized, non-polarized, and 405 nanometer dermatoscopy. And this is UV dermatoscopy. But what's your provisional diagnosis here with all these images? Any idea? Forget about the age. If you see a lesion like this, what do you consider? Excision, yes. Because there's a central ulceration. Every ulcerated lesion should be excised to exclude malignancy. What can be this one? Yeah. Who votes for basal cell carcinoma? Yeah. 3 person. Sepke? No one. What are those white structures in the polarized mode? Megalobules are, what can they be? Yeah, good differential. But megalobules are not visible with UV dermatoscopy. Sub-UV mode, it's okay, but in UV dermatoscopy, they're not very visible. These white structures, when they are visible in UV dermatoscopy, they are keratin cysts, okay? So where do we see keratin cysts? In seborrheic keratosis, right? Sometimes, of course, in basal cell carcinoma, but most commonly we observe keratin cysts in seborrheic keratosis. Let's go back. Oh. Okay. This is great. Yeah. You see? The peripheral gray clots look like basal cell carcinoma, right? We have big blue clots. It's generally observed in basal cell carcinoma, and this is non-polarized, and you see the ulceration and blood spots. So here, most likely diagnosis is basal cell carcinoma. Yeah. But these keratin cysts is a bit confusing, and let's see the histopathology. At first glance, it looks like a seborrheic keratosis, right? You see the keratin cysts here, keratin cyst, and elongated retorich looks like a reticular seborrheic keratosis. But with immunohistochemistry, especially with BEREP staining, you see the tumor islands here. So this is a collision of seborrheic keratosis and basal cell carcinoma. Yeah, this is a collision tumor. We have both seborrheic keratosis and basal cell carcinoma here. So the patient is 10-year-old. There's no family history of skin cancers, but we have a collision tumor. What should we do? Genetic, for sure. And this time, we detected a mutation in patch gene. So this patient is most likely to be a Gorlin syndrome. Yeah. Now he's under follow-up, and the other examinations are ongoing right now. This is a recent case. So it's very important to ask genetic consultation when you see tumor before puberty. Now let's go to nail. How about nail pigmentations in UK? Do you observe? Rare. Yeah. In Turkey, it's very common. We have nail matrix melanoma, nail matrix nevus. It's very common, and I'm going to show you a case. Okay, let's have a look at dermatoscopy. The patient is a 16-year-old girl, and there's a pigmented band on her left forefinger, which had been present for 5 months. And here's the dermatoscopy. The patient is just 16 years old, and we have longitudinal bands, and we call this pattern as, is there anyone who knows the pattern here? Triangular longitudinal melanonychia. This is a sign for melanoma in adult nail matrix melanoma. But for patients, for pediatric patients, it's very common, okay? So the patient is 16-year-old. According to the pediatrist, the patient is still in the pediatric age group, right? So in this patient, the best approach should be follow-up. But if the patient was older than 18-year-old, then we should take a biopsy to exclude melanoma because of these triangular longitudinal bands. The bands are larger here, but at the distal part, they are getting thinner, right? Like a triangle. And 3 months later, there's a great change, right? So we have to take a biopsy at this point. And there's a nail destruction as well here, splitting. This is a sign for melanoma. And here you see nail matrix dermatoscopy. There's highly vascularized area in the nail matrix. And histopathology showed that this is a melanoma in situ. So when there is rapid change, biopsy should be done. Again, a pediatric case again. The patient is 15-year-old, and this is the baseline photo. This was taken by the mom, and 6 months later, they came to me. You see the rapid change? Yeah, but it could happen during the pediatric period. It's okay. But let's see the dermatoscopy. What do you see here? Can someone explain me? We have here chaotic distribution of black dots. What is the meaning in histopathology? These structures can be phagocytoid spread because we have black dots and clots here, okay? Atypical melanocytes can come to stratum corneum, and that's why we see these structures. And when we have a look at the longitudinal bands, they are irregular in size. For example, there's a thick band and there's a thin band here, and the spaces between them are different. It's a chaotic lesion. Here is a close-up. And we have here, free edge dermatoscopy is also very important. Always look at here. In nail matrix nevus, this part is not chaotic. You just see a homogeneous brown or black structureless coloration. But have a look at this area. It looks highly chaotic, isn't it? Yeah. So we need to take a biopsy from this lesion, and histopathology was consistent with, again, melanoma in situ in this patient. So if free edge dermatoscopy is chaotic, and if there's a rapid change, especially after puberty, we should be really very careful and take a biopsy in these cases. Even the patients are at the pediatric spectrum. But we should be comfortable before the age of puberty, because the reported cases of melanoma before puberty is extremely rare, just 5 cases in the literature. And retrospectively, some authors again reanalyze the reported cases of melanoma before puberty, and they said that they are not melanoma, they are all nevus. So our threshold should be very high before puberty, but after puberty, regular follow-up is very important. When you see change, or when you see a chaotic arrangement of coloration in the distal nail, you should take a biopsy. Okay. Yeah. Okay. Let's see. These are all pediatric cases. Okay, maybe last one more case. Let's skip this one. Yeah. And this is my last case. 15-year-old male, history 6 months. This is on the shoulder and skin of color patient, skin type 5. What do you think it is? Here's a dermatoscopy. Any guess? BCC, but there's not an option for BCC here. Kaposi sarcoma, dermatofibroma, melanoma, hemangioma. Which one? Any of them, yeah, perfect. Any of them, yeah. But another clinical clue to you, it was firm on palpation. Firm on palpation. So, histopathologic diagnosis here is dermatofibroma, but no way, cellular dermatofibroma and hemosiderotic dermatofibroma. It's a mixture of both histopathologic findings, but the patient is died for this reason. What can be the reason for that? There was histopathology was evaluated several times, and it was cellular dermatofibroma. In the literature, there are some cases metastasized to the lung and lymph nodes and died because of cellular dermatofibroma. And in this patient, at first visit, the surgical borders were continuing with the tumor, and re-excision was performed. And then lymph nodes examination also showed, because they were palpable, and show that there's something wrong with the lymph nodes, and we need to request CT examination. And in thorax, there were multiple metastatic lesions in this case, and it's very interesting. Our histopathologists perform 2 mutations for this cellular dermatofibroma. When you detect these mutations, it shows that this dermatofibroma could be aggressive, and these mutations were positive in this patient. So if you get a result with cellular dermatofibroma, but surgical borders are continuing with the tumor, always perform re-enlargement of the tumor, because there's always a risk of metastasis in cellular dermatofibroma. This is an exceptional form of dermatofibroma. Cellular. Thank you.
Thank you very, very much for a wonderful presentation. A very tricky, difficult area of childhood cancer and all that goes with it. We're probably running short of time for questions, so we're going to move straight on and are welcoming Stephen Hayes, who many of you will know from the UK. Stephen's been your stalwart of melanoma skin cancer over 20, 30, 40 years, leading the way for general practice, early detection at the front line. And he's taught so many of you over this time. So it's wonderful, Stephen, to have you as part of the presentations today. And we're looking forward to your presentation. Now, I've just got to get the thing. That's it, and we just move the slide on for you, which should be good.
Can you hear me at the back without a microphone? Okay.
Yeah, you're up. We've got you up here, Stephen.
All right.
Okay. That's audio complex. Right, and you've got this one here. That's the big thing. You just press that, and that gives you across there.
Thank you very much.
And the big one's going.
Okay, thank you very much indeed. It's a great pleasure to be here. This talk's perhaps a little bit pedestrian after the last two. Thank you very much. So this talk might be a little bit pedestrian after the last two. I've been working for the last 10 years until I retired recently as an associate specialist doing mostly skin screenings. All week long I've been checking patients from head to toe, and I thought I was quite good at this until I did a sabbatical with Cliff Rosendale in Brisbane 5 years ago and realised I had a long way to go. And so anyhow, this is about basal cell cancers. I'll be talking about diagnosis, essentially not particularly about management. These are the sources of my knowledge, basically learning on the job, going to lots of conferences and reading lots of books, including these ones. The most recent book I read was Manuel de Dermatoscopy in French by my friend Luke Thomas. So, to begin with the obvious, basal cell cancer is very common, and it's very easy to diagnose when it's advanced. When I was at university in the 70s, they talked about these great big rolled borders, pearly, telangiectatic, central, ulcerated rodent ulcer thingies. And yes, the cat can diagnose them, a 12-year-old kid can diagnose them, but as professionals we need to do better than that. I'm a great believer in what I call integrated skin lesion diagnostics. And I produce this acronym BEATS. You use your brain, first of all, to learn all that there is to learn about the natural history of common and important skin lesions. You use your ears to take a history from the patient. All of these things matter. You use your eyes to inspect it, and ideally the surrounding skin, ideally the whole of the skin. And you touch to feel the lesion. Is it rough or smooth? Is it raised? Is it tender, etc.? And then you use the scope. You apply the scope. So you do all of these things and then put together an integrated diagnosis. Oops, sorry, press the wrong button. Okay, so we still see huge, even with today's advanced medications, pretty much incurable BCCs, at least very, very difficult to manage. I mean, there is this increasing conversation about the very elderly, the very frail, the option of not treating them or just managing BCCs conservatively when the treatment is likely to be more aggressive than if we'd left them alone and do nothing. These great big huge tumours are easy to diagnose, but the challenge is to diagnose them at an earlier stage. I don't like the term rodent ulcer, because when we're thinking about an ulcer, we will miss out the pre-ulcerated BCCs, and most of the BCCs, many hundreds, if not thousands, of BCCs that I diagnosed screening were pre-ulcerated, as we'll see. Why do people let lesions grow to this kind of size? You know, I've seen this in intelligent adults who were not mentally ill. You know, you expect it perhaps in a 92-year-old living on their own with dementia, but we still see these huge tumours which people have been watching growing for ages and ages. But this is more what I think of as a typical BCC. I don't think the huge ones I've just shown you are typical. These are what I call a typical BCC. And there are two lesions on this man's back. The one on the right of your picture is quite easily diagnosed, but the one on the left is smaller. And all of these lesions are small to begin with, and they can be featureless without a dermoscope. Is it even worth bothering to pick up BCCs? As we've heard, you know, if you're hunting for big, dangerous animals, perhaps metaphorically, we'll shoot a few foxes and rabbits while we're looking for them. BCCs hardly ever kill anybody. We can treat them. Screening the whole population isn't cost effective, and we haven't got enough consultant dermatologists. On the other hand, we know a lot more now about who is more likely to get skin cancer. So by being more selective about who we perhaps do screening for, it may be more cost effective. And of course, it doesn't have to be done by a dermatologist. Now, a fully trained dermatologist has a wide and deep lot of skill sets, but which would include lesion recognition, but you can train somebody who's not a fully trained dermatologist to be as good as a dermatologist in this one skill set of skin lesion diagnostics. And we certainly learned from Australia and New Zealand that this is perfectly achievable for GPs to do as well as, if not better than, a consultant dermatologist. So these are the sort of BCC that I would be in the habit of finding, sometimes up to 12 on one patient. I made a nuisance of myself. I personally caused our waiting time to increase because I diagnosed so many small BCCs doing these checks. Here's an example of the sort of thing that I started picking up more after I spent a little time in Cliff's clinic, where I was shown very generous hospitality. This is a chap who's being followed up for melanoma. So I take a look at his back, and low down on the back there's a little pink papule. Close up, it's a little bit more noticeable. The dermoscopy is really quite revealing. We can see as a pink background lesion. There's a central ulcerated scab there. There's some focused serpentine curved branching vessels, very sharply focused. And we've got some blue clods of varying sizes and irregular distributions. All the clues you could possibly ask for in a very small lesion the patient had no idea was there. When doing a skin check, it's very important to take the spectacles off. I think of the BCC triangle, an area made by across the top of the eyebrows and down to the tip of the nose and back up. I call that the BCC triangle. And you get a lot of BCCs there, but B, if you can pick them up when they're just 3 millimeters in diameter, and this is perfectly possible if you look carefully enough. Again, the no-touch dermoscope is very, very helpful in the first instance. Then you can save a huge amount of surgical expense and morbidity by cutting lesions out at the stage when they can come out with simple elliptical closure rather than needing Mohs micrographic surgery and a big plastic surgical wound repair. I haven't seen very many BCCs on the actual upper eyelid, but obviously this one did occur. Oops, sorry. Yeah, very common. Get people to take their spectacles off and take extra care looking for small lesions around this area. Look on the back, it's often surprising what horrors may be concealed on people's backs. This was a gentleman who was spending a lot of time in the sun, and he sought advice because he had a big bleeding lesion on his back, but that's not the one that was going to kill him. That one was. Now, you don't need a dermoscope to diagnose that. The great Giuseppe Argenziano, I heard him give a plenary lecture at the JADV in Milan a couple of years ago, and he said, why do we miss melanomas? Often because we don't see them, because we simply do not inspect the area where the melanoma is. Now, it is a very easy melanoma to diagnose once you've clapped your eyes on it. But it's clapping your eyes on it in the first place that matters. I'm often shocked by the things which lurk behind people's ears. How can somebody have that and not really notice it? Patients' false health beliefs are important. It's amazing how many people, when you tell them they've got a skin cancer, well, but how can it be a cancer, doctor? Because it doesn't hurt. People think that cancers are painful. Of course, SCCs can be. This is one of the reasons I don't like the term rodent ulcer, because this morpheic BCC have been growing for maybe 10 years, and it still hasn't ulcerated. Watch out for this sort of lesion. Again, get people to take their spectacles off. Basal cell cancers are often easier to see when you tension the skin. It's a very obvious thing to do, but it's using 2 digits to tension the skin. The tumour becomes more obvious, and also the extent of it becomes more obvious. This is a very good example of why we don't like amateurs doing difficult, complicated surgery on the head and neck. As you know, there are various subtypes. Do superficial BCCs invariably morph onto more invasive subtypes? I think almost certainly they do. I couldn't find a lot of evidence, but again, it's like how many invasive melanomas will move on to, how many superficial melanomas, the melanomas in situ, will move on to become invasive. Answer, we can't do a prospective trial because it's not ethical. It's not even technically possible. But most likely they do. This study in the JAAD in 2019 shows arborizing vessels, very common, shiny white structures, ovoid nests. Again, the term arborizing is controversial. I have 9 acres of land and I've got lots of trees, and arborizing means tree-like, like the branches of a tree, but trees don't all have the same branches. So if you're going to use a metaphor, serpentine is probably a more accurate metaphor. So superficial BCCs, most often on the trunk. If you see one, take a good look because they're often multiple. What are the features? Essentially, they're pink. Quite often, you've got some peripheral pigmentation. Spoke wheels, maple leaves, or sometimes you see a lesion that looks like that, but it's better to use the geometric descriptive terminology and talk about radial lines, because that's less susceptible to observer error. You see these clods within clods as well. This lesion shows multiple small erosions, and that's a common finding in superficial basal cell cancer. Multiple little ulcerations on the background of pink and white. Here's another example. It's a pink and white background at the top of the lesion. You can see numerous yellow clods which represent multiple micro ulcers. Similar thing here. And that's just those close-ups just show you've got these radial peripheral lines. Just going to whip through and show you a few more of these. This is interesting feature you don't always hear described. This is the BCC, which, as well as other features, has got a number of aggregations of fine dark grey dots. There's some more spoke wheels, if you like, clods within clods. Now, the thicker tumours have got these blue clods in them. You won't see blue clods in a superficial. If you see blue clods, it's a thicker BCC, and that is important clinically because you need to cut this out. You won't be able to treat it with topical therapy here. Brown clods within clods on the right, and on the left you've got blue clods. This one has got some grey clods. The vessels are very typical, sharp, focused vessels. Superficial BCC, you've got sharply focused vessels, but they're very short and they don't tend to be, and they're thin and they don't tend to branch. The thicker lesions have got these bigger tapering sort of vessels. A big horrible tumour like this, you can't really tell whether it's a melanoma or a pigmented BCC. So you asked your friend the histopathologist. This one we weren't sure about, so we cut it out quick. It was a BCC. On reflection, the vessels are very helpful. On the nose, they can be tricky to capture. On this image, you can see the plain view. You've just got this slightly depressed, shiny area. The dermoscope is quite handy. You've got an area of porcelain, like white in the middle, and within that, you've got some very sharply focused vessels. However, back up at the top right-hand edge of this lesion, you've got some more that doesn't look right. So this one really needs micrographic surgery. But note that within the area occupied by the tumour on the nose, I'll have to answer later, but I've got a rash on. The follicles are absent. In the top right-hand corner of this image, you can see you've got some follicles, but within the tumour area, there are no follicles because they've been abolished by the tumour. Now, I've seen this a lot, and probably a lot of you are very well aware of this, but I've not often heard this taught on. So the absence of follicles is quite interesting. I'm going to whip through a few of these for time. This is an absolutely photogenic one. And I think this is one of the problems that teachers often pick out their most photogenic images. This one's got beautiful arborizing vessels and big blue clods. But most of the lesions are actually less exciting than this. That's the point I'm trying to show you, the early ones I picked up. Nice vessels here. This one's a bit squashed. I'm just going to whip through some of these a bit quicker. That just goes to show if you put the pressure down, the vessels disappear. We've heard that from previous speakers. Just going to whip through a few more of these. And this is a very feature-rich one. Don't have diagnostic greed. You don't need to have all of the features. One or two of them is enough. And let's refer from Cliff, and I always teach this. There are 5 common benign skin lesions. If you can't positively diagnose one of those, then you should be concerned. Obviously, you can't here. I don't like the term chrysalis structures because the shiny white structures we see in BCCs don't really look like insect chrysalids at all. Insect chrysalids tend to be grey or green, sometimes some very funny colours. I don't like the term. We've heard about this before, just another nice example. You won't always see all of the features. Differential diagnosis, lots of things. I used to see cases like this when I was a GP. Why won't this eczema get better with steroid? Because it's a BCC. Beware of a solitary plaque of eczema. But we do see people with sometimes a lot of lesions. This was a Scandinavian seafarer. I saw him a few times over many years with a lot of tumours. And this had been treated as eczema. Took a biopsy. It's a superficial BCC. Cleared up very nicely with Effudix, and it did not recur because I followed him up for years after this. This gentleman had 3 lesions, and he'd been treated for psoriasis. These, of course, are all multiple BCCs. Most of BCCs I've seen on one patient at one time was 12, and that was not a genetic case. It was just somebody who had a lot of sun. So is this a BCC, is it an SCC, or is it something worse? It had come up very quickly. I thought the vessels looked a bit like a BCC, but I could not tell. And as my friend and mentor Cliff has said earlier, you can't always tell, and the audit does not lie. But I thought this was maybe basal squamous or something horrible. So we cut it out quick, and it was a BCC, believe it or not, although it had grown very fast. Could have been any of these other things. And I want to propose the idiot rule. Bob Dylan put out an album called Blood on the Tracks. It was about a marriage or break. Anyone love that album? Anyway, he's got a song on it called Idiot, and there's a line, someone's got it in for me, their place in store is in the prayers. Whoever it is, I wish they'd cut it out quick, but whether they will, I can only guess. And so I propose the idiot rule. When you see a new pink lesion, whatever it is, you better cut it out quick. Okay, in Southampton, which I don't think is very different from other places in the UK, we have 2 waiting lists. The urgent one for suspected melanoma, SCC, Merkel, etc., where we try to get the lesion removed within 5 weeks, and then the non-urgent one for BCCs, which post-COVID has gone up to 15 months. And as we were hearing earlier, you can't always tell, and that was the one thing that kept me awake at night, was the fear that I had put a tricky melanoma or a nasty SCC on the slow track waiting list. Of course, it is a disgrace, verging on criminality, that we're keeping people waiting for up to a year. Anyhow, tattoos, obviously, as you all know, much more popular these days, and they can make life more difficult, but it just adds to the difficulty of it. But the same rules still apply. History, what kind of patient is it, etc., etc. And we can see ulceration here, and we can also see, I think, some vessels. It's got to be something, but again, you've just got to obviously cut this out. Just another example of a BCC in a piece of body art. Ulceration, crust, vessels. If in doubt, you take a biopsy. I'm not a great fan of tattoos, but some of them are very pretty. And this bluebird, I was very sorry to have to cut. Obviously, we've seen a nice example of a wolf earlier. I don't know if we'll see that again. But this was interesting. You can see some very typical BCC vessels here. And you can also see a huge number of May globules. These are a recently described feature. And they're made of calcium, I believe, and they're seen in slightly more aggressive BCCs. Can you tell a pigmented BCC from a hypopigmented melanoma? Well, sometimes you can, but I've got a lot of cases that I've shown to expert audiences which people were divided 50-50 over. So again, the idiot rule applies to these. The one on the left, you can see some very nice peripheral projections, some peripheral lines. And at the top, you can see clods within clods. These brown clods within clods, where you've got a dark clod within a dark brown clod within a medium brown clod. This is a very specific sign for a BCC, I find. The lesion on the left is a melanoma. Can you tell which is which? Not always. It's a good rule to cut them out quickly. And yeah, obviously collision lesions occur. We've got a nice seborrheic keratosis on the left and a BCC on the right. One of the things about collision lesions is often you've got a very clear line of demarcation between the two components of the collision lesion. And I think you can see that the seborrheic wall on the left is a very clear, very clean curved line separating it from the BCC. So you can see they are indeed two separate lesions, which, just like junk in a teenager's bedroom, one something lies on top of something else. It's not related to it, it's just superimposed over it. This is a scary lesion. It was a little pink papule, some grey blue clods in it, which you could maybe be a BCC. I've shown this to experts and people come down 50-50. But in fact, look at the vessels. Now, the pink nature of it could go for a BCC. The blue-grey clods could go for a BCC. But what about the vessels? I can see some linear vessels and I can see some dotted vessels. That points to a melanoma rather than a BCC. And that's what it was. Now, I've said that in superficial BCCs, you'll see short, thin serpentine vessels. whereas in thicker ones, you will see thicker, tapering, arborizing type vessels. And this was a thick, palpable lesion. So you would expect to see arborizing type vessels in it if it was a BCC. But if I can see, they're always subtle, but I can see linear, irregular, polymorphic vessels here. So this is a dangerous tumor. And God have mercy if someone had thought that's a BCC and put it on the slow track wait, and it had been a year before the patient had their excision. What do we see here? Well, we see a nasty ulcerated lesion. Again, that comes under cut it out quick. There's a blue clod. There's shiny white lines. These are, as the chaos includes algorithm teaches us, these point to malignancy, but they don't necessarily distinguish between different types of malignancy. And this was a very thick and dangerous melanoma. This lesion, on the other hand, was a pigmented BCC. Now, can you really tell which is which? It doesn't matter because you've got to cut them out quickly. The decision algorithm. So there's more information about this sort of thing on the International Dermatoscopy Society website. If I could just say a few words very briefly on behalf of the International Dermatoscopy Society, of which I'm a board member. It's a great society. It's free to join. There is a lot of online resource, not including a number of brilliant, accessible videos on Facebook. And we've got a conference coming up in Buenos Aires in a few weeks. Those of you who are not yet booked probably won't be booking, but a lot of other good things are done by the International Dermatoscopy Society. It's free to join. The next big conference will be in Europe in 2027. I can't tell you where it'll be in Europe, but it's going to be in a great city, and I've had the honor to have been asked to be involved in it and to be promoting general practice dermoscopy. So I hope you will all be there in 2027. You'll find out more later. Thank you.
Thank you very much, Stephen. What a wonderful presentation. BCC's in action, absolutely, and all the things that go with it, and concerns in health systems, and I'm sure we can traverse some stuff in the panel later on today. It's time for a morning tea. We have about 20 minutes. We'll bring you back in by 20 past if you could be coming back in, so you go and have a nice cup of tea and a chat, and we'll see you all soon. It's time to make a start again. We're running a little bit late.
Hi.
We'll do our best to cover most things
Hi.
for you.
Okay.
And our next speaker, who you know now, is Nisha, who's going to run over diagnosing pigmented facial lesions. Really good area.
I'm out
High-powered
of time. Please
Nisha.
let me know, okay? Because when I'm talking, I forget. My timing is not so good. I can stop anyway.
That's you?
Yeah, it's me.
There we go. So remember, you've got a thing here.
Yeah.
Press there. Press that. It should do that. See, running around?
Mm-hmm.
If you just hold it down, you can point with that. And that's forward.
Yeah.
That one, big one.
Okay. Hi, dear friends, once again. Now we are going to talk on diagnosing pigmented skin lesions. Sometimes it's very challenging, but when you know the clues, actually it's not so difficult. When you have difficulties to diagnose, then take a biopsy. It's the best way. Now I would like to start my presentation with a lentargo maligna case, looking like a Turkish map. And I am living here in Ankara, the capital of Turkey. And now I think we all know the dermatoscopic features of lentargo maligna on the face. There are circles, complete, either incomplete, half circles, circle within a circle, central dot within a circle, gray dots and clots, angulated lines, rhomboidal structures, perifollicular radial projections. They're all described common dermatoscopic features of lentargo maligna. But unfortunately, they are not very specific for melanoma. Especially in pigmented actinic keratosis, we can observe all these structures except obliterated follicles and structureless areas. They are more specific to lentargo maligna, but the other features can be observed in pigmented actinic keratosis and sometimes in solar lentargo as well. This is a very good approach described by Emilios Lalas, and he called this algorithm as inverse approach of facial pigmented skin lesions. According to him, there are some non-melanoma features and melanoma features. And if we know the non-melanoma features, the algorithm really works very well. What are they? Scales, white and white follicles or rosettes or four-dot clots, and erythema. These are more specific to actinic keratosis. White and white follicles, erythema, and scales. And the other non-melanoma features commonly observed in seborrheic keratosis and solar lentargo are reticular or parallel lines. And these reticular lines are generally very delicate, thin reticular lines. Sharp demarcation and scalloped borders, and classic seborrheic keratosis criteria like medial axis, comedolike openings. And according to this method, when there is the presence of one or more of these structures as a predominant feature, is suggestive of actinic keratosis or seborrheic keratosis. If none of these features can be seen as a dominant feature, then the lesion is suspicious for melanoma. And this approach is called inverse approach. Now, for example, let's have a look at the first lesion. What we see here, the dominant pattern is reticular lines, right? Delicate reticular lines. And we have scalloped borders. So this is a typical solar lentargo. And for the one on the right-hand side, it's again a typical solar lentargo. We have parallel lines, we have scalloped borders, and the one on the inferior part is also a solar lentargo because we see structures light brown and scalloped borders. They're all very easy to diagnose, so you don't need to do any action for these lesions. Here, another easy diagnosis because we see here a typical seborrheic keratosis criteria, which is curved, thick lines. And this is also called brain structures in metaphoric language. I generally use descriptive language during my presentation, and I call these structures as thick, curved lines. This is very typical for seborrheic keratosis. And for seborrheic keratosis, we also have to look for the feature with non-polarized mode, because in non-polarized mode, milial-like cysts, white structures, and comeda-like openings, brown, black, and yellow structures are much more visible. And this makes our diagnosis easier. For example, here, what is the dominant pattern? What do you see? We have white and white follicles, right? White and white follicles, and in some parts we have 4-dot clots. You see white and white follicles and perifollicular pigmentation and erythema here. So what is this? And we have also scale. Is this a solar lentigo? No. Is this a seborrheic keratosis? No. This is a clear-cut pigmented actinic keratosis. White and white follicles and erythema. It's highly specific. Again, a skin of color patient. This time we have a very dark perifollicular pigmentation, right? So we should concentrate on follicular openings. Are they white and white? Yes, they are white and white, right? And we have here 4-dot clots. You see? Rosettes. So this is an actinic keratosis of a skin of color patient. And what do you think for this one? Do we have white and white follicles here? A skin of color patients. We have white and white follicles. You see, they're all white and white. Even we have some rhomboidal angulated lines, because we can see this structure in actinic keratosis as well. I told this at the beginning of my presentation. So the dominant pattern is here, white and white follicles and erythema. So this is another actinic keratosis. There are a lot of skin lesions here. This part is solar lentigo. What we have here is structure is light brown, and we have well-demarcated borders, right? Look at the borders. This part is a solar lentigo. And here, there is a seborrheic keratosis because we have thick, curved lines. It's very common on the face. Solar lentigo and seborrheic keratosis are always together. And for this part, what do you think it is? Even though we have angulated lines, polygons, the dominant feature here is white and white follicles, right? So this is an actinic keratosis. Then on this, the part on the superior part is an actinic keratosis, and here solar lentigo. And what do you think for this one? What's the dominant feature? We have erythema, we have scale, and we have white and white follicles. Then it is actinic keratosis. It's easy, isn't it? Yeah.
Excuse me, are you saying light and white or white and white?
White, white, color white, and white. Big, enlarged. Okay? White and white. And here's the close-up. White and white follicles, erythema, and in some parts we have scale. This is very easy. What do you think it is? When you see coarse, pigmented structures with different shapes, it's most likely a lichen planus-like keratosis. They're all melanophages. And I think we all know this progression model, which was first described by Schiffner for the diagnosis of lentigo maligna. According to Schiffner, he thought that melanoma always starts in the interfollicular area, not in the follicles. The first structure is dotted structures, dots and little clots in the perifollicular area. Then they form short streaks, then first sign of rhomboidal structures appear, and then they obliterate hair follicles, and then we see follicular obliteration as structureless background. So this is the progression model for lentigo maligna, according to Schiffner. But there's a recent publication published by Christian Navarrete Deschamps. This is a really very good clue for lentigo maligna cases. I'm going to show you some examples on these structures. He thought that lentigo maligna doesn't start in the interfollicular area. It starts in the follicles. And the first changes are complete and incomplete circles, then perifollicular projections appeared, and they form a connection point between the other follicles, and here angulated lines appear, and then follicular obliteration. It is the last step of his progression model. Now let's have a look at the examples. For example, he called these structures as perifollicular projections, and he said that this is highly specific for melanoma. Almost, it has a specificity of 97%. You see these structures? Okay. And according to his progression model, then circles, again, perifollicular projections from the hair follicles, emanating from the hair follicles. We see here 2 perifollicular projections. And now, angulated lines. There's a connection between hair follicle to other hair follicle with these perifollicular projections. And here there are a lot of perifollicular projections, and you see the lines are connecting one follicle to another follicle. Perifollicular projections. And they took a biopsy. This is the confocal microscopy of these perifollicular projections. They took a biopsy from here, and this is confocal microscopy images, and you see these perifollicular projections in the hair follicle, and histopathologic correlation is very similar with confocal microscopic features. You see these perifollicular projections here, pigmented keratinocytes and atypical melanocytes along the dermoepidermal junction is observed here. And this is the reason for the perifollicular projections. But in Turkish population, I observe these perifollicular projections in solar lentigo as well. From my point of view, it's not very specific to melanoma. For example, this is a case of solar lentigo. I took a biopsy after his description, and there's nothing for lentigo maligna in the histopathologic sections. And you see these perifollicular projections here and here. This is a solar lentigo. It's a little bit out of focus, but you can see the projections. Again, a solar lentigo with perifollicular projections. And again, another solar lentigo. You see the rhomboidal lines really looking like a lentigo maligna. The main pattern is here brown circles, but we have perifollicular projections. And this is also another solar lentigo. Typical lentigo maligna here. This is not solar lentigo for sure. Now, I'm going to ask your opinion on this case. This is a clinical feature. There is a flat pigmented brown lesion. What do you see here? Background structure is light brown, right? There are no white and white follicles here. And we have brown circles. This part looks like a seborrheic keratosis because we have curved lines, thick curved lines. And let's have a look at on this part. This is perifollicular projection, right? And these are all perifollicular projections, you see. We have angulated lines, and here maybe this part is going to follicular obliteration because we don't observe the follicles here. So what will you do here? Are you going to take a biopsy? This is a solar lentigo or a lentigo maligna. What's your preferential? We exclude actinic keratosis here. So we have to take a biopsy here, right? Because there are a lot of suspicious findings. And histopathology showed that this is a lentigo maligna. So what's the treatment here? The patient didn't accept surgery. It was a huge lesion. Yeah. And you see the irritation We prescribe Aldara 5 times per week. And when you have a lot of irritation, ulceration, and crust, the result is much more better. We should be patient. And 2 years later.
Fantastic.
Fantastic, isn't it?
Yeah.
And there is no relapse. The patient is under follow-up. Really, I would like to show the effectiveness of Aldara in lentigo maligna patients when there is no lentigo maligna melanoma features. And when for patients who doesn't accept surgery, Aldara is really a very good option. And you see, there's a small lesion here, and 2 years later. This is the first dermatoscopy. Actually, this looks like a lentigo maligna here, isn't it? I think we should take a biopsy from this point. But the patient has a lot of moles in the body, and we generally concentrated on the moles on the body, and we just take the dermatoscopic photo. And 2 years later, you see the change? Let's go to Christian Navarrete's perifollicular projections. Are there any perifollicular projections here? Yes, we have. Structureless light brown background, perifollicular projections, and again, here's some follicular obliteration, and it's getting larger. And here, according to the model, we see most of the features described by Christian Navarrete-Deschamps. And here you see perifollicular projections, perifollicular dots. And I think
we're getting close on time, yeah.
Yeah, so let's show this case. Yep. This is my last case. Okay, let's ask this case. It looks like a lentigo maligna, right? Let's have a look at the dermatoscopy. What do you think it is? Melanoma or AK? AK. Why? White and white follicles. What's this? AK or melanoma? Melanoma. Because the background is light brown, right? So there is no white and white follicles. Here is the difference of lentigo maligna and actinic keratosis. You see white and white follicles, and there is no white and white follicles in the first photo. The main difference is this, actually. And last question, what's this? AK or lentigo maligna? AK, super, because we have white and white follicles. This is actinic keratosis. Just concentrate on the follicles, I mean, not perifollicular projections. This is very typical for actinic keratosis. Thank you for your patience.
Thank you very much. That was wonderful. And we'll keep moving as we're going forward. This is good. We need to. So Amanda, we need to get you hooked up. Do you want to have a? Yeah. So welcome back to Amanda. Now Amanda's going to traverse for us the evolution of melanoma. Now Amanda, for those of you that weren't here yesterday, is a professor from New Zealand, worked closely with general practice over 30 odd years. She really birthed teledomoscopy in the Waikato, a big rural area where there's a lot of melanoma over the years with her GP groups, and most wonderful evolution of that. But Amanda also is known for being the founder of DermNet. Sorry, my apologies, Amanda. DermNet. Who uses DermNet here as a resource? Look at that, the whole room. Isn't that amazing? So there we go. So lovely to have you, Amanda, and we're looking forward to your talk.
Thank you. Do I have the pointer as well?
Yeah, you can. And that's it there. Remember there, you've got that.
Great. I loved your talk. Thank you, Nisa. It's so exciting to be here. I've never been to Manchester before, although I should have really, but there we go. And it's very nice to talk about the evolution of melanoma. I haven't got any answers for you. I thought by doing a little bit of background research, I'd come up with this. This is how melanomas evolve and how you diagnose them, and everything would be easy. But instead, I'm just going to show you some pictures. Some complex. So I'm going to talk about dermoscopic criteria for melanoma and the variation according to subtypes and early detection through dermoscopic changes. So to remind those of you that are seemingly unaware, we have we're equal with Australia in terms of registration numbers for melanoma per head of population, but we win the race for deaths from melanoma. There we are, the capital of the world. Early diagnosis means diagnosing melanoma before it has metastatic potential, so we try and get them in situ for an improved prognosis, minimize morbidity and reduce treatment costs, but that's at the expense of unnecessary excision with what is biologically benign. We do it by skin examination training, prompt medical intervention when we can achieve it, training health professionals, and digital monitoring to detect change. The ABCD criteria include change, so E for evolution. Here's an example of very slow evolution of a pigmented macule that was eventually excised due to detection of change and found to be melanoma in situ. These are clinical views. The dermoscopy views really show a very uninteresting lesion even at review, and it could well have gone on being monitored for years and years and become enormous without it being biologically serious, perhaps. So we prefer the revised descriptive pattern analysis to the traditional having to memorize 350 terms, none of which, or very few of which, actually make any sense. And change that isn't consistent with a benign lesion. So we're looking for atypical pigment network, asymmetrical, irregularly distributed structures, focal radial streaming, and pseudopods, which are lines with a bulbous end. An increase in colors, although, as we've seen in that previous example, we just had a uniform brown color. And we look for structureless hazy blue, gray, white, scar-like white, polarized white lines. You'll be familiar with these, and of course, with Cliff's excellent poster. Is there a variation according to subtype? Yes, there's been quite a lot of published about how the dermoscopy changes according to the histological subtype. But I'm not sure it's very important. The subtype, the clinical subtypes and the histological subtypes have become less important than early diagnosis, whatever type, and looking for the dermoscopic features is a priority. So we've got examples of lentigo maligna, and yet each of these has quite different clinical and dermoscopic features. Of superficial spreading melanomas, of nodular melanomas, and acral lentiginous melanomas being the most common subtypes. The evolution may depend on the body site. Is it sun exposed and viewed by many and ignored by most, or in hidden sites, hidden to the doctor as well as the patient? So how is it that we see over and over again patients presenting with large melanomas, often melanoma in situ, on clearly exposed sites? That's a philosophical and ethical issue, which I won't go into further. Or is it surprising that hidden sites will present late? If it's the sole of the foot or the back of the neck, within a hair-bearing scalp, or in a mucosal site. And what about variation of melanoma according to Breslow thickness? Can we actually tell how thick a lesion is by its dermoscopic features? Some people claim they can. I'm not very good at it. So here's some examples of melanomas in situ, histologically. If that's true, I'm not sure our pathologists are any better than our clinicians at uniform diagnosis of variants of melanoma. Perhaps they missed the deepest bit and have called something melanoma in situ, where in fact invasive tumour was present. So that picture on the left is a dermal nevus and has a little melanoma in situ arising on top of it. So here's some examples of Breslow thickness less than 7.9 millimeters. Is that true? Did the pathologist look at all these sites which are dark? So I can't tell how deep they are because the black is surface melanin and could indicate melanoma in situ. And I'm not sure if I'm looking at grey or blue, which would indicate a thick melanoma. So if we follow our minimally worrisome lesions over time, it is really, really helpful to be able to detect change. And if that's increasingly bizarre, we can make a diagnosis of melanoma. In this case, I think we missed the boat because the follow-up showed it was an invasive tumour. Was it invasive in 2012? We will never know. So these are the next thickness of Breslow thickness. I've seen melanoma in situ look like that scaly plaque, where all the melanoma cells, I forgot to put a picture in looking like that, but all the melanoma cells confined to the epidermis with a bit of reactive epidermal hyperplasia can result in a really thick plaque, and yet the tumour is in situ. Or maybe it's thick because there's follicular involvement, and that is still in situ, even though it may be penetrating a millimetre or two into the dermis. It's not involving the dermis. Here we've got some thick lesions. Can we tell that they're thick before we cut it out? I'm not sure. Here in the first lesion, we have some white lines, negative network perhaps. And in this one, we've got lots of features of invasive melanoma, multiple colours. This is more or less totally blue, so we'll accept that that's going to be thick. But what about this presumptive basal cell carcinoma, which turned out to be 20 millimeters thick melanoma? Was not the lesion of presentation, which was a small seborrheic keratosis on his forehead. And the nurse examining the patient said, "Would you like me to check your back while you're here?" He didn't survive very long after that skin check. So can we detect dermoscopic changes early, and does that result in saving lives? I hope it does, because it's what I do for a living. Short-term follow-up of individual lesions of concern is usually at the 3 to 4 month level. Maybe in some slow-growing tumours, we'd be better to say 6 or 12 months. But there's a lot of data, including my own, to say the patient doesn't turn up for follow-up if you leave it too long. And you are better to have a shorter follow-up simply to improve adherence to recommendations for checking. Annual full-body skin checks or mole mapping are very prevalent in New Zealand because we have a number of services. I work for Mole Map New Zealand and have done so since 2003, which promotes annual full-body skin check. Originally, it was promoted in the patients at very high risk of melanoma due to multiple atypical or so-called dysplastic nevi or a history of melanoma. But in fact, it's incredibly valuable to prevent the unnecessary excision of lesions because we can clearly say that it hasn't changed, it's normal, you don't have to have it cut out. And that is probably saving an enormous amount of time, cost, opportunity costs, so that because in many places the huge number of benign excisions is preventing people with melanomas getting early treatment. And what is the role of automated treatments? So the short-term follow-up is for minimal concerns lesions with a few atypical features, and that concern might be modified by the age of the patients, the sex of the patient, the risk factors, and sun damage. So here's an example of a 3-month short-term follow-up. Has it changed, or is it stable? It might take a 30-second look in this slightly atypical lesion to be certain. But when we get dermoscopy, we can see subtle changes that we would have missed by only examining the patient face to face without dermoscopy and without that follow-up showing very subtle changes, and this was melanoma in situ. This is an example, it's quite an old example, of the mole map program as presented to the dermatologist. We get a map which shows us where the lesion is, and we get a location view, and we get close-ups and dermoscopy views. Now this is obvious change in an obvious melanoma that should have been excised earlier, and indeed was recommended for excision earlier. But patients don't do what they're told. And unfortunately, some patients go to doctors who don't do what they're told. So from time to time, we do follow up quite obvious melanomas inadvertently. In this case, I'm demonstrating how the patient was recommended for a review in 3 months, but actually turned up at 11 months. And that's not at all uncommon. It's very nice to see the progression of that patient's melanoma. Retrospectively, we should have excised it earlier, but there may have been modifying reasons for not doing so. Perhaps the patient had many similar lesions. So here's a patient who's been monitored for multiple lesions, no particular concerns about the one on the left, until 5 years later the patient returns for re-imaging, and clearly it has changed. I cannot tell you what the histology was because I don't know it, but it's suspicious of melanoma. Now, an evolving nevus with peripheral dots is nice to follow up to confirm the benign nature of the lesion. It remains symmetrical and continues to have the peripheral dots, so it's continuing to enlarge. But there's not much difference between 2012 and 2015, so that enlargement is occurring extremely slowly. In a young person, we feel we can reassure them because that's the age of growing nevi, and an older person, we're better off to excise because they're less likely to have a growing nevus and therefore more likely that peripheral growth pattern is indicating early melanoma. What about this one? 2009, we probably weren't quite so aware of the changes to look out for that we are now, but still, there was change, and the 2.5 millimeter diameter lesion hasn't changed in diameter, but it's changed in structure. When should we be following people up regularly? I mean, we say once a year. That's an arbitrary figure because the calendar makes it easy. Can we detect changes from whole body photography? So there's been a lot of emphasis in the last 2 or 3 years of automated systems and a lot of research going into can we use polarized macro photography with automated camera systems to then detect change on re-imaging. And that's true, but it's marred with problematic issues because you just have to move a squidgen and that lesion is going to look different. And indeed, if the patient bends slightly over, the lesion is going to be stretched and look different, and the lighting must be constant and so on. So we're not yet doing automated monitoring by change detection. We're still looking at individual lesion detection. So here's another example of slow growth of melanoma in situ. We've got 10 years between these two images, and this is a biologically benign tumor, which is, again, not really much bigger in diameter. So the old instruction, well, you should measure it before we had useful photography, was clearly not very sensible, and it still goes on. Here's another one. 2014 to 2015, just subtle changes. It's a large lesion with atypia to start with, quite obviously a melanoma in a patient who has 1 million of them. which ones are we going to remove in the patient who presents with 5, 10, or 20 pigmented lesions of this kind. They are all histologically either atypical melanocytic hyperplasia or the next stage, melanoma in situ. But if we detect change, that's a reason for excision. So here's some pretty pictures to show you one or two other evolving melanomas in situ. I really like this running dog. It was running faster and faster as the years went on until the patient finally gave in and said, oh, all right, then cut it out, which is what happened. What about this one? We've got a macro plus 2 dermoscopy images, polarized and unpolarized, 2020, 2023. It seems to have got smaller in 2023, 2024. What about this one? 2014 through to 2018, and eventually the patient agreed to stop monitoring. So what about artificial intelligence? So in New Zealand, MoleMap has its own artificial intelligence program called Kahu. And Kahu is in use in MoleMap's clinics. So most of the clinics, there are 40 nationwide in New Zealand, have Kahu inbuilt into their system. So what happens is the melanographer, that's the nurse who's taking photographs, who does a full skin check. So as they do the full skin check, they will photograph lesions, and Kahu will tell them whether it's benign, malignant, or in between. And if it's benign, they don't keep those images, or at least they don't send them to the dermatologist for assessment. We only get the malignant ones and the ones where AI is just as confused as me. That is to say, this one has more confidence that it's benign than it's melanoma, but there's enough there to say it could be melanoma that clearly it needed imaging, and the dermatologist is going to recommend excision. In this case, it was actually followed up. We've got lovely pictures of evolving lesions that were benign. So this lesion, macro on the left, dermoscopy on the right, was imaged in 2023 and again in 2024. It is enlarged in a patient over 50. It was excised. It was a compound nevus. Melanonychia. This looks pretty dodgy. It's already had a biopsy of the matrix. The matrix biopsy was benign. The patient was reassured. Nothing to do with me. This is an inherited one. And the patient continued to attend for follow-up as the line became broader and broader, and the nail began to become destroyed before it was finally underwent further biopsy. Fading nevi. So in adults, you read that as we become senescent, senescent nevi disappear. Well, I've been seeing many, many thousands of older people who've had whole body skin checks and multiple lesions imaged. And to be honest, this senescent nevus phenomenon is uncommon. It's very real, but it is uncommon. And here's some examples of fading nevi. So what about the future? Or the near future? Are automated systems going to help us detect change? Yes, but we have to be cautious. So this is a picture of the Canfield Vectra 360. There's a few of them nationwide, worldwide. They cost $200,000 or $300,000 US. We don't have one in our clinic and no prospect of getting one, but they have them in all the big centres in Australia, and they're doing some fantastic work on determining whether their artificial intelligence can detect accurately changing lesions over time using macroscopic polarized imaging as well as dermoscopic imaging. PhotoFinder has a module which will do the same with a camera that moves up and down, and the patient has to move around. It takes a little bit longer than the Canfield Vectra, but it's also less expensive. But no, we don't have one of these in our clinic either. But my mate down the road has one, or at least he has an older version, and he's trying to decide whether to purchase the upgrade to get this artificial intelligence. So it's been interesting reading the Skin Cancer College of Australasia's discussions on this topic. I'm a lurker, rarely contribute. But the people that have these are saying, well, it's not good enough yet, but I'm really glad I bought it because it's going to be good enough, and I'm going to have baseline images that other people won't have, and I'm going to be able to detect earlier melanoma once they've sorted the various problems that exist currently with the AI. So that was an interesting thought. Now, DermEngine is Meteroptima's product, and you can purchase their module for total body photography. It's not expensive. And basically, you buy a ring light, a huge ring light. It's very heavy, and you walk around the patient taking photographs, and the software can recognize the photographs taken before and detect change. Again, this is early days. It's fun. It's going to be useful in the future, but the technology isn't quite ready for recommendation. So what are we looking for over time? We're looking for increase in size. But sometimes melanomas get smaller. We did a published paper on melanoma in situ changes, and about 10% of the melanomas in situ were smaller when they were excised than when they'd previously been imaged. Greater disorganization is usual. We expect that. But that could mean loss of symmetry, loss of patterns, and features, gains of features, loss of features. So you might have radial streaming one time and none the next time. Increasing colors would suggest increasing depth of the lesions and scar-like depigmentation, but it's not predictable. We know with increased thickness, we would expect more blue, more white, shiny, and milky red structures, and fewer angulated lines. Anyway, in conclusion, early detection of melanoma is important, but it isn't easy, and serial imaging helps. I see Chris threatening me.
You did say in conclusion.
Yeah, that's true. Let's welcome machines, but let's just be cautious for the time being and use our human skills to aid those tools to make the right decisions. Thank you for inviting me to give this talk. It's been a pleasure.
All right, that's lovely. We are, as you know, running behind time. We do have some interesting cases before lunch, but I thought before we move on to some of those, you may want to ask Amanda some questions, and maybe Nisha as well. Is there any questions at all? Yes. Speaking up loud, please.
How much time are you given per patient to do a full body check? And what's your next available appointment for a follow-up? Do you have enough slots?
Okay, so it's no good asking me questions that I can't answer. The question is, how much time do I allow for a whole body skin check, and when's the next follow-up opportunity? Now, I'm an academic. I supervise registrars in a clinic. We don't do skin checks in our clinic. All our skin lesion management is by teledermoscopy. We are depending on other people to do them. We depend on our general practice colleagues, and we depend on MoleMap New Zealand, which is a very expensive private service. And so I will defer that question to Chris, who does skin checks all the time.
All right. We do. So we allow between 20 and 30 minutes, and it does vary because if you have someone with hundreds of nevi, you're going to spend a long time. You're going to see every nevi every time. So we target the high-risk people and give them a bit longer, but generally I would allow 30 minutes time to write notes between, and that suffices. You're taking a lot of images as you go. And like Amanda, we have derm engine, we have a nurse doing full body photography and a double check dermoscopy on high-risk people using the whole thing at the moment. So we allow 30 minutes for that as well, for the high-risk. So you've got to give yourself time. You've got to get a good constant process you go through each time when you do your skin check. So, you know, it's consistent and you're not missing areas. Everything works out well. And we're all a bit different. Cliff teaches probably the best gold standard way of doing that. So, yeah. Cliff, would you have any comments about the full skin check? It's pretty important, isn't it?
Depends on the patient. We allow half an hour to get 15 minutes for a standard follow-up examination. For some patients, we get them back for half an hour or an hour. Someone who's got lots and lots of lesions, we spend a lot more time.
Great. Is that good?
And your next availability, do you easily find slots in 3 months for a review?
Yes, so we do short-term for monitoring 3 months, most of us. That's pretty gold standard in Australia and New Zealand, so we'll be doing those. And we allow 10 minutes for that because we're going to be tracking 1 or 2 lesions, and those are high-risk people we're tracking anyway. So those ones will be on an annual check anyway, but we're doing a 3-month short-term on something new and as you go. So you build your time, and like your GP template, your time template, you build it in. Every day, Andrew and I have slots at the end of our sessions for acute cases that can only be booked a day or 2 ahead. So people who have got something they're really anxious and concerned about, they're going to be seen really quickly. And the old days of general practice in New Zealand, we could do that too. It's sort of gone by the by, but we do that in skin cancer. We bring that technique with us. We'll see people extremely quickly. They're worried, they're anxious, and they need to be seen. And often it's something that needs to be dealt with quickly, and we can then deal with them quickly in our clinic as you go. So it's a really good model.
It's not possible in the public hospital system. We have no appointments for anything. You just about have to have toxic epidermal necrolysis to be seen in my clinic.
So we share the same problem as you in New Zealand. We have very small numbers of dermatologists in our public system for some reason. Next question. We'll just bring you up a microphone, all right?
Thank you. Could I come back to the photography AI issue? Is there a sufficient track record in the use of this technology that would show an incremental improvement? You know, if we're assuming that it's going to be better in the future, is there any data to show that the specificity and the sensitivity of this technology is getting better?
The idea of using whole body photography for following up with change is very new, so that data is not yet available. But if you look at the expansion of generative AI, for example, in the last 12 months, you can imagine that all aspects of AI will show very rapid incremental change. Now, we have an expert on artificial intelligence and computer imaging of skin lesions in the audience. Moi Hoon, would you like to answer that question?
I think yesterday Cliff talked about the contribution of HAM 10,000 and also the effort of international skin collaboration, all the images that show to advance this area. There are also some publication in Nature Medicine to prove the improvement and compare with the dermatologist performance here. So the next step for this, it will be in using multimodal, not just about imaging, but combined with text, other type of comments, history of the patients to improve that. And some of them even use like the power of ChatGPT to generate some more information about the images to improve. So it's ongoing in other areas. It shows lots of improvement for natural images, because that one is what computer vision and AI scientists start with, is natural imaging, because lower risk. But all these techniques will come into medical imaging. So there are lots of new development in Mikai this year, 2024, in Morocco this year in October as well. So there will be lots of mind-blowing things happening in medical imaging. I'm happy to speak about it later if anyone with questions. So yeah, thank you.
Thank you for that. It's really good. I think the question is, are we going to get replaced as doctors, and can we rely on? And we're not. We've got to learn chaos and clues. Clinically, we've got to interface with people, and the AI will be augmenting and helping us. There is no rescue. We have to do it. We're the people. Okay, that's my view. We're the people. Is that right? All right, Amanda?
Yeah, sure.
Very helpful.
Absolutely.
Good as gold. Now, there's no more questions. Oh, sorry, Finbar. I clean forgot. Finbar from Ireland.
Thank you. Thanks, Amanda. I just had a question relating to any medical legal aspects of serial photography and then subsequent detection of melanoma, and then somebody complaining that it wasn't picked up sooner when the images may have shown that. Is there any precedence of medical legal problems there?
Well, we miss melanomas all day, every day, and if you think you're not missing them, you're wrong. I pay my medico-legal indemnity fee, and so far I've missed lots of melanomas. They've been brought to my attention, but I haven't been sued. Well, you can't be sued in New Zealand, but
It's a good question.
It's an important issue, and it's terrifying, and I'm glad I work where I do. I wouldn't like to be in the United States. Missed melanoma.
Just saying, in my experience, we're taking photographs for the benefit of the patient, you're pretty safe. If you're practicing defensively, then you may not be safe. But if your motivation and your obvious intent is taking photographs for the benefit of the patient, you don't have too much to worry about. And I've seen people miss things, but when they were challenged in court and they could show they were doing it for the benefit of the patient, they were fine.
Good answer.
Yeah, I think documentation is really important, and documenting why you didn't recommend excision, or being able to retrospectively do so on the basis of what you've received. So for the teledermoscopy service, you'll hear about that later, but we decline if we don't have good confidence. And that relates to image quality.
I can just add, in that process of short-term monitoring, I always give patients the choice of having it excised then or waiting 3 months. And I would do it again at 3 months and document that. So people, explain things with them, explain it well and document it. Okay, I think we've done very, very well with the session. I'm sorry we've run over, but that's just a technical glitch. We've got a few interesting cases next, which we will move on to.
How are we doing this? Are we starting with mine?
We'll just see what comes up.
Cliff's.
And the first one's Cliff. Definitely. There's the signature. So we need to just pop a microphone on Cliff, and he will lead us through. And we'll lead up to lunch, which is 1:45, and that'll get us back on track. So this is great, Cliff. There we go.
Okay. Now, those who were here yesterday have seen this case, but I don't apologise because it's a good case and it's worth seeing again. So this 37-year-old lady with 3 little kids has these 2 pink lesions. Now, what I didn't tell you yesterday was that she brought the one on the right thigh, the lower one, to my attention. She said it was new. So we're going to look at these 2 lesions, and we haven't talked about the way of diagnosing non-pigmented lesions, but I'll go through it here. The first thing you do with any lesion is look at it with a dermatoscope and decide whether you can put it in one of the 5 common disease categories confidently. And those categories are nevus, seborrheic keratosis, hemangioma, dermatofibroma, and sebaceous gland hyperplasia, because most of what you see will be in one of those categories, whether it's pigmented or non-pigmented. Now, the one on the left, which is on the left thigh, can you put it to one of those 5 categories confidently? So those are the 5 categories in non-pigmented variety, and that is actually the lesion I've chosen on the left to show the hemangioma, a clods-only pattern. That's a pattern recognition hemangioma. Notice that some of the clods peripherally are actually apparently lines. So when you've looked at 10,000 hemangiomas, you'll realise that small hemangiomas, the clods at the edge can vary at a linear shape. That's normal. But the ones in the centre will be clods and clods only. Now, the one on the right thigh, can you give that a pattern recognition benign diagnosis of any of those categories? Can anyone call that a nevus or a seb-K or a sebaceous hyperplasia or a hemangioma or a dermatofibroma with confidence? You can't. So, the next thing is we look for, in priority for a non-pigmented lesion of concern, and this is of concern, 1, because the patient's brought to our attention, and 2, because we can't give it a confidence-specific benign diagnosis. So first of all, for a non-pigmented lesion, if you look at the top, we look for ulceration or white clues. And white clues are in any lesion white lines, and in any raised lesion, the SCC clues of keratin scale, white circle or white structures areas. So there's no ulceration. Are there any white clues there? You can see the white lines. You can see the white lines clearly there. They are polarising specific white lines, which means shiny white lines, only seen with polarising dermatoscopy, and they're often at right angles with each other and not crossing. You can also see a 4-dot clot, and that is not a white clue because it's commonly present on benign lesions. But the polarising of specific white lines are a clue to malignancy. Now, they can be seen in BCC, melanoma, Spitz nevus, dermatofibroma, or lichen planus-like keratosis. So, in the context of a lesion of concern, which is not a lichen planus-like keratosis, not a dermatofibroma, and not a Spitz nevus, it's a sign of malignancy. But the context is important. Now, this is just to show you, this is the nodular melanoma, 0.9 millimetres Breslow, or 0.8 millimetres Breslow. And now I'm going to show you the first image with the dermatoscope. Can you see any clues there to malignancy? There are no white lines because this is non-polarised dermatoscopy. Okay? And so all you're seeing is a structureless lesion, which again you can't confidently diagnose. So if you were putting this through the algorithm, which you would do if this is all you had, you say, is there ulceration? No. Are there white clues? No. Is there a benign vessel pattern? No. Because benign vessel patterns are clods only, which hasn't got, centred, serpiginous or reticular. It's not one of those patterns. So you still cut it out. When you put the dermatoscope on it, all you see here is a 4-dot clot. There are no white lines. That line, apparent line, is a hair. There are no white lines there. You've got to rotate the dermatoscope to get the white lines. This is important because polarising specific features change with rotation. They can be from absent to present. And this illustrates that beautifully. That without rotating the dermatoscope, you weren't going to see that clue. Now, is that lesion a pattern recognition one of the 5? Is that a pattern recognition hemangioma? Yes, it is. So the white lines, you ignore them. Okay, it's a pattern recognition hemangioma. And those aren't polarising specific. They are the septae that you often see between the clods of hemangioma. And when you put that beside the melanoma, you can see. The one on the left is a pattern recognition hemangioma. Those white lines are not relevant. There's another lesion with white lines, but it's a pattern recognition hemangioma. And you can only make pattern recognition diagnoses when you've looked at thousands of hemangiomas, thousands of nevi, thousands of sub-Ks, because there are many, many different varieties. But that is the first step in the diagnostic process, learning the pattern recognition appearance of benign lesions. And again, the one on the right has white lines. It's not a pattern recognition hemangioma. So you cut it out. The one on the left is a hemangioma. So that's in the book, which is out there. It's the best book on dermatoscopy in the world, apart from maybe Amanda's. If she has one, it's probably better. But thank you very much.
Thank you, Cliff. Create change. Very good. I'll have 2 microphones now, which will make it interesting. All right. So what's next? Amanda, here we go.
So I've just got some interesting cases really to talk about, and I'll whisk through them because really they're just visual delights. At least I think they are. What happened to that pointing machine? Thank you. Rescued. So we're going to just do some mystery cases and shout out what you think it is. Anyone? Is it a nevus? Is it a melanoma? Okay, well, we didn't know, so we cut it out. And it was a bapoma, which is a misnomer, but it's a nice sounding word. Here's another example. A bapoma is actually a BAP1 inactivated melanocytic tumor, and it's benign. This is another example. So you need to know about that because although this lesion was not malignant, this patient is at risk of malignancy, and uveal melanoma is one of the risk factors, and some other cancers, I think. Here's another example. Odd-looking things that you can't quite call a nevus and feel impelled to excise and are then told a benign lesion. Just ask your pathologist to check BAP1 staining. And this is the histopathology. I'm not a histopathologist, but those cells look a bit odd to me. Case 2. Shall we cut this one out? We did. We have some irregular features consistent with melanoma. It wasn't. This was a nevus. This time it was a deep penetrating sclerosing nevus, again in a young person. And we found another example of a deep penetrating nevus. Was that one of yours, Andrew? I don't think it was Andrew's. I thought it was. Sorry, I haven't acknowledged you on the slide. I suddenly thought, oh, I think that's why it's got black bars around the edge to remind me. Case 3. What shall we do with this one? This looks pretty simple. We're going to ignore it because it is pretty simple. But we ignored it and the patient got referred again. Oh no. What has happened? Any ideas? Laser therapy, good idea. Any other suggestions? A shave excision with recurrence. And that's what actually happened. So I think it's a good idea not to use that procedure unless you're really sure what you're doing, because we were impelled to excise this melanoma-like lesion despite its very benign presentation a short while earlier. Okay, case 4. I can't tell you what this one is because we didn't excise it. Let's have some suggestions. Yeah, maybe. We actually thought it was a blue nevus for various reasons, but we didn't cut it out, so we'll never be able to tell you. And the history was that it was stable. What about this one? I think this one might have come from Andrew as well. Did it, Andrew?
Yes, but I can't remember what it was.
Ah, well, I'll spill the beans. So this is a hemosiderotic dermatofibroma. So we saw one of those. Nisa showed us one of those. Yeah, and they can look very melanoma-like. And if it looks like a melanoma, I suggest you cut it out. You've got lovely negative network here, but this is not a nevus and did not have any melanocytic features. And here's another hemosiderotic dermatofibroma, which was excised and proven to be benign. I wasn't aware of the risk of metastasis, and I'm now really nervous. But as far as I know, these patients are fine. Red lesions are common, and they're really difficult at times. And we don't always have the pathology because I do the diagnosing and don't always get the pathology. And sometimes that's because the lesion has not been excised, and sometimes it's because it's done in St. Elsewhere's, and sometimes you just can't find it. Okay, what about this? What do we think this one is? It looks like a typical squamous cell carcinoma. We've got a colorative scale telling us that it's bouncing out of the skin. We've got central ulceration, and we've got a pink nodule. Absolutely typical. Only it was melanoma. And what about this one? Molluscum contagiosum, trichoepithelioma, basal cell carcinoma, pilomatricoma, and it was a squamous cell carcinoma. So this is just for fun, you know. These things don't actually arise every day, but I do collect them, especially this year, knowing I was giving this talk. How about this one? We have a large nodule. Surely the dermoscopy should show something. It doesn't show a lot, really, does it? I mean, we've got a little bit of redness here, and with some polarized white lines have come in, suggesting we should excise the lesion. Indeed, we did. It was pilomatrixoma. Did you get that one, Nisa? Good girl, isn't she clever? You can come and work in my clinic. We didn't get it. Here's another example of pilomatrixoma, diagnosed on histology, not by dermoscopy. Really, I mean, we're just seeing something that's red with funny vessels and some white lines on it, and we're going to cut it out. The pathologists might find it easy, but clinicians don't. How about this one? You should be able to get a clue because it's, that's funny. Why have I called it 9A? Oh, what? Epidermal cyst. Epidermal cyst. Any other suggestions? I'm sure you're all now nervous to give any suggestions. And this one was an ecrine hydrocystoma. So that's a benign adnexal tumor. But it was a growing erythematous nodule, and we couldn't make a diagnosis of a benign lesion. And we've got white structures and some funny-looking vessels. I found another example of an ecrine benign tumor in my collection. And this one shows the colorative scale because it's recently erupted out of the skin. And here's another one which wasn't called a hydrocystoma, but might have been. The pathologist was not my usual pathologist, and he said ecrine tumor, not otherwise specified, brackets, possible syringoma. It doesn't have the clinical presentation of syringoma, in my opinion. So erythematous nodule, who knows what's going on, some plunny blood vessels and some white spots. Cut it out. How about this one? Here's another red nodule. Are you all confident you know what this one is? Melanoma. It could be. We've got a colorative scale, so it's clearly bursting out of the skin. We've got some funny blood vessels. It wasn't. This was benign and was an inflamed clear cell acanthoma, which is a seborrheic keratosis-like tumor with very nice histology and dermoscopy, but fairly uninteresting clinically. Here's an example of a more typical clear cell acanthoma, just a small pink plaque with a lovely uniform, symmetrical blood vessel pattern characteristic of that condition. Now, how about this? We've got a nodule lateral to the eye, and it's got some branched red lines. And so what have we got? Basal cell carcinoma, I heard that. What else? Well, I've heard lots of things, but none of them made any sense to me. So I'll just tell you what it was. And it was a marginal zone B-cell lymphoma. I bet none of you came up with that. And this is not a tumor that usually arises in the skin, so I had to look it up. Okay, case 12. That one looks easy, doesn't it? Pink nodule, it's ulcerated, it's got very typical BCC, focused, beautiful vessels, but guess what? It wasn't a BCC, it wasn't an SCC, it wasn't a Merkel cell carcinoma, it wasn't a melanoma. Keep trying. Wasn't even a lymphoma.
Any cystotumor, benign or malignant, which pushes the dermal plexus up, it can look like that.
Absolutely, and you're right. So what tumors do we have in the dermis? What are the structures in the dermis? Some ideas coming out? No, I'm not hearing right. You're really not concentrating, you guys. This was a leiomyosarcoma. And none of you came up with that one. And here's its pathology. And just as an extra one, I don't know if any of you have ever heard of this entity, congenital lower lip pits. But this was a shared case on our MolMap group, and one of our clever clots put it into Google Lens, who diagnosed it. So congenital lower lip, well, it didn't diagnose it, but it showed us a picture similar. And so congenital lower lip pits, this was a 17-year-old, there was no history given, we were simply sent the pictures, what did we think? And our minds went blank. But it sounded quite nice, this congenital lower lip pits, and so now you know something I doubt you knew before. So if we've got time, let's rush on with purple lesions. What's this purple lesion? Mainly the pictures to remind you to ask people to remove the hair over lesions, getting a lot of hair. Yep, what kind though? This was an angiokeratoma circumscriptum, a localized angiokeratoma. Late adult onset, well, late teenage years. What about this one? Should be easy. It's shiny. We've got some clues. And it's a purple basal cell carcinoma. So sometimes BCCs are white, sometimes they're pink, sometimes they're gray, sometimes they're brown, sometimes they're black, and sometimes they're purple. And what about this one? Another purple spot. You've run out of ideas, I can tell that. This one surprised me. It was a neurofibroma. I wasn't expecting that. I didn't even require it to be removed. But anyway, that's what it was. So, thank you.
Thank you, Amanda. That's fantastic. We have caught up with time, but you want to do a quick, just hang on, let's see what's here. This is you.
I'll do one case.
Can you?
One case.
You can do two, because I'm sure they'll love two. Come on.
Okay, fantastic,
Yeah,
great.
good man.
Well, I'm jumping in halfway through, so you don't need to know me. I'm not important. I'll
You
introduce
do.
myself in the next talk.
Yes.
But I've got one case to show you. This lady is 54. She came to clinic with this long-standing lesion in her thigh. She's had it for years. But the only reason why the GP referred her is because the lesion has got slightly darker. No symptoms, no family history of melanoma. What do you think? You would think melanoma? But it's been there for so many years. Maybe it could be melanoma in situ and it's becoming invasive. Maybe. Yeah, I mean, that's the thing. What is they zooming in? This thing? Or this thing? So featureless pigmented, hyperpigmented areas through the lesion, I thought maybe melanoma in situ as well. So the surprise was, of course, we excised it quickly as urgent suspected cancer, and it came back as a benign thing called large cell acanthoma. Have you heard of it? I hadn't until I got that lab report in front of me, and I said, what the hell is that? So I haven't heard of large cell acanthoma. I know clear cell acanthoma, obviously, but large cell acanthoma, that was new. And basically, it is a totally benign lesion where the keratinocytes are slightly large in size, but there is absolutely no dysplasia whatsoever. And the dark color is only because of pigmentation in the basal layer. So if you read about it, only a few hundred cases reported in the literature, and it's assumed to be a variant maybe of seborrheic keratosis, but some literature say no, it is a variant of lentigo, solar lentigo, but some of these can be non-pigmented, so it can't be solar lentigo. Solar lentigo. Oh, sorry. How do I go back? I gave it away now, didn't I? Oh no, disaster. Oh, that's the one to go back. Okay. Well, now we know.
What are we doing?
No, this. Keep going back again. Back again. This. No. Back again. This one.
The sharp border of the seborrheic keratosis.
It does look very sharp. Yes, it does. Yes. Well, I thought, could it be seborrheic keratosis because of that? But I think there is these hyperpigmented black blotches, you know. So, yeah, of course, that's one of the reasons why in the literature it says it is a variant of seborrheic keratosis. But I hadn't heard of it completely. Yeah, no, completely. No, completely. Yeah, so it was on the thigh, easy to close it up. So that was just my case. Do I have time for one more? One more?
I'm sure we can have one more.
Well, I'm going to skip this because you all know it. It's lentigo maligna. But this lady is youngish. She's in her mid-40s, and she was referred with this lesion on the right upper eyelid. And if you look at it, what's your impression? Clinically, dermoscopically? SCC. Yeah, or maybe other, sebaceous carcinoma or something similar. But she, sorry? That's it. So she's had it for over a year. For over 1 year, more than 1 year. And it's not tender in South Wales.
Similar cases with
Leishmania. Leishmaniasis, yeah, it's exactly, yeah. So, but there is no history of travel anywhere. No travel to any of the Leishmaniasis common places. So when she came, I thought it's an SCC. I don't feel confident enough to excise that with a 5mm margin. So I brought her to clinic, and I thought, let me take a biopsy. And when she was sitting there, she was just picking like this all the time. So what could it be? Yeah, so it's Picker's nodule. Picker's nodule. Nodular prurigo, just localized solitary prurigo nodule. So I took a small punch biopsy from it just to make sure, and it was Picker's nodule. So just gave her a bit of topical treatment, and that was it. So avoided big excision. I'll stop there, maybe. Should I stop?
Do you want one more case? We want to one more case.
One more case. I think some of you might be very quick to see the diagnosis of this one when I flicked the slide earlier. So pigmented lesion, red lesion on the lower leg, slightly scaly, male patient, 76. The pattern of the blood vessels is Bowenoid-like, would you say? Yeah. So what is it? Is it Bowen's? Would you treat it topically? Dermatofibrosis? Bowen's? Irritated clear cell acanthoma, that age group. Typical site, yes, but it's not that. Melanoma. Who said melanoma? Well done, yeah. So the Bowenoid blood vessels, yes, we agree. These sort of coiled blood vessels everywhere, but the short white lines there worried me, and a little bit of pigment. So I'll be talking later about bones, and if pigmented bones, I always take a biopsy because it's difficult to exclude melanoma. In this case, it was indeed melanoma Breslow 1.2. So that shows you sometimes amelanotic melanoma can be really tricky. Just to rely on the vascular pattern, short white lines, and polarized dermoscopy, that can be very helpful. So that was completely excised. I excised it from the outset. I didn't take a biopsy, and it was a melanoma. So I think probably I will stop here. That's another amelanotic melanoma, again, just to show this whole area has been treated as vitiligo. I mean, solitary vitiligo, just on the arm. But there is this, sorry? Mears yeah, I thought Mears and nevus, inflamed nevus, but it's been there for a long time, and the white area is spreading out. And when we looked at dermoscopy, then all these short white lines and some polymorphous blood vessels there, well, we took an incisional biopsy. I can't remember this one. Yeah. Well, that's a good point. I can't remember the details, to be honest. Sorry? Yes, yes.
When there's halo around the melanoma, probably there's a lymph node metastasis because this is an immune reaction. And if there is lymph node metastasis, immune reaction developed and there is halo around the melanoma. So in patients like this, even if the Breslow is, for example, 0.6, we have to perform PET-CT examination for cases like this.
So in this case, the pathologist said that red part in the middle is the invasive melanoma, and the white pale area around it is melanoma in situ, amelanotic melanoma in situ, lentigo maligna kind of appearance. So it was all melanoma. So we published a paper about 3 years ago, a series of amelanotic melanomas, and we have about 4 of these. They're just pink patches. They're amelanotic lentigo maligna. So yeah, so we've got a couple of these cases, but I'll stop there for the sake of time, and I think we'll come back after lunch. Everyone is hungry. I'm hungry.
Thank you very much for that. A wonderful overview. Nice to have you on board now. There are more. Stephen, how long is your? 2 minutes. We've got a 2 minute, then we'll break for lunch. How's that? We're just short lunch down. I'm sure that's what you're here for. And these are great, juicy cases. Get your brain thinking.
2 minutes. I've got the advancer. Very much. All right. So, great cases. So, somebody was presented with this lesion on his hooter. And so what was the first thing that you think of? What's the first thing you think of? Yeah, obviously, that was the first thing you think of. But I thought, I'm not really quite convinced that this is a BCC. And there's something very interesting there, if you remember something I said earlier. Can you see follicles? Yeah, loads of great big follicles. So if that's sorry? What did Cliff say about Nisa earlier? She's very clever. She's very, very clever. And this was this is the case I showed you earlier. There was no follicles inside. There's loads of follicles here, but on this this other lesion, which sorry. But here, this is a BCC, and there were no follicles. The tumour abolishes the follicles, and that's probably a very obvious observation, but I haven't heard it taught very much, so it's worth thinking about. Okay, B-cell lymphoma. Good job we biopsied it and didn't do a great big operation on him. Okay, anyone want to know what this is? It's a new, I'll tell you what this is. You all know what this is. It's a new pink lesion occurring on elderly white sun-damaged skin. We cut it out quick. Anyone know what it is, though? AFX is, yeah, possible. Any other? BCC is, I guess, possible, yes. Melanoma. Anything can always be a melanoma, I guess, unless proved unless proved otherwise. And I can't see any features here. Yeah, it was Merkel. It was a Merkel cell cancer. Now, this seems to show the polychromasia, so-called rainbow sign, but in the relatively small number of Merkel cell tumours I've seen, this rainbow sign is not very reliable. So this comes under the, as we've heard from various teachers today, new red lump, elderly white sun damaged skin, cut it out quick. Ask your friend, the histopathologist, what it is. Okay, and here's something horrible, said to have developed over a short time. Sorry? Now there's two dermatoscopic images. The one on the left is of the background of this lesion, and the one on the right. I'm told it's a very rare tumour, and it's a pretty bad one to have. So no, I'll just show you some three interesting, uncommon cases. Thank you for being so patient.
Thank you very much. What a great session. Okay, we'll just shorten lunch down. We'll come back in here at 1:45 to 2. All right, so have a lovely lunch. Yes. Lunch, you go out the door here left, go up the corridor, not to where the cup of coffee was, turn right. An afternoon ahead of fun and intrigue, I'm sure. So it's lovely to have Amanda back, and Amanda's going to focus on teledomoscopy. As you know, Amanda birthed this in New Zealand in Waikato, as we spoke about earlier, and she has a huge wealth of experience and knowledge working with the rural GPs around her, and a huge hospital that she works in, handling massive numbers. So it's a wonderful thing, Amanda. It's lovely to have you, and welcome. And here's
Thank you. This talk is really just a taste of teledermoscopy according to my experience. It turns out that not many dermatologists in New Zealand do what I do. That won't surprise anybody. So I'll just tell you something about the New Zealand health system and the use of teledermoscopy for skin lesion referrals in different periods of time. So let's start with definitions. So tele comes from telekinesis, to or at a distance. And dermatology is apparently the branch of medicine concerned with the diagnosis and treatment of skin disorders. So that would suggest that teledermatology was to do with diagnosis and treatment. I couldn't find a dictionary definition of dermoscopy or dermatoscopy. As is the case in the United Kingdom, we come from a background of a severe workforce shortage in dermatology and primary care, not to mention other specialties. Until the 30th of June 2022, we had 20 district health boards, and they were really quite autonomous, and dermatology was very low on the priority list. And historically, they ran us down. Public hospitals are free, but primary care is not. They're private systems that can get subsidies for groups of individuals. For example, children 13 and under consult for free. Private specialists depend on the patient paying up front or having an insurance company that will do that for them. Only about 30% of adults in New Zealand carry any health insurance. Lab tests are free in most places, but I think not everywhere. Prescriptions are free or subsidized or not available because we only have a very small formulary. So Health New Zealand took over on and was called Te Whatu Ora for a bit. And look, in Waikato, we look after 500,000 population in an area of 21,000 kilometres square. It's one of the largest employers, and there are 5 publicly funded dermatologists, resulting in 3.2 full-time equivalents. There's about 200 GPs, terribly underserved. We also provide tertiary services for 1 million, and we can bring up another 1.2 FTE from the rest of the Midland or Te Manawa, Taki area. That is one dermatologist for basically 250,000 people. In the hospital, we receive acute and elective referrals. These include severe skin diseases such as blistering diseases, drug eruptions, terrible eczema, awful psoriasis. And then most of those patients are stuck in our clinics because we put them on difficult drugs, which are not all that useful for many of our patients. We also see a lot of skin cancer. This results in huge waiting lists for appointments. We're a training centre. There are only 3 training centres in the country, and we have 3 new dermatology trainees per annum. It's a bit out of kilter because at the moment, this year, we only had 1 new dermatologist in training, and next year there will be 5 to make up the 6. And we see a lot of medical students. So a typical week in dermatology is looking after extensive, severe inflammatory dermatoses. You will be aware that, as in the UK, the New Zealand population is aging, and the pyramid structure, known as the population pyramid, in 2020 had 10% of people over 65, but now we have 15% of over 65, and I believe in the UK it's higher, and I've got that written down here. It's 18% of the population is over 65, and it's that group that get inflammatory skin diseases and skin cancers. And these people are going to live another 25 years with their skin cancers and inflammatory dermatoses, and will need specialist dermatologic care from an aging dermatologist and general practice workforce. 42% of referrals in the month I looked at, which was April when I was preparing this, were over 65. So aging results in sun damage, accumulative tobacco issues, and lots of skin cancer. We also suffer from obesity, as you do in the UK, subsequently metabolic disease, diabetes, and all these have complications on the skin and block our waiting lists. And then there's a lot of chronic venous disease. That's not new. I think the population over the age of 40 in the 16th century had something like 50% had venous ulceration, including Henry VIII, only that was in 1500 and something. So there's polypharmacy too, and lots and lots of drug eruptions or suspected drug eruptions, which are actually very complicated. And the new drugs, like the immune checkpoint inhibitors, have vastly complicated and difficult inflammatory skin disease complications, not to mention every other organ in the body. So few dermatologists leads to late diagnosis of skin cancer, and even more so, unnecessary excision of benign lesions. The skin cancer statistics, Australia and New Zealand have the highest rates in the world, and our age standardized rates are 53 per 100,000. I don't know why I got percent, that's a bit bizarre, compared with the UK, which is 27.7%. And because we've got an expanding and aging population, the numbers of melanomas, even though the age standardized rates haven't really changed much, have doubled. And now we diagnose a lot of melanomas in situ, which are biologically benign, but they're still important to remove. And we are now removing twice as many of those as we are invasive melanomas. So outpatient clinics in Waikato were overburdened with people with benign skin lesions. We proved that teledermoscopy worked by a couple of studies and persuaded our managers that we could bravely join the modern world and offer a teledermoscopy service, which began in January 2010. At that time, many referrals were for benign lesions. That's not true as much as it was now, I think, because we've trained our GPs and we don't get as high a proportion of benign lesions as we did 14 years ago. We kept our outpatient clinics for complex multi-tumor patients and inflammatory dermatoses. And this was not a joy. We had no break. Every patient coming in has got something dreadful and difficult, and we just don't get the break of having a chat with someone who's got a seborrheic keratosis. We're not a surgical centre at Waikato. We do straightforward surgical procedures, but we're co-located and share nurses with plastics. So between us, we manage a lot of surgical procedures as well. So in those days, I was already experienced as a teledermoscopist because I had been contracted by Molmat New Zealand, a completely private company that had begun in 1997 and was intended for high-risk patients to detect melanoma and for follow-up. It was quite clear that teledermoscopy was very effective, and it was actually easier to make a diagnosis of a skin cancer, especially melanoma, from photographs than it was from examining a patient face to face. So in 2010, we introduced the public teledermoscopy clinic by a public-private partnership, and MolMap provided the service in 3 locations with 10,000 visits over a period of time up till 2019. Now that service is now just from 1 location and has markedly reduced. So the referral criteria for a virtual lesion clinic appointment at that time was an inadequate GP referral with up to 5 skin lesions. And that was usually because they didn't add images. The images were poor quality. And believe it or not, we didn't have electronic referrals in 2010. But we did in 2016, which was our peak year for the virtual lesion clinic. But for funding reasons, the GP was expected to have examined and done a full skin check, and we just did the spot checks by nurse-led clinic. And so here's a nurse in the VLC and the dermatology team. We have it as a teaching exercise on a weekly basis to go through the cases. So if you came to the Waikato, you got a lot of training in teledermoscopy. So the GP would refer, we'd arrange the imaging, the patient would be discharged, monitored, or care at the hospital. If they were discharged to the GP, it was sometimes with topical management of precancerous lesions. And the number of lesions reached a peak in 2016 and then rapidly reduced because the introduction of the electronic medical referral system meant that we now did receive excellent referrals from our GPs, which we will call the now. So since the 1st of July 2017, after we'd got used to the electronic system and written some templates, now the patient can see the GP by phone, or video, or in person, get referred to dermatology, which might be in private or through the hospital, through the suspected skin cancer service, which is basically electronic referrals. E-triage takes place to arrange any treatment if necessary. And MolMap New Zealand still continues in its private capacity, and MolMap have provided me with this data for this talk. They have 47 clinics, and in 2023 they had more than 500,000 lesions evaluated, and for 86,000 of those, an action was recommended. They introduced Kahu over the last couple of years to improve the specificity of the lesions presented to the dermatologists who are paid a per patient / lesion fee. In the hospital system, Kahu is not offered in the virtual lesion clinic. We no longer use the virtual lesion clinic for GP referrals. We now confine the virtual lesion clinic for our surveillance of organ transplant recipients. So a new renal transplant patient is referred to us and to the virtual lesion clinic for a nurse full skin check and photographs of any lesions of concern, that's to say skin cancers or peculiar looking spots. These are all viewed by Waikato Hospital dermatologists. And otherwise, we are looking at the electronic referrals for skin lesions. The referral criteria for the virtual lesion clinic, includes whole body mole mapping for very high risk patients with multiple melanomas. So last week, June turned up. She's had 17 primary melanomas that we know of, and she has had metastatic disease. She is on an immune checkpoint inhibitor, and we found 1 more definite and 3 more possible melanomas through the teledermoscopy service. E-triage means the referrer chooses the urgency and completes a template either for suspected skin cancers or inflammatory diseases and attaches images. For lesions, we expect regional, close-up, and dermoscopy images, preferably polarized and unpolarized. So 2024, actually it's gone up to 700 referrals per month, which is double what it was a few years ago. It's become a bit unmanageable, really. So if a GP suspects skin cancer, they select suspected skin cancer and they select the urgency, and they refer to us, and we will either see the patient if they ask us to do that for surgery, and we'll direct book them for surgery if that's what's needed. Otherwise, the majority, the GP wants to be in control. They just need our advice as to whether the lesion should be excised or not. Usually that's accompanied by a diagnosis, and sometimes we decline because of poor quality referral, but that's really less than 5%. So we ask a few risk factors for cancers. We ask them to describe the lesion according to a template, and we've done some research to show that before and after adding the templates made a difference, and the improvement in quality of referrals was quite impressive once we introduced the templates. And I've recognized that recently because I've just started 2 weeks ago to add teledermoscopy services to a different district where the template is optional, which means the GPs opt out, and I am going decline, 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 because I don't have the information on which to base a diagnosis. I need to know when its onset and duration. I need to know if it's firm or bleeding or ulcerated. So we get adequate to excellent images mostly. Nearly all the GPs in my district can do dermoscopic imaging, and they often do that by asking their practice nurses to do it. So the GP will put a dot beside the lesions that need photographing. The nurse will do the photographs and complete the templates. We know that training improves quality, and we are getting it. So in 2024, we are considering the use of artificial intelligence. It's not there yet. So in May this year, there were 793 referrals, and only 9% got an outpatient clinic appointment. That means the rest were either declined or we gave advice, which is called a non-contact first specialist assessment and is considered equivalent to an outpatient clinic appointment and is funded adequately for that. But we have to give extensive advice. We can't just say, cut it out. We have to give a full report. But now, instead of getting that report the same day, as we were proudly stating 10 years ago, they're waiting weeks to get that care plan sent to them if they're in the non-urgent category. If we do offer a clinic appointment, that's going to be months, so I suppose weeks is better than months. And they're certainly waiting years for follow-up. So you might be on methotrexate, and we say, we'll see you in 3 months, optimistically, and give them an appointment in a year. So I'm sure that's happening here too. So just examples, here's a brief referral from a hospital clinic with absolutely no information of any kind and no photographs, so of course it gets declined. This one is an excellent completed referral with nice pictures of the lesion of concern, and we can fill in the template that you see on the right there in 3 boxes to provide advice as to excision. In 2020, it was changed from decline with advice and a letter that said, "I'm sorry, your appointment has been declined by the dermatologist. Please see your GP." Now they get one, "We're pleased to tell you that you've been accepted for a non-contact first specialist appointment. Please see your GP." That is supposed to be more friendly, and it is coded and funded, which is progress. There's some legal stuff that comes into it, and then the pandemic hit, and we were able to manage very nicely in dermatology at Waikato compared with other centres because we had marvellous photographs of all our patients, not just the ones that have been referred by their GPs, but also we routinely photograph in the outpatient clinic and have really good photographs of nearly all our patients that allowed us to do telephone consults without problems. So the conclusion was it was all working terribly well, and I'm well known for this and been around the world and was president of the International Society of Teledermatology for a few years, ran some conferences. But then, now we are in 2024, and the responses are delayed, and that's causing a big problem. So we've got some successes. We've got great referrals from most of our GPs, fabulous photographs, and we don't need to see many people in the hospital, and we know our GPs and nurses have upskilled tremendously. There's no doubt that patient care is better, sooner, and more convenient. But we cannot cope because we're overworked and burnt out, and we need help. You've heard that before. So how are we going to deal with it? I don't know. It's an ever upward slope, that referral graph, and I can't see it stopping anytime soon. Will technology help? Yes, it will. But how much? I'm not sure, and I'm looking into it. Our vision is that we'll have a dermatology digital hospital powered by AI. This will speed up the ability to provide a care plan to the referrer. We already have started sending the patient by snail mail a diagnosis and information, and we still say, please make an appointment with your GP, but this time we tell them why. And that has to be something. We are looking at whether we can actually do direct prescriptions for patients without them having to make an appointment to go to their GP to get the prescription for the thing we told them in their letter they'd have to get. So this year we're doing research on whether AI could reduce time, could reduce error, increase efficiency, aid training dermatologists, and generally support us. Do we want it? So we're looking at surveying dermatologists, referrers, and patients, and we have 4 studentships funded and ready to go for the summer to work on some of those things. So we're building a project team. We've got the most amazing nationwide experts on digital health, on Maori digital health, on Pacific digital health, on artificial intelligence with international collaborators. And we're creating a standard image data set of our local population with particular emphasis on Maori and Pacific, and skin lesions in older people. So because our skin lesions are not the skin lesions you see in Europe. Our patients are severely sun damaged, and one image might have 3 cancers in it. So this year we are intending, it's sort of, year is running away with us, but we're expecting to test for differential diagnostic algorithms in at least one system. And next year we will be doing more. We're also doing lots of collaborative meetings, usability studies, and getting some grants. I've never asked for grants before, but they're pouring in, so some people believe in it. If only that filling out a grant wasn't such hard work. And you always do it the day before the grant's due. So I'd love to thank my dermatology colleagues who've supported my madness, collaborators and friends worldwide. striving to reduce the burden of skin cancer. Oh, this is just a quick one. Sorry if I'm just allowed to do it. Oh, didn't work.
Didn't work, just go back.
Let's try. How do I click on it?
No.
Oh, it's somebody hasn't embedded it. They
It's
haven't
not embedded.
realized they
All
had
right.
to embed it.
We'll move
Sorry,
on.
that was to show you how the AI works. You're just going to have to imagine it.
No, I'm sure it works really well. Thank you very much, Amanda. That was great overview. And you're doing some wonderful work for not only for New Zealand but for the whole globe. So fantastic. Now, our next speaker is Osama. And before Osama comes up, you come on up, Osama. I'm just going to ask Stephen Hayes to introduce you, even though we've met. It's fine. It's fine.
Thanks. It's a great pleasure to introduce my friend and colleague, Dr. Osama Atwan from Newport in South Wales. He's a consultant dermatologist and has worked with the British Association of Dermatologists and indeed contributed a chapter on dermoscopy to their new book and has published some stuff. He came to my attention when I read a really nice article in the British Journal of Dermatology that had set up what seemed to be a beautiful and was clearly a highly effective teledermatoscopy scheme in South Wales. Clearly, I'm not the only one who thought it was a good scheme because the Welsh Government has asked Osama to roll it out across the whole country. So I thought this is a story that deserved to be told. So thank you very much.
Thank you very much, Stephen, for the kind introduction and for inviting me to be here. It's a great pleasure, and thank you for the Skin Cancer Symposiums for inviting me to be here. It's an honor. So it's great to be back in Manchester. I was here last month for the BAD. I don't know if some of you were in the BAD last month. So my wife is kicking me out of the house now, say, go live in Manchester, then don't come back to the house. So here we are. So I'll be talking about teledermoscopy, and to follow on what Amanda mentioned in the presentation, I think it's a way to find a solution, really, to cope with the pressure we have in secondary care. Just to give you a little bit of background, this is Wales, and that's the map of Wales. And Wales is a small country in the UK, in the southwest, for those who are not familiar. And it rains a lot in Wales. So it rains 364 days a year. And anybody from Wales here today? No? Yeah, because today is sunny in Wales, so nobody decided. So they all decided to stay and enjoy the sun in Wales. But here we are. So that's the map of Wales. So we have 7 health boards in Wales, and each health board is more or less independent. And this is where are we? This is the largest health board there. It's in the north of Wales, and just above that, there is a beautiful area. It's one of the landmarks in the UK called Brecons, towards this side here, Brecon Beacon. It's a beautiful area. And then there is Powys below that, and this is where I work. This is called Aneurin Bevan University Health Board. And for those who don't know, Aneurin Bevan is a Welshman, basically, and he is the founder of the National Health Service in the UK, of the NHS, back in 1948. And that health board is named after him, Aneurin Bevan, and that's a very Welsh name. And the one next to that is Cardiff and Vale in the very south there, and that's where I live. That's where I worked before, in Cardiff University and NHS. So overall, in our health board, this is Aneurin Bevan Health Board. Now we have different areas, different counties, catchment areas, and we serve a population about 630,000 people. We have 3 hospitals in site, so we commute between different hospitals, and that's to provide services for areas, outreach areas. We have 9 whole-time equivalent consultants, and that's, I must say, Amanda, that's almost, sort of double what you have, because that's almost 1 consultant per 100,000 population. And we have 4 Macmillan clinical nurse specialists. Without them, our department would collapse. These nurses are fantastic. They run clinics side by side to us. They do the follow-ups. They do the immune-suppressed patient follow-up annually. They see new patients. Some of them do operations, including head and neck surgery. So we receive about 20,000 referrals a year, and that is a lot. There are challenges like everywhere else, I guess. I'm just stating the obvious here. But there is increase in population. In our health board, there is 10% increase in the population in the last 10 years. About 1 in 5 in Wales are classified as elderly above the age of 65, according to the WHO. I think Amanda mentioned 18% in the UK. In Wales, the elderly population is higher than the rest of the UK. So as a result, there is increased risk of skin cancer, which is doubled in the last 10 years, including early melanomas, lentigo malignas, BCCs, etc. To add to that, the majority of the referrals we get from primary care are urgent suspected cancer, i.e. melanoma or squamous cell carcinoma or Merkel cell or these weird rare tumors. The quality of referrals is getting worse and worse. We don't have a lot of information. Some of the referrals come from non-GPs and non-nurses, including clinical pharmacists and paramedics and physician associates with no experience in dermatology whatsoever. And we look at the majority of the urgent suspected cancer referrals. These are benign stuff. So only about 10% are true urgent melanoma or squamous cell carcinoma. The rest, the 90%, the main bulk of the referrals is benign stuff or non-urgent, meaning BCC, for example, on the arm or something. The shortage of dermatologists everywhere. I think in the UK at the moment we have about 200 vacant consultant dermatology posts. So it's unsustainable. We cannot function the same way we functioned 20 years ago. From the patient's perspective now, imagine if you are a patient or you have a relative who's 70 or 80 years old, who's got a hospital appointment to come from Aberystwyth, from that area in the north, to the hospital in the south, about an hour and a half drive. Or if you don't drive, of course, you rely on family members to take you to the hospital, or you take a bus journey that will take double that time, then to be told by a dermatologist, oh, don't worry, it's a seborrheic keratosis, you can go back home. So it's not right. It's just not right. So there has to be something to be done. Is teledermatology, meaning images without dermoscopy, is that a solution? Who is able to discharge these 3 patients from these images? Anybody? No, we can't. So it's not a solution. So clinical images alone is not enough. And we know that. One, because there is evidence to say that. So there is this study in the Blue Journal in JAD a few years ago to say teledermoscopy is superior to teledermatology without dermoscopic images. So there is evidence to prove it. But also in the UK, our sort of Bible is NICE. What we follow is NICE guidance, National Institute of Clinical Excellence, and the BED recommendation to say every pigmented skin lesion must be assessed dermoscopically. So we must have dermoscopy. So we need to follow these guidance. So I know then from these images, the one on the left there is this one here is a benign junctional nevus. I don't need to worry about it. The one in the middle is a benign globular nevus. I don't need to worry about it. The one on the far right is the lentigo maligna. That is the one that needs excision. So without dermoscopy, you can't tell. So that's a proof that we need it. Not only for pigmented lesions, what about non-pigmented lesions? Would you discharge these 2 patients? Are they subcase or seborrheic keratoses? Viral wart? Something else? Difficult, isn't it? So with dermoscopy, we will know the one on the left-hand side is a seborrheic keratosis, non-pigmented seborrheic keratosis. The one on the right is a nodular amelanotic melanoma with Breslow 4 millimeter in a 40-year-old female. So that can be easily missed without dermoscopy. So I have to give credit when it's due, and this is Dr. Caroline Mills, one of the consultants in Anirudh Bevan Health Board, and she was the one who found teledermoscopy in 2013. I was very young then. I was not even a consultant, and she started this service in Anirudh Bevan back then. So this is the pathway. This is what we do. The GP will send a skin lesion referral to us, electronic referral, and we triage the referral and we decide what we need to do with it. If we think that the referral is suitable for teledermoscopy, we push the referral through to the medical photography unit. We don't bring them to us. They don't see a nurse. They don't see a registrar. They see a clinical photographer. So they go to have clinical and dermoscopic images taken. And what else, what better quality can you get from having an experienced clinical photographer? I think they take better pictures than me or anyone else, knowing what they do. For that, then we need clinical photographers, and we need a portal. We call it medical images management system, then to upload these images and to store them in the patient record. We need hubs for the clinical photographers to go in the community and take photographs of referred patients. The images then will be uploaded, and these are stored electronically for remote access for the consultants to access these images, to look at them, to report on them, to make an action plan. And for that reason, then I need to decide what I'm going to do with this referral. So it needs to be part of my job plan. It can't be ad hoc. It can't be in the evening or the weekend. It has to be part of my job. So it needs to be integrated in the job plan. I'll talk about that in a minute. And what we'll do then is make a decision. We can discharge that patient if it's a benign nevus or a seborrheic keratosis. We can book them directly for surgery. We can say this is a basal cell carcinoma, low-risk skin cancer, blah, 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 send them an information leaflet to the patient and book them straight to come to surgery. I know it's not urgent. They can wait 6 months for surgery. It's a BCC. If it's a melanoma or a urgent suspected melanoma, I would say, well, it's a mole that looks suspicious. We will arrange to remove it surgically. I don't need to see the patient until I get the result to discuss it and break the bad news. So we can do that. We can book directly for surgery. We can refer to also to avoid the bottleneck situation. We networked with a lot of GPs in the community. We have about 7 GPs in the health board to do surgery for us. And for any low-risk things below the neck, below the clavicle, BCCs or irritated sepcase or Bowens or anything like that, we can send them to GPs to do the procedures for them. They don't really need to come to the hospital for an appointment in the outpatients or the minor ops. And if it's a complicated BCC near the canthus or a massive SCC covering the whole ear, I don't need to see them in dermatology. I'm not going to excise it. I'll send them to the right people to excise it. I'll make a diagnosis, but I'll send them to oculoplastics or maxillofacial surgeons. So I would save the dermatologist slot. If I'm not sure and I need to see them in clinic, I'll book them in my clinic, depending on the urgency, in a couple of weeks or 3-4 months for re-examination. More than 3 lesions are excluded. They need to be seen in clinic for full examination. Genital area, we don't send them for teledermoscopy. We bring them to clinic. Any subcutaneous lesions, lumps, cysts, they need to be seen and assessed to feel the area, because photograph doesn't show you nothing. Anything weeping or underdressing, for example. And sometimes we exclude if it's a hair-bearing site and it's not clear to say the patient is bald, male, or whatever, then we're not sure. We bring them to a face-to-face clinic as well. Immunosuppressed patients, or if they had melanoma before, we tend to see them in clinic. So what we've done then is, this is our health board, where you see OPD, that's where we have hospitals, secondary care. We have consultants almost every day in these hospitals. Where you see the digital camera, that's the hubs for the clinical photographers to go out in the community to take photographs of patients who are referred from this area. We see them locally closer to home. And in this area, we see them locally closer to home to take photographs, instead of a 90-year-old patient driving an hour to have a photograph taken. And where you see a scalpel, that's supposed to be a scalpel, by the way, not a pen. So these scalpels, these are the GPs in the community who do surgeries. So if we see a BCC in a patient there in the north, we ask a local GP to see the patient and treat it for them, rather than coming to the hospital. The number of referrals increased year on year. Now, on average, we see about 7,500 patients a year, only in teledermoscopy clinic alone. Of course, the benefits in my normal clinic, face-to-face clinic, I normally see about 14 patients, 12 to 14 patients. Based on the BAD job planning for consultants, teledermatology assessment is about 24 patients for one session. So instead of one session for me in the hospital to see 12 patients, I do 24 patients in teledermatology. So that's double my capacity, double the productivity. And it's a diagnostic service closer to patients' home. It's efficient because we prioritize accordingly the urgency. We send them to other specialties if needed. We utilize the outpatients appropriately. And we peer review cases. A lot of times I see challenging cases like that large cell acanthoma thing. I send it to 3 other consultants, just told them, what do you think? So you don't have that opportunity in clinic. You're on your own, you have to make a decision there and then. But with that, there is an opportunity for peer reviewing. We learn from each other. Standardized digital monitoring. And of course, it's a resource. Now, teledermatology and dermoscopy are finally part of the dermatology training curriculum in the UK. We caught up late after Europe, but in the 2021 curriculum, it's updated now. So teledermatology and dermoscopy are in the curriculum. So it's compulsory. So we did a study published a few years ago, written by one of our registrars at that point, Dr. Lowe, and we showed that we diverted 86% of the skin lesion referrals away from the outpatients. About 50% of those were discharged straight away because they were benign stuff, but the others were forwarded to plastics or maxillofacial or oculoplastics, or orthopedics for stuff on the nail, for example, myxoid cysts, etc. And we demonstrated through the finance team that we saved a big amount of money by doing it that way. So far, we've seen over 50,000 patients, and we see USC and routine. And we use the same model to develop something called tele-LEDs, and that's for ophthalmologists to see lesions on the eyelids and meibomian cysts and what have you, and tele-ENT, where the clinical photographers use the otoscopes to take pictures of the eardrums for the ENT surgeons to look at it remotely. So we've done that. We presented this in the BAD here in Manchester last month to show our teledermatology reporting outcome that it's fascinating, isn't it? Seborrheic keratosis, about 26, 27%, whether it's USC urgent suspected cancer or routine referral, is the same. So it doesn't make any difference. And more or less BCC is the same across all groups. Actinic keratosis, not much different. But if you look at the other category, the true urgent suspected melanoma or squamous cell carcinoma, about 5% of the routine referrals included suspected melanoma. Imagine these patients waiting a year for a hospital appointment. So it's a quicker way to filter through these patients. So based on that, we won last year a couple of awards from Quality in Care Dermatology in the Royal College of Physicians in London, and another award a couple of months after that. So it was a double treat within a short space of time. So based on that, then the Welsh government said, well, hang on a minute, why don't we do this across all Wales? So I changed the title of my presentation from how it works in South Wales to how it works in all Wales, because now it is operational in all Wales. So the Welsh government funded this over 2 years, and they gave us about £800,000, and I was appointed as a clinical lead to make this happen across Wales. And we used that money. So I created this guidance for planning and implementation guide, how the standards should be set when we create a teledermoscopy service. And it is, to cut the story short, it is operational in all the health boards in Wales now. But there is a problem. In this health board here, Powys, they do not have a single dermatologist, a substantive dermatologist. So we thought, well, it's difficult. So what we'll do is we funded them to buy cameras, and I'm not affiliated with any dermoscopic making companies. We bought them, or they bought the Casio cameras, which is integrated camera with a dermatoscope. The quality, we tested it before. We compared the quality of the images of the Casio compared to Heine, Dermlight, and Opticlar. And we found no difference in the dermoscopic images. And we thought, well, it's easy. You know, anybody can use it to take good images, so they don't need to be trained to take, you know, use the adapter with the digital camera and fiddle with the dermatoscope. And so it takes polarized, non-polarized, and the black and white. So they bought the cameras and they send the photographs with the referral to us. So it is teledermoscopy. The other problem is this health board in West Wales called Hywel Dda, where they haven't been able to recruit dermatologists for the last 6 or 7 years. They have 2 plastic surgeons, 1 locum, and 2 middle grade dermatology doctors, but there is no one to take ownership of the teledermoscopy service. So we thought, well, hang on a minute. Why do they need to be disadvantaged because there is no dermatologist there? I can be reporting on the images from West Wales if I'm sitting somewhere in the Caribbean or something, you know? So it's a remote service, so anyone can access these images if they have the rights to access them. So they've set up 3 hubs in the West Wales region, and the images are accessed by dermatologists in other areas in Wales, in Cardiff, in Southeast Wales, in Newport, and we support them despite not having a local dermatologist there. So we created this group called STAR Group, which is Supportive Teledermoscopy Ad Hoc Reporting Group. It took me a week to come with that acronym, you know, just to make it appealing for people to join. And we've got 4 people at the moment supporting West Wales by doing this. And our next mission now, which hopefully in the next couple of weeks, this is the electronic portal for our patients. So all the information, the letters, results, x-rays, whatever, you name it, is there. So we're going to add an icon, a tab in that to include one link for the photographs to be accessed from the medical images portal straight away to the patient portal here. So that's our next project now, which hopefully will be achieved in the next 2-3 weeks. Just to mention, I finished almost. There is a lot of work happening in the UK overall about this, not just Wales. So Dr. Julia Scorfield is taking a lead on this in the BAD, in the British Association of Dermatologists. And I'm part of the BAD Teledermatology Working Group party. So we're engaged in these discussions all the time about how to implement a similar model to what we do in Wales across the whole of the UK. The thought process is maybe they will be using nurses to take photographs or healthcare professionals or healthcare assistants rather than clinical photographers. My concern is the quality of the images. What someone said, you know, a good photograph speaks 1,000 words. If the photograph is not great enough, maybe if it says 500 words, that's good enough. I think that's totally wrong. I think if it's not good enough, it means it's not good enough. It needs to be a good photograph to make that confident decision and not to miss things. So it needs to be quality in to produce quality out. So it needs to be good quality dermoscopic images. We need to use technology, i.e. telecommunication, digital photography services, and personnel, you know. So if there are nurses, there is no right or wrong. I think, you know, a nurse can take a photograph and screen the patient, but I would rather the nurse sit with me in the clinic to see a list of patients, follow up all the melanoma patients, see the immunocompromised patients, rather than taking photographs. There are other people who can do that. And I think we need to set the standards to be, sort of not compromised, and to make sure it's consistent, you know, if we run a national service like this. A long list of people, I can't take another half an hour to thank every one of them, but it's just who helped me across the way. It's a teamwork, it's not me. It's a teamwork, and everybody in that, from the Welsh Government to the Digital Health and Care Wales people, to the clinical lead, to the medical photographers, the IT people, everyone helped us to achieve what we wanted to achieve, so I thank all of them. And that's my email. If you're interested at any point, just reach out. Thank you.
Thank you, Ram. That was fantastic. Is there any burning questions? We've got a few minutes. Yeah, over the top.
You mentioned that you use teledermatology in your patch, but in the
in one.
The quality of the camera, is it as good? Is it acceptable?
So we tested the camera. So we used in our clinical photography service, we were interested. So any new gadget for UV images, we try it. For any new dermatoscope that comes out, we try it. And we tried all the dermatoscopes that you can think of to take good images. And we used, of course, the Casio camera as part of that test. And we found the clinical images are not the best because it's not a DSLR digital camera as such, but it's good enough, I think, clinically. It looks a little bit warm, but the dermoscopic images, we found them no difference from using dermatoscopes, such as Opticlar or Heine or Dermite.
So, is a clinician using it or a medical photographer using it?
So in these GP practices where they have the camera, normally they send the patient to see a nurse, and the nurse takes the photograph, and they upload the photographs with the referral. Some GPs take the photos themselves, but for my GP colleagues here, you only have 10 minutes per patient in GP practice, so you don't really have the time. But one of the healthcare assistants it's dead easy to use it, dead easy, to get that quality.
On the receiving end, you're processing the referral. Have you thought about, or do you train non-consultant dermatologists to process the images? For example, a GP with extended role or a specialist nurse. If so, is there a standard approach, chaos includes 3-point checklist, just to standardize and ensure safety?
Yeah. So the question was, can we train someone who is not a consultant dermatologist to go through the referrals with the images? We do. So I have, in my reporting, I do a list every week. So I've got a 24 patient every week. And I have a registrar with me. The registrar will see 10 patients and I'll see the rest. The images, I mean. And the registrar will come to me to say, this is the referral, this is the image. I think it's a seborrheic keratosis. I ask her why. She tells me why she thinks it's seborrheic keratosis. I say I agree, and she will process that. The nurses are, to some extent, they can't make that decision without consulting with a consultant. So they will have to discuss it with a consultant anyway. So we can't just give the list of patients to a nurse or a registrar to go through them. So the responsibility is on us, on the consultants. So we have to see all the referrals ourselves in the end. So it can be through registrars or nurses, but they have to be discussed with us to make that final decision.
Amanda was next.
I've got 2 comments. Firstly, on the camera. So MolMap used to make its own cameras because there wasn't anything suitable. And the camera that was produced by 3Gen called the MolCam was actually designed by MolMap.
Okay.
Then they couldn't get parts during COVID, and they've moved to the Casio. But they've had to open every box and change them to improve that macro images, and didn't get much help from Casio actually. But they do use it in all 45 clinics. They've got about 100 of these cameras, if not more.
The Casio cameras.
The Casio cameras, and I diagnose them without problem. In fact, I prefer the current clinical pictures to what we had before.
Yeah.
But they use an SLR for the regional views.
Yeah.
The second question is regarding training. So we have 6 computers in one room, and the dermatologists will have the registrars next door, and we also have a medical officer, i.e. a gypsy, who does skin lesion assessments. But I absolutely agree, this is really important, and a dermatologist, an experienced dermatologist at that, needs to be signing off.
Yeah, I agree. And I think in 2022, we launched a new program in Wales. Well, I did. And that was called All Wales Monthly Dermoscopy Teaching Program. That's for any healthcare professional. Dermatology registrar, nurse, GPs, Max Fax, anyone who's interested to come online once a month. We do 1 hour teaching every month for all Wales. Because we know in some areas, especially now they're starting, In some areas, they don't have that expertise, and everybody, I think, should be equipped with the skills to do the diagnosis. So we do this every month for the last 3 years now. So
One last question, yeah.
Back.
Sorry.
Getting back to your job plan, I was looking at that with interest on your job plan. Excuse me. We've in Blackburn, we've developed our teledermatology service, and I liked your template for your referrals, but it's only, as you said, it's only as good as the information that's put in. We've also had a perfect storm where we've had Cerner introduced with electronic patient record management, which has slowed all the clinics down and everything. Our managers also, not being disrespectful to them, see this as a cash cow to try and increase productivity at the expense of overbooking clinics. I wanted to know how you manage your workload when some of the service doesn't support you doing this, because we're quite capable of the clinicians of rattling through, but sometimes it's unmanageable, particularly also when patients come in and say, oh, I've got something else I'd like you to look at.
Yeah, I totally agree with you, and I feel for you. I know exactly what you're going through. A couple of points. One, if the patient comes in, the appointment letter we send to the patient to have photographs to say, you're not going to see a doctor, you're not going to see a nurse. The photographer is not allowed to take photographs of anything else on your body. If you're concerned, go back to your GP. Secondary care is not a screening service. It's not designed to, it's not meant to, it can't survive. That's one thing. The other thing is, one of the big things that helps is I have a see and treat clinic, one-stop clinic. So the patient comes in from teledermatology or new referral or whatever. They have an SCC on the cheek. They go next door. I've got a doctor working with me next door. Normally, a GP with special interest. Working next door, they have it excised on the spot. And the patient comes in, have the treatment, and they go home. So I don't need to create a lot of backlog on the minor op waiting list then. If they need CNC, why should I book them on a minor surgery slot? CNC will take me literally 5 minutes, isn't it? So they can have it done in the clinic next door. But I know the challenges. You need space, you need staffing, you need a nurse. So it needs to be set up for that purpose. It needs to be funded. And having GPs in the community is massive. So we send about 7% of that 5,000 patients, 7% go out to the community for GPs to do the procedures for us. And that's the way to try to tackle it. But instead of doing one clinic, I do one teledermatology, and that's 24 patients every week.
Okay, we're running short of time. Very quick, Kate, and then there's one
quick
here.
question from someone online. It says, thank you for the excellent talk. We have implemented a med photo-based teledermatology service with 5 of us running this clinic at a time, extra pair of eyes when needed. Their question is, what are your thoughts on the use of AI without second reads, which is being pushed by the NHSE? And I don't know what that is.
That's NHS England. So right, okay, well, as I said, I'm part of the BAD teledermatology working group, and there are things I'm not allowed maybe to divulge information that's not meant to be in public. But I think there is a lot of talk, and we're waiting, everybody in the UK now, everybody is waiting for nice guidance to come out on AI. And that was meant to be April, it was delayed to July, and then they had more questions, and now we've been told it will be October, when NICE is going to publish the new guidance about AI, and we will see what that says. So whether AI can be autonomous and make a diagnosis without a dermatologist doing a second read, we need to see the evidence for that as a safe intervention. So far as I'm aware, I can't see that evidence yet, but I think NICE is doing all the examination for the evidence and the data at the moment. I think the biggest AI provider, we were talking about that with Amanda earlier, I think they submitted more data based on, I don't know how many, tens of thousands of cases. So I think we're just waiting for the evidence, the guidance to come out from NICE in the next few weeks, hopefully.
Okay, thank you very much for that. It was wonderful. Would you have a comment or a quick question? You'd be very quick.
So I'm a clinical lead. We've
We don't know how it's going to go, but we've commissioned a service called Isla Care, a platform. And what they do, which is I think very interesting, is that they allow you to upload your images. But if the image isn't of good enough quality, it's rejected. So it kind of makes sure that only good quality images get through to the dermatologist.
Yeah.
So we'll wait and see how it works. But I think we'll get around some of the issues.
Excellent.
Because medical photography is actually a very resource expensive way of doing it.
Thanks for your comments, and thank you, Obama. It was a wonderful presentation, and it's cutting-edge stuff, and congratulations to you and your team for the wonderful work you've been doing in Wales. And we will move forward now to Cliff, who's ready to rock and roll.
Thank you very much. That was great. It's been a very interesting afternoon. Now, photographic technology. Who employs photographic technology for monitoring or baseline total body photography or total body photography with detection software? That's what we're talking about. And this is my experience over 48 years. And you can see here, for the first period of time, for the first 30 years, I didn't find very many melanomas at all as a general practitioner. And then in 2005, I started using dermatoscopy, and it made a big difference. So 1,032 of those melanomas were in the last 17 years. So that's from when I have data using the Skin Cancer Audit Research Database. And you can see there, the ones with the bar around them are where I was using photographic technology. So the thing about melanomas, as Amanda was talking about earlier, is we start from something very small on the left-hand side, we end up with something very big. Is it actually a precursor on the left-hand side, or is it a very small melanoma? And from using monitoring, we can get some insights into the situation. Now, targeted monitoring, where you look at a lesion and you decide to monitor it rather than cutting it out, does involve some theoretical risk of monitoring a lesion which may metastasize. To avoid that, we monitor only flat lesions with low risk based on morphology, which means only reticular or structureless pattern lesions, not clot pattern because they grow faster. And we need a flawless recall protocol. And we should always offer the patient the option of an excision rather than monitoring, and we should document that. Now, here's an example of a lesion which looks pretty innocuous on a young lady. That's the baseline dermatoscopy in June 2010, and really it doesn't look like much. There's not too much suspicious about that lesion. We monitor it for a few months and you can see there's definite progressive change, and that was excised, it was melanoma in situ. Another one, a very small lesion. Now, this is being monitored because of the geometric cutaneous melanoma sign. You can see those sharp angles, like a triangle, okay? This is unusual in nevus. And so I decided to monitor this from 2015 for 6 months, and you can see definite progressive change. And this was excised melanoma in situ. The scalp. It's very important to examine under hair, right? Because if you get a melanoma on the scalp which is invasive, the relative risk is 4. It's 4 times more likely to kill the patient than at the reference area on the back. So we always examine the scalp. And this lesion looked like nothing. But you couldn't call it a nevus because it didn't have the right border for a nevus. You couldn't call it a sol lentigo. It didn't have the right border for sol lentigo. So we monitored it for a year, and it showed progressive change. Still totally featureless as far as melanoma-specific criteria, but melanoma in situ. And that's right on the left-hand side of that timeline where you can't diagnose without photographic monitoring. You can't diagnose that by dermatoscopy. Whereas the ones on the right you can diagnose by dermatoscopy. Now this young lady came in, and as I always say to my patients, is there anything that's new that you're concerned about because you had a past history of melanoma? She said, yes, this is new. So, dermatoscopy, nothing. As far as I'm concerned, there's nothing there. But it's a lesion of concern. And I can't give it a confident diagnosis of nevus because of her history she's given me, that it's new at mature age, 37 years old. So I monitored it 5 months. Chaos, white lines, and that's an invasive melanoma. So that's getting a bit scary because this isn't just an in situ melanoma, and it could have been invasive when I first saw her. So Breslow thickness 0.3, never ignore your patient. They might tell you a pack of lies, but don't ignore them. Now if they say it's new, then until you prove it's not changing, it's new. So this is right on the left-hand side of the timeline. You can't diagnose that without photographic technology. Now, Finbar is going to visit a dermatologist in Australia shortly who doesn't believe in photographic technology at all. He doesn't use it, and he's proud of the fact that he's published. I won't say his name, but Finbar knows who he is. So when you talk to him and he tells you that it's rubbish, this monitoring, you'll say you've seen Cliff present about photographic technology. Now, this is random monitoring at no risk to the patient. This young lady has lots and lots, a couple of hundred pigmented skin lesions. She's the one whose father died a week before she was born. She's a twin. And as I just selected 75 random lesions to monitor, I just randomly picked them, and that was one of them. That was 2009. You can see it's a Molmax image. It's low quality because that's the Molmax that I paid $40,000 for, my first Dermatoscope in 2005. But that's a photograph. And then I monitored it, and look, it's changing. Now in 2013, okay, well, it's still symmetrical. I wasn't really worried about it. But in 2016, I couldn't ignore it. I excised it, and it was a melanoma in situ, still, after all that time. Right back on the left-hand side of the timeline, no clues to malignancy in that lesion at all. Now, this is random monitoring of a high-risk patient, young lady, 25, and I randomly monitored 6 lesions. And I got really lucky because one of those had a melanoma rise in it at 6 months. Not at 3 months, but at 6 months. Which one? Who says A? Who says A? Who says B? Who says C? Who says D? Who says E? F? So F's a cobblestone congenital nevus. They're all congenital nevi, but D, this guy down here put his hand up high, sitting next to Margie, I forget his name, but he picked it. I don't know how he picked it, because there's nothing about that lesion that would tell you it's going to have a melanoma rise in it. And there it is. You can see the melanoma at the top, and you can see the junction at the bottom between the melanoma and the nevus, okay? And that's the most bland nevus you'll ever see there at the bottom. There's no dysplastic features histologically in that nevus at all. And there's an absolute sharp demarcation. The nevus did not turn into a melanoma. That doesn't happen. The melanoma arose in a totally bland, just congenital nevus, and you can see the little cluster of peripheral black clods at the top. And that's the only dermatoscopic clue. There's a melanoma in situ. That's a fantastic set of photos. And I just got really lucky. And that's right on the left. There's nothing about that nevus. I don't know how you picked it, but yeah, you did well. Now, baseline reference. We offer all our patients baseline total body photography with Photo Finder. And this is an example of a lesion which has arisen on a 49-year-old male in his left popliteal fossa. It's completely symmetrical. There's nothing suspicious about that. And we compare it to the total body photography from 5 years before. So 6 years before, and it's not there. Now, the difference in the colour balance is because it's 2 different cameras, total body photography on one and the Photo Finder on the other, and you can see no lesion there previously. So this suddenly becomes a lesion of concern. We examine the patient with the total body photography images open. Superficial spreading melanoma, Breslow, already 0.5, totally symmetrical. Right back on the left-hand side of the timeline. This lady, she's 56. This lesion, chaos or no chaos? Perfectly symmetrical, biologically symmetrical, structures in the centre, peripheral clods around the outside. Clues to malignancy? Okay. With chaos, clues and exceptions, it's got no chaos, you can forget about chaos and clues, but you must go through to exceptions before you discard it. And the first exception is any changing lesion on an adult, right? So any lesion, whether it's symmetrical or asymmetrical, if it's a changing lesion on an adult and you can't give it a diagnosis, a benign diagnosis specifically and competently, you must cut it out. This is a growing lesion on an adult. How do I know that? Peripheral clods. Peripheral clods, peripheral radiolines or peripheral pseudopods are all evidence that the lesion is changing. So this was excised. We went back and compared it to a year before and look at the difference. So that confirmed it was changing. Having the baseline photography was absolute compelling evidence that this was a melanoma, which it wasn't, it was invasive. Breslow 0.3, totally symmetrical, invasive melanoma. Right on the left-hand side of the timeline. Now, this is a completely non-pigmented lesion. And she has pointed it out. She's pointed both these lesions out, where you see the two arrows. And so they become lesions of concern. And we'll just look at the top one. It's a lesion of concern because she's pointed it out. Has it got ulceration? That's the first thing with prediction without pigment. No ulceration. Has it got white clues, white lines in a flat lesion? That's the only clue you're looking for in a flat lesion. No white lines. Has it got a benign vessel pattern? Is the pattern clods only or centered or serpiginous or reticular? No, you've got to cut it out. That's prediction without pigment. Now we go back and look at the baseline total body photography from 4 years before. There it is. So it's not a mosquito bite. So it could have been a mosquito bite, but it's not a mosquito bite. It could have been something inflammatory, but it's not, because it was there and it's changed ever so slightly. That's an amelanotic superficial spreading, Breslow thickness 0.3. Right? This stuff's all in the book, which is available out there. Now, while I'm talking about out there, has anyone today bought a Heine Delta 30 dermatoscope? Did you buy the Delta 30 or the Delta 30 Pro? Didn't buy the dermatoscope. Has anyone bought a dermatoscope out there today? Because the Heine Delta you have, did you buy a Delta 30 or a Delta 30 Pro? The Delta 30 doesn't show polarizing specific white lines. Did he tell you that? I told him he had to tell everybody. So you go back out and change it for a Delta 30 Pro. Because the Heine Delta 30 doesn't show polarizing specific white lines at all. It's a Rolls Royce with a faulty airbag. So you make sure that, and if you have a problem, you get me, and I'll sort it out for you. I thought I'd mention that because I saw them trying to sell the Heine Delta 30 out there. And I was the one who pointed out that it didn't work, and they had to develop the Delta 30 Pro because of that. Okay, this is a lesion on a 40, so these are all young people, right? This guy's 43. Like, that's young, isn't it? 43. Are you 40 yet, Finbar? Okay. So here it is. Okay, it's a little bit suspicious. There's some chaos and there's a few peripheral clods, right? But we'll go back and compare it to the baseline total body photography, and it's changed a lot in 4 years. Okay, Breslow thickness 0.3. Really valuable to have those earlier photos. Really valuable. This one's across the middle of that timeline. You can diagnose it with a dermatoscope. Now, total body photography for the detection, no risk to the patient. You tell Jim Muir that, Finbar, that there's no risk to the patient with most of the types of photographic technology. He doesn't use any of this. This is the first paper we published on the detection. This is rat drug from America. And there's the lesion there. That's when it was diagnosed. But it was present 3 months earlier and just present 6 months earlier. And there it is, pretty well featureless on dermatoscopy. Well, there's no real clues there, but it's a definite melanoma on the dermatopathology. There's no equivocation about that. And that's right back on the left-hand side of the timeline. Here's one of my patients. Now, the photo finder has flagged that lesion as new. Let's go back and look. The photo finder's compared it to that one, and the photo finder hasn't seen that one, so it's called that one new. But you can see there, 5 years earlier, there's a tiny little dot at that spot. This guy's 41. This is a really young guy. His mother's Chinese, 100% Chinese. Dad is from your land, from Ireland. Right? He's an Irishman, born in Australia. When you've got a name like Finbar McGrady, with an Irish accent, you're safe as a bank. But this Finbar McGrady had a broad Australian accent. His father. He's had 18 melanomas, this guy's father, okay? But he's got his mum's Chinese skin. That's the melanoma. Now, if you put your dermatoscope on it, you will diagnose it because it's chaotic. It's got radial lines at the bottom. It's got a bit of grey at the top. But would you have put your dermatoscope on it? That's the important thing. And with total body photography with detection, you had no choice. That was a nodular melanoma, Breslow 1.9. Now, this shows us something interesting too. We can see that not all nodular melanomas grow fast. That one's grown pretty slowly over several years. Detection software is great. Now, this young lady, she's one of the ones whose dad died a week before she was born. And now I've been looking after her from 2009 until now, and this is just 2022. This is just a couple of years ago. That lesion on the right, would anyone think that was a dangerous lesion? Would you see any concerning features about that lesion on the right? Okay. Well, there's the software. That's the recent one. That one there is from 4 years earlier. You can see it's changed. The photo finder hasn't picked it up. My nurse has, right? Because I give my patients to my nurse for an hour and a half when they do this detection, and I just expect her to run the software, check all the things that the software flags, discard the SEBKs, the bits of fluff, the pimples, right? And bring the patient to me with sticky arrows on the ones that they're concerned about. And she was doing more than I'd asked her to do. She was sitting down, comparing the pictures manually, side by side herself, and she picked that up. Now, is this important? Breslow thickness 0.3. Now, I've been looking after these girls from 2009, whose father died a week before they were born. They've had multiple melanomas between them. We'll see those in a later session today. And this could have been the undoing of one of them, this lesion. We would never have picked that without the total body photography and my nurse comparing side by side. I wouldn't have picked that. And I doubt that anyone here would have picked that as a lesion of concern. And that's just to show it was an invasive melanoma. No question about it. That's my nurse. And if she's here, I'd ask her to stand up, but she's not here. And she is worth her weight in gold. And my nurses, I work with them. I examine my patients with them. They are much better than I am, and I'm the one that gets all the credit for it. So this is right back on the left-hand side of the timeline. Now, in my practice, of melanomas detected in the last 17 years, 15% were detected by photographic technology. Of the symmetrical melanomas I diagnosed, 27% were detected by photographic technology. In my practice, 24,063 lesions excised over the last 17 years. And of all of those, 2% were detected by technology. Of the lesions tested to check for melanoma, 13% I used photographic technology. And when you divide the 1,032 melanomas into the 4,010 lesions detected, you see the number needed to treat was 3.9 over that period of time. So for every 3.9 lesions excised, there was one melanoma. Now, these are my monitored lesions over that 17-year period. And you can see 3,618 lesions monitored and 3,158 excisions avoided, 3,100 scars prevented. And 10% of the lesions that I monitored were excised and were benign, and 3% were melanoma. And the ones that were excised, you can see there were 460 excised that were monitored, and 354 were benign, 90 were melanoma in situ, and 16 were melanoma invasive. The average Breslow of the invasive ones was 0.34 of a millimetre. The range was 0.25 to 0.55. And of the adverse outcomes, which were 5.6 of my invasive melanomas, none were monitored lesions. None were monitored lesions. So it's warm work. There are some risks involved, but I wouldn't be elsewhere for thousands. Thank you very much.
Thank you, Cliff. Absolutely superb. And it really makes us think about what we're doing now and where the future's going. And it's upon us, and it's wonderful work. It is warm work. Now, we have a few minutes before a delightful afternoon tea. I'm sure, Cliff, there'll be some questions for you. There may well be for Amanda as well, so we can just take a moment. Anybody would like to start some discussion? Yes.
You raised concerns about the Heine Delta 30. What about those who have already invested in other Heine products like the Delta 1? Asking for a friend. So the Delta 1, do you have the same concerns about, is it just the Delta 30 that can't see the white polarizing lines? Or
So what was the question about the?
the question is, are other Heine dermatoscopes also at fault?
Okay, the Heine dermatoscope issue. The only Heine dermatoscope that has a problem that I know about is the Heine Delta 30. All the earlier ones were fine. The Heine Delta 20T, fine, no problem at all. All of the other ones are fine. But when they brought out the Heine Delta 30, I found out about the problem from a colleague. I notified them. I went to Bad Bernbach where they make them, and I told them. And they said that their dermatologist said it was fine. I said, okay, so we published it. We published the paper on different dermatoscopes showing comparative images and showing that the Heine Delta 30 didn't show any polarizing specific white lines at all. In fact, it was unique in the world. And the paper proudly pointed that out. And they immediately developed the Heine Delta 30T, Heine Delta 30 Pro, which is perfect. I've got one of each with my name carved in it by Heine. So it's a very important issue. And as far as I'm concerned, the Heine Delta 30 should be sold to surgeons to check their surgical margins with, because the polarizing specific white lines don't matter there. It should not be sold to people diagnosing melanomas. I told them out there today, you make sure you tell everybody who's selling this thing to that it's a Rolls Royce with faulty airbags. And they conned this guy over here, so.
Yes.
What do you think about the rule follow-up only once? I saw some follow-ups.
Follow-up only once, that's dangerous, and that's totally wrong.
Okay.
I've had melanomas I've followed up and diagnosed after 5 years.
Ah, right.
So I don't stop following up unless the thing goes away.
Oh yeah, exactly. So I learned that follow-up, if you have doubts, you cut it out. But don't say I have doubts and follow up a second time.
Well, for example, with nail matrix melanoma, I follow up for at least 2 years.
Right.
Okay. Anything I'm monitoring, I won't stop monitoring until after 2 years, unless it's going away.
Right.
Okay. And some things are. I use total body photographic detection now to select lesions for monitoring, because then you're getting a better pre-test probability that it's a lesion of concern. When the photofinder picks something up, after the interval of monitoring, I either discard it if it's something that's irrelevant, like a sole lentigo, or I excise it, or I monitor it. And if I monitor them up, I monitor them, at least 2 years. And some things I've monitored longer, and some things that we've stopped monitoring after 4 years. When we examined the patient clinically, we've noticed that the thing we were monitoring before is now bigger than the thing beside it. We've gone back and checked it, and we've published one now. It's in press. That turned out to be a melanoma arising in an involuting nevus. A nevus was involuting. We stopped monitoring, and bang, a melanoma arose in the nevus. And we picked this, the first time it's been picked that I know of that moment that happened.
Yes, yes.
Do you have an opinion about the My Skin app, which has now been endorsed by the British Skin Foundation?
Sorry about
It's
that.
called the My Skin app, MII.
I know nothing about the My Skin app.
It costs around £25 per annum, and you can develop, like you can have login details to log in from different devices. It reminds you every 3 months to check your skin. And it also has, like, you can choose the areas and then take photographs, because this is something that has been endorsed by British Skin Foundation.
Okay.
But you don't have dermoscopic images. So I don't know if, I have been telling all patients for the past 2 years about it. And in US, I believe you can link it to your dermatologist. So you can send photos to them, and I don't know. So
I know
is that
nothing
something
about
that's
it.
used?
No, I know nothing either.
But I would like to be linked to something in someone's home.
Yeah.
Can I jump in there briefly? The The International Dermatoscopy Society, working with the European Academy of Dermatology and Venereology, has produced a position statement on the use of apps for self-diagnosis. And these are proliferating. If you look that up online, you should be able to find it. I believe it's an open access paper. They say, yes, these patient-used apps, they're potentially good, but they must be tested and have various cautions applied to them. So there are lots of people who are trying to sell apps. There's a possible downside to them. I was talking to an American specialist who said they're having terrible trouble because people who are selling self-diagnosis apps, obviously, they're very, very frightened of false negative diagnosis. You reassure somebody, then it's a melanoma, so they sue you. So they set them at an impossibly high level of sensitivity. So lots of people are using these apps and they're going to dermatologists saying, well, the machine told me it was a melanoma, and it isn't. So it's creating a lot of extra work, a lot of extra fear. So if you go online and look up European Academy of Dermatology and Venereology position statement on artificial intelligence apps. And we've heard from Dr. Atwan that the British authorities, the BAD is working on a statement which should be out later this year.
Correct.
Although it's nice, wasn't it?
Nice.
Nice. NICE.
I'm a bit out of date, but My Skin approached me when I was looking after DermNet, and they had the biggest hearts and really wanted to do the best for people. And the intention was simply to provide an archiving system. And at that point, they said they were not going to use artificial intelligence, but that's 3 years ago. Are they using artificial intelligence now?
In the MindSkin app?
Yeah.
They say according to what you buy, how much you spend, there might be some AI attached. I have never done that.
It might be
a
whole body. It might be whole body detection of new lesions.
Just use log their nose.
Yeah, that was its original intention was an archiving system, and you could take your pictures to your doctor, and they really wanted to help people. But I know there is some ridiculous claims made by some of these apps.
The MySkin is just archiving. It's just
It's just archiving. Yeah.
It's just that.
So I think you can support that.
Amanda,
Thanks,
just
Amanda.
while you've got the mic there,
Simba.
for somebody considering investing in a total body photography system, what suggestions would you give in order to discover the different systems that are available and how to investigate the best technology out there?
Well, Cliff decided on PhotoFinder, and you're pleased with PhotoFinder. PhotoFinder have got a great reputation. They've been around for a long time. But there are competitors. I really can't say because I only know.
Yeah, Canfield is apparently good. PhotoFinder is good, but I've just shown you where it failed to pick up an invasive melanoma, and they know about that. And it may be because there wasn't much pigment in it. I don't know. But you need to know the limitations, so I've told you the limitations. Apart from that, I think it's an excellent system and much, much less expensive than Canfield, for example. But I've never had experience with Canfield. Once you get one, you're committed to it because you need to be able to use the same device to compare old photos. So you can't go for PhotoFinder and then change to Canfield because then you've got to discard all your previous photos.
The Vectrus knew them.
That's not the Canfield one, though.
Well, Canfield has a range of different products, and Canfield produces the Vector.
Oh, right.
Yeah. They also have a range of artificial intelligence-driven software that they don't promote yet because it's not validated fully.
Yes, over here, and then we'll come back. Yep.
Just a quick one, not related to photographs. I was just interested to find out in Australia or New Zealand, what is the sort of prevalence do you have with patients who've had metastatic SCCs, and how do you sort of follow them up? Do you do any scanning? And maybe the same with Merkel cells as well.
So questions regarding metastatic squamous cell carcinoma, they don't come to dermatology in my region, plastic surgeons and oncologists, but we certainly discuss them at the multidisciplinary team meetings. So I'm aware they exist. There's about 300 deaths from melanoma and about 150 deaths from squamous cell carcinoma per annum. And of course, the SCCs are much more common. And most of those are in head and neck, and most of them are immune suppressed, with renal transplant patients being a huge problem.
And in Australia?
Australia, you want a comment from Australia? Cliff, can you?
Sorry?
Can you give us a comment on metastatic SCC and management in Australia? With it?
And what about SCC?
Yeah.
What's the question?
Just
But basically, MDMs.
yeah, it's the same. It's basically I'll answer it for you. That's okay. Yeah, it's basically the same sort of thing in Australia and New Zealand. We have MDMs. The squames get picked up. The local public system, often some are private, but they get gathered up and followed carefully and managed correctly quite quickly. Yeah, and Merkel's are very rare, as you know. There's a slight rise of them in New Zealand, and the similar thing, they get picked up, they're managed very, very quickly.
In Australia, when we find a cancer, it's managed straight away. So if we find a melanoma that we don't want to operate on, it's operated on within a couple of weeks in the public system. A Merkel cell carcinoma, they'll see 2 days later.
Yep.
So we don't have these problems that you have in the UK and in New Zealand. Our system is very, very, very efficient, both the public and the private system. Probably because we have such an amount of skin cancer, it's funded fee for service. So if a GP treats a melanoma, they get fee for service, the same payment that a specialist surgeon would get for dealing with that. So GPs have found it very worthwhile upskilling to manage skin cancer. That's why we run the Master's course at the University of Queensland. We have more alumni now than there are dermatologists in Australia. More highly skilled GPs have done a Master's degree in skin cancer. So we don't have these problems at all. So you should all come to Australia.
And New Zealand. We're pretty good too, aren't we, Amanda? Come on, we are. Okay, this is very good. So look, we've broken into afternoon tea time. So if you could be back in here by 25:02 for the last session. I hope you're enjoying yourselves. It's going well. We're very pleased with the feedback and input and question time. And we'll see you shortly. Enjoy afternoon tea. Last session of the day. I hope you're all feeling good, and we're coming into a nice soft touchdown before you get to go home and have a nice night out or whatever you're going to do. But Nisha's back, and she's going to traverse for us really the dermoscopy of the skin of colour, which is very, very important. And we're really looking forward to your here. I've got it. This one here.
Thank
How's
you.
that?
Thank you.
You're right. So, welcome.
Thank you. Thank you. I hope this will be a colorful presentation as here. Actually, the dermatoscopy of skin of color is a bit challenging if you are not get used to see these melanocytic lesions. Because when you see blue and gray color in fair skin types, it means that you need to excise it. But in skin of color, blue and gray color is very common. For example, this is a lesion located on the leg of a skin type 4 patient. And you see whitish areas, blue structures, blue clots. And the patient said that this is a lesion there since birth, and it doesn't change at all. So what is this? This is a congenital nevus. When you have dermal melanocytic nests in the deeper dermis, we all know that it looks like blue. In skin of color patients, I don't know exactly the reason for that, why blue color is so much common other than blue nevus. Dermal component generally looks like blue structures or blue clots. For example, this is an ulna nevus. It's located on the chest, and you see again blue-gray clots. Maybe you said that we see also some whitish areas around the blue clots. This should be a sign for melanoma. When dermal nevus is traumatized, whitish color is very common, especially on the hair, on the scalp, on the face when you traumatize after shaving or something like that, picking. White lines is very common in dermal nevus when it is traumatized. And the patient said that this never changed. This is there, no worries. And in my practice, in my early years, I generally excise these type of lesions and saw that they're all dermal nevus. Again, another patient, we see purplish blue clots. And again, we have some white lines because it's traumatized. And now, what do you think it is? Is this different from the previous one? This is a patient, skin of color patient. This time, again, we have blue clots, gray clots, and white lines. And this is totally different with the previous one. This is a pigmented basal cell carcinoma. We have pigmented basal cell carcinoma very common in Turkey, and around 90% of these basal cell carcinomas are pigmented. In skin of color patients, we very less commonly see pinkish basal cell carcinomas. All basal cell carcinomas are just looking like that. For example, what do you think it is? This is the dorsal hand of a 6-year-old boy. Is this Spitz? What we see here is blue structures, and we have rainbow pattern. It can be seen in everything other than Kaposi sarcoma, even in basal cell carcinoma, even on scar tissue. Rainbow pattern can be seen in everything. So ignore the rainbow pattern, just look at the underground. We have blue structures. And the patient is a child. This is a blue nevus. Another lesion looking like a blue nevus, right? But I said that this is not a blue nevus. This is not a basal cell carcinoma. And this is a dermal nevus. What can be the reason for that? Why this is dermal nevus, not blue nevus, instead of blue nevus? Because here we have terminal hair, you see? And around the hair, terminal hair, we have perifollicular pigmentation, hypopigmentation. In blue nevus, generally the blue structureless part involves around the hair follicles as well. Do not respect the hair follicle. You see blue structureless everywhere in blue nevus. And when you see perifollicular hypopigmentation and terminal hair on the surface, it's most likely to be a dermal nevus. And this was a traumatized dermal nevus. We excise it, and histopathology showed that this is a traumatized dermal nevus. You see the white lines. This is secondary to trauma. Again, we have two patients. One is basal cell carcinoma, one is dermal nevus. Which one is dermal nevus? Which one is basal cell carcinoma? Yeah. This is basal cell carcinoma. You see the ulceration here. This is a nodular basal cell carcinoma, and you see the vessel here. Since there's pigmentation, hypopigmentation, the pigmentation obscures underlying the vascular structure. If you know Photoshop techniques and enlighten the image, you can see the branched vessels more clearly. And here, we have again blue structureless, but this is not a basal cell carcinoma. Again, we have here vessel. So why this is dermal nevus instead of basal cell carcinoma? Any guess? Hair. Because if this is a basal cell carcinoma, it should be nodular basal cell carcinoma, right? Because we have blue color. Blue color is located in the dermis. So hair follicles should be distracted. But we see the hair follicles. Then this is a dermal nevus. Again, another patient, BCC or dermal nevus. Which one? Dermal nevus. Again, we have hair, terminal hair, and you see perifollicular hypopigmentation around hair. And here again, we have a perifollicular hypopigmentation. This is not a blue nevus. This is a dermal nevus of a skin of color patient. I enlighten the image. These two lesions are eczema, contact dermatitis, and we see spongiosis, and these are vesicles. And the first lesion belongs to a skin type 2 patient, and the other one a skin type 5. So even in eczema, dermatoscopy is different. The pigmented structures are very common in skin of color patients. For example, do you know the diagnosis? They have the same diagnosis here. This is an inflammatory disease. LP. Lichen planus, right? Because we have here Vicam stria, you see? And again, we have Vicam stria, but I will look at the background. It's blue structureless. This is skin of color patients, skin type 5. But we still have Vicam stria, which is the clue for the diagnosis. Of course, we combine these dermatoscopic features with the clinical context. You don't know the clinical morphology here. I just show you the dermatoscopy. For example, these are, what's the diagnosis here? Any guess? The one on the right side is skin type 2. This is skin type 4 or 5. Actinic keratosis? No, it is not. We have follicular plaques here. This is lupus. This is, you can see the follicular plaques, scale and vessels. Look at the morphology here. And again, yeah. And follicular plaques, they're all pigmented. The background is more pigmented. But here, the follicular plaques, plus the clinical context, was a clue. So again, an inflammatory dermatosis, fair skin type and dark skin type. The one on the left-hand side is a psoriasis. You see the dotted vessels and scale. And here, since the erythema is a darker erythema, the vessels are not so prominent when we compare with the light skin type. So psoriasis is an easy diagnosis for fair skin types. But for darker skin types, it's very hard to see the dotted vessels. But here, the scale, and again, the clinical context is helpful. What are these structures? Darker skin type and fair skin type. In comparison, I would like to show you. Any guess? The clue is capillary macules. Yeah, these two lesions are neurofibroma, but they look completely different, right? In fair skin type, we can observe the vessels easily, but in darker type, vessel is not so prominent. Again, left and right, same diagnosis. Any guess? I can say that in skin of color, it's much more beautiful, right? Much more colorful. Yeah. Because we have purple, claret red, blue, white, and we see here rainbow pattern. So these two lesions are Kaposi sarcoma. So why there is difference, especially for the inflammatory dermatosis, the lability of the pigmentation is much more prominent in darker skin types. Again, darker background and sclerotic reactions. That's why we see white lines much more common in skin of color patients, and follicular reactions are much more prominent in skin of color patients. I think you all know the distribution of melanin and melanocytes in fair and darker skin types. The number of melanin is higher in skin of color, whereas the number of melanocytes is equal in all skin types. And there are some studies published by the International Dermatoscopy Society in skin of color. I advise you, if you are interested in this topic, the differences and the dermatoscopic features are very well described in these published studies. Now, I'm going to ask you some questions. What is this? A solitary lesion on the back. Any guess? We have a darker erythema, and we have some vessels. They look like coiled. Perfect. This is clear cell acanthoma. Fair skin type and dark skin type. Okay. The background erythema is just different here. Again, let's have a look at. Any guess? The vessel is the clue here. There's heavy pigmentation. Yeah, perfect. You see, you get the vessel. And these vessels are called, in metaphoric language, cherry blossom-like vessels. And we say this, vessels with bulbous endings in descriptive terminology. This is ecrine poroma. You see the vessel morphology. Again, skin of color and fair skin type, you can see the difference. In skin of color, at first glance, they're not so visible, right? But when you look at carefully, we see these vessels with bulbous endings. Again, another ecrine poroma in a fair skin type and darker skin type. Easy diagnosis, dermatofibroma. It's heavily pigmented in skin of color. And again, comparison, fair skin type and dark skin type. They really look like maybe amelanotic melanoma, right? Because we have white lines, dotted vessels, and pink structureless. The major clue here to differentiate amelanotic melanoma and dermatofibroma is, I would advise you to press on the lesion and with the plate of your dermatoscope. In dermatofibroma, there is fibrosis, and this fibrosis is both in vertical and horizontal sections. So in dermatofibroma, when you press over the surface, you see just white structures. area. But in melanoma, when there is white lines, when you press on the lesion, you see again just white lines. It's not yet more whiter. You see just white lines, but in dermatofibroma, you see white structures. Another clue is dimple sign. Another clue is the history. That when the patient says that it's there for a long time and it doesn't change, and when you palpate it and it's solid and firm on palpation, it's a dermatofibroma. Again, dermatofibroma were skin of color and fair skin types. Erythema is different. And peripheral pigmentation, there's no pigmentation there. And here, some more examples of dermatofibroma in skin of color patients. Maybe that one is looking like your case. And now, what do you think this is? There are some pigmented spots on the face of a child. And let's go back. And I gave a treatment, and they're all gone. What is this?
You were lucky.
Again.
Has it gone too far?
Yeah.
I'll go back.
Let's go back. Let's go back.
Good.
Let's go back, please. One more. Clinical and dermatoscopic. Any guess? Is this nevus? No. And 1 month after therapy. Okay. This is a viral infection.
Yeah.
What's that? Viral wart.
Yeah.
Verruca plana juvenile. Have you ever heard about it? It's a HPV virus infection and generally observed on the face and dorsal hand. In skin of color, they are generally pigmented brown, but in fair skin types, they have a pinkish color, and dotted vessels are much more visible. But in skin of color, it's hard to see that those dotted vessels, and I prescribe here topical retinoic acid. And it's very effective because it peels the surface. This is a superficial viral infection, and it's really very super therapy, and the patient is also happy. Another patient with varicoplana juvenile, you see, this is fair skin type 2 patient. Again, we have brown flat lesions. This time, dermatoscopy is just like that, looking like maybe a seborrheic keratosis, but they're all wart, okay? Again, the treatment option is topical retinoic acid. Another pigmented wart, you see dotted vessels, but they look like pigmented here. And again, another wart with Auspitz phenomenon. And now, here's the dermatoscopy. Any guess? Perfect. This is porokeratosis because we see the cornate lamella. We will see it in the histopathology. Double keratotic rim at the periphery, you see. So dermatoscopy is really very helpful in the diagnosis of porokeratosis. We observe papular lesions on the leg, but as soon as we put the dermatoscope on the surface, we see this double keratotic rim, and it's highly diagnostic for porokeratosis. And here you see the histopathology, the keratotic rim, and dermatoscopic and histopathologic correlation. You see the parakeratotic column, and it's a dermatoscopic correlation. Another interesting case. What's your clinical impression here?
Old.
The patient is 21 years old, and this is there since childhood, early childhood. It looks like a maybe linear epidermal nevus, varicose nevus, right? Maybe segmental lichen planus is also possible here. And another option,
Like in aureus, like in striatus.
yeah, but it's very long history for lichen striatus, and pigmented variant is extremely rare in lichen striatus. Let's have a look at with the dermatoscopy. Yeah, great, because we see here double keratotic rim. You see, look at the periphery. But what's beautiful here is UV dermatoscopy. Keratotic rim, double keratotic rim, is very visible with UV dermatoscopy. It's really very easy to diagnose with UV dermatoscopy.
It's an unusual pattern. It looks linear, though, doesn't it?
Yeah, linear segmental porokeratosis.
What's the diagnosis?
Segmental porokeratosis. Yeah. And these are also cases of porokeratosis, fair skin type, and basal cell carcinomas. It's very common to see. And fair skin type and dark skin type, you can see the difference. Just the color of erythema is different. Fair and dark skin type, you see one is pigmented, very similar features. Fair skin type, dark skin type. And when I enlighten the image, the vessels are much more visible. What's this? I'm asking you. Basal cell, who says this is a basal cell carcinoma? Who says this is a melanoma? Okay. Seborrheic keratosis? No. So the differential is between melanoma and basal cell carcinoma. This is a polarized mode. If you are not sure about it, whether it's a basal cell carcinoma or melanoma, have a look at with non-polarized mode. Those white structures all disappear, right? And we see branched vessels. So this is a basal cell carcinoma. And we have also May globus. Yes, which one is blue nevus, which one is basal cell carcinoma? Yeah, perfect. Which one is melanoma, which one is BCC? Perfect. Melanoma on the right, BCC is on the left. Here is melanoma. What is this? Seborrheic keratosis. What's the clue here? We have looped vessels and centered vessels. Perfect. Irritated seborrheic keratosis. This is a fair skin type, seborrheic keratosis. And non-polarized mode, you see the milia-like cysts and centered vessels much more clearly. And non-polarized mode of the fair skin type, seborrheic keratosis. What is this? Seborrheic keratosis. Let's have a look at with non-polarized mode. Is it seborrheic keratosis? Yes, it is. Heavily pigmented, but polarized and non-polarized mode helps us. What is this? Non-polarized mode. Seborrheic keratosis again. Pigmented variants of seborrheic keratosis is also very common, but with the modes of the dermatoscope, it's easy to diagnose. What are those? SEPK again, pigmented variants. Now, let's find the basal cell carcinoma here. Which one is basal cell carcinoma? A? Maybe. Suspicious. I think we should take a biopsy from that lesion, right? B? What's B? BCC? C? D? E? F? Yeah. F is definitely a basal cell carcinoma. B is lichen planus-like keratosis. You can see some milial-like cysts underlying. You see, seborrheic keratosis is going under regression. B is LP-LK. I biopsied A and F. because I think A also is suspicious for basal cell carcinoma. It's not a clear-cut seborrheic keratosis, right? And histopathology say that A is also a seborrheic keratosis. F is nodular BCC. What is this? Collision. Collision of what? BCC and solar lentigo. Could it be a collision of lentigo maligna and solar lentigo? Maybe melanoma is on the upper part, solar lentigo here. And I said that this is a benign lesion. There is nothing basal cell carcinoma and melanoma here. I take the biopsy from here because this part was suspicious, right? Yes. It comes as seborrheic keratosis. We have curved, thick lines at the periphery, well-demarcated borders, but anyway, it's a suspicious lesion. In skin of color patients, seborrheic keratosis are generally looking like this. Now, two lesions. I would like to learn your preferential diagnosis here. What's the first one? It's easy, very easy one, right? Because we have radial lines converging in a common point. So the first one is a basal cell carcinoma of a skin of color patient. Well, how about the second one? BCC? Maybe, but it's not a BCC. We have scale, right? We have keratin. Is it common to see scale and keratin in basal cell carcinoma if it is not a basal squamous carcinoma? Perfect. We see radial lines in also Bowen's disease, right? So this is a Bowen's disease. Scale, keratin, and radial lines. For example, what do you think about this lesion? Sun-damaged skin? Looks like BCC. I also consider here a basal cell carcinoma. And when I learned the histopathology, it was a surprise to me because it came as heavily pigmented Bowen's disease again. Bowen's, yeah. Yeah. And this came as pigmented squamous cell carcinoma arising on actinic keratosis. And here you see the keratin and blood spots here. Yeah, this is the invasive part, probably. And these parts are actinic keratosis parts. Fair and dark skin types, it's easy again, easy diagnosis. Bowen's for sure. This time there is no pigmentation. We see clustered coiled vessels and keratin and some blood spots. And here, background erythema is darker, but we have coiled vessels. Yeah. And what's your diagnosis here? SCC. But this SCC is developing from Bowen's disease. You see coiled vessels, and this is keratin and blood spots. Invasive squamous cell carcinoma. Again, another SCC. We have again keratin. When you see yellow keratin, always consider SCC spectrum. But we can say that this is, again, pigmented squamous cell carcinoma, which is quite rare. But in skin of color, pigmented variants of all types of skin cancers are very common. Blue and gray is the color of skin of color patients. Fair and dark skin types, spot diagnosis, easy diagnosis. We have white circles, keratin again, and blood spots. And again, we have keratin, vessels. They're both squamous cell carcinoma, well differentiated. Again, well differentiated squamous cell carcinoma with a peripheral pigmentation. Again, SCC, fair and dark skin types. You see beautiful white circles. It's very characteristic for squamous cell carcinoma. And this is double keratoacanthoma, which is very rare to see them together. Another keratoacanthoma in a skin of color patient. Now, a question for you. Which one is malignant? this patient is 7-year-old. So what can it be? What can be this one? 7-year-old patient. Spitz. Because we have white lines quite common in Spitz nevus, and they're all looking like a melanoma. For sure, we excise it. And what is this? I think this is very similar with your case. Do you remember? Yeah. This is hemosclerotic dermatofibroma, fibrocollagenous dermatofibroma. And what is this? Number 3. There are multifocal erasions. You see? Erasion, erasion, erasion. These cross are all erasions, superficial erasions, ulcerations. This is a pigmented basal cell carcinoma. It's very tricky. And here are the diagnoses. Okay, we can finish.
Oh, thank you very much for that wonderful presentation.
Yeah.
And time has eluded us a wee bit, but that was fantastic. Now, is there any quick burning questions? Nisha, that was a tremendous traverse of the skin of colour, which is so important, especially in our country too. We have a lot of people with skin of colour, and it is tricky and difficult, and I've learned a lot. It's fantastic.
Thank
I'm sure
you.
everybody has it. Thank you very much.
Thank you.
Okay. All right. The next speaker is Osama, and welcome back. You're all good to go?
All good to go.
Okie dokies.
I think Lisa covered most of the things, so do you have any questions for me? Fantastic talk. I really enjoyed it, Lisa. So I think I need a microphone. So I've got 15-20 minutes, very quick, to talk about actinic keratosis, Bowen's, and SCC. I think Nisa already touched upon these things very nicely. So it will be hopefully a straightforward presentation. So I've heard that you all like anatomy, like medical school. No. But I thought I'll bring some anatomy anyway. And I think it's just not complicated, but it's just to make sense of what we see in histology and what we see in dermoscopy. And then we'll just go through a few cases of AK, actinic keratosis. Sometimes you call it solar keratosis as well, but we don't say SK because normally when we say SK, it's seborrheic keratosis. So it can be confusing. So in the UK, we say AK is actinic keratosis, SK is seborrheic keratosis as a standard, really. So, and then Bowen's, which is squamous cell carcinoma in situ, and then invasive squamous cell carcinoma. You all know the medical school anatomy of the skin. We've got 3 skin layers. So we've got the top, the epidermis. Middle layer is the dermis, where you've got the hair follicle roots, the eccrine sweat glands, the blood vessels, the nerves. And below that, we have the subcutis or the subcutaneous fat or the hypodermis. Now, if we take a punch biopsy from this area, just zoom in into the epidermis, that's what you will see. Starting from the bottom up, so we have the basement membrane, that black line, wavy line, and that separates the epidermis above from the dermis below. And immediately outlining that basement membrane, we have the basal cells. So these basal cells of the keratinocytes are the mother cells. They produce keratinocytes. And these cells are, where is it now? So these are the brown cells. Imagine these are the keratinocytes. So the keratinocytes migrate from the basal layer. Oops. How do I go back again? The keratinocytes migrate from the basal layer upwards towards the top of the skin, and as they reach the top, they die, and they produce keratin. So that's the top surface, the corneal layer, is dead keratinocytes. Now, all of my talk now is about the keratinocytes. Actinic keratosis, Bowen's disease, squamous cell carcinoma is all keratinocyte abnormality, keratinocyte dysplasia. So it's all of that is keratinocyte problems. Now, the best approach, my way of thinking, and I have very simple way of thinking normally, is to think about it as a spectrum. You know, actinic keratosis at one end of the spectrum where it's not cancer. And we used to call it pre-cancer. When I started studying dermatology, they say actinic keratosis is a pre-cancerous condition. Is it really a pre-cancer? If it's something, a true pre-cancer, you would expect it to stay as it is or to progress to cancer. But in fact, about 20% of actinic keratoses with no intervention, just sun protection and moisturizer, there is 20% chance that it will resolve by itself. So it's not really a true pre-cancerous thing. Yes, there is a small risk of progression, maybe 1 in 3 to 400 risk that an actinic keratosis can progress to cancer. But then towards the worst end of the spectrum, in the middle, we have squamous cell carcinoma in situ. And that is what we call Bowen's disease or SCC in situ or intraepithelial neoplasia. And that is a true pre-cancer. Because if you leave it, if it does not progress to squamous cell carcinoma, it will always be there. After a year, 2, 3, 5 years, it will always be there. So that is a true pre-malignant condition. Some consultant colleagues, sometimes they say Bowen's disease, someone who's 80, don't bother to treat it. I do, because why would we take the risk of something progressing to invasive cancer if we can treat it? Topical treatments, we've got lots of options, and CNC, curettage, so we have options. So I treat it. And then the invasive part of the spectrum is the squamous cell carcinoma, invasive squamous cell carcinoma. Now, if we imagine the histology that I was talking about, so in the case of actinic keratosis, there will be some abnormal keratinocytes, and imagine these red cells are dysplastic keratinocytes, abnormal dysplastic keratinocytes. And as there is a bit of dysplasia, they will produce a little bit more keratin. So you will see the stratum corneum, the top, becomes slightly thickened, slightly more scaly. So that is keratosis. So that is actinic keratosis. When it comes to Bowen's, in the histology report, it will say full thickness epidermal dysplasia, meaning the whole layer of keratinocytes is dysplastic. Okay, all of the epidermis is dysplastic, and as a result, there is more hyperkeratosis on the surface. In the case of squamous cell carcinoma, these dysplastic keratinocytes become invasive. They breach the basement membrane, they invade downwards into the dermis, and they rise upwards as well to form that area, which we'll see clinically as well. So there will be a bit of shouldering there. And then in the middle, there will be that mass of keratin. So clinically, that's what it will look like. So that's just to give you an idea of what we see clinically and histologically. So of course, I can't talk about this topic without referring to this paper back in 2012, published in the Blue Journal again, Zalaudik et al. And I, of course, Cliff is one of the co-authors in this study, and I think Jeff Keir was one of the co-authors as well. So it's a nice diagram just to show the pattern of the transition from actinic keratosis on the top there, and that's what we will see some examples of. And then actinic keratosis moving into Bowen's, and then Bowen's, and then Bowen's progressing into invasive squamous cell carcinoma, early invasive squamous cell carcinoma, and then advanced or more invasive squamous cell carcinoma. I found it very helpful because it shows the difference in the vascular structures. It shows the difference of the white structures. And I think, it's just to keep that in mind, I think it's a helpful diagram to look at. So starting with AKs, I think it's the bread and butter in dermatology, especially if you work in sun-exposed, high sun exposure countries, Caucasian skin type 1, skin type 2, it's inevitable. So actinic keratosis is common, and patients normally will have these dry, scaly lesions on sun-exposed areas. There can be multiple lesions. Normally, there are multiple lesions. They can be completely flat, and that's low-grade actinic keratosis. They can be slightly more thickened, and that's a high-grade actinic keratosis. And normally, sometimes you don't see it. You just run your finger on the skin and you feel it. So it's easier felt than seen. And that's very mild low-grade actinic keratosis. But the typical actinic keratosis will be these pink, scaly patches on sun-exposed areas. How would you know this is actinic keratosis and it is not eczema, or it's not psoriasis, or seborrheic dermatitis, or discoid lupus, or something similar? I think that's where, dermoscopy always helps. And I think the typical 3 hallmarks of actinic keratosis, Nisa mentioned that already. You'll find the redness on the background, and you will find the hair follicles are dilated and they are plugged with keratin. So they are white in color because there is keratin plug in them, and they are dilated in size. They're slightly bigger. Plus minus scaling. Now, if you take dermoscopy with non-polarized light, so you apply the medium, the gel or the oil or whatever, that sometimes can mask the scaling. So you don't see it if you use gel on the surface. But generally, you would see at least 1 or 2 of these features. The redness on the background, the hair follicles are white and dilated, and sometimes you see the surface scaling. That's the typical strawberry pattern. I'm one of those people who likes to use the metaphoric description because, I'm very sort of simple in my way of thinking, but I think, it does look like a strawberry skin. So it's redness on the background and the white follicular opening. So it looks like a strawberry pattern. Another example on the tip of the nose, and I don't know if I have a close-up, no. So in this case, again, a lesion on the tip of the nose. It can be, of course, actinic keratosis, but it might be, I think, maybe BCC or something else. You look with dermoscopy, it ticks the boxes. Redness on the background, white, dilated follicular openings. You don't see scaling here, but it doesn't matter. You've got enough to say this is actinic keratosis. And if you pay attention to these areas, can you see the small white dots forming a square? Small dots, 4 dots, white dots in a square. That's what we call rosettes. So these rosettes is a sign of sun damage. It's not pathognomonic for actinic keratosis. It's not diagnostic. You can see it in any sun-damaged skin condition. So the rosettes are not entirely specific. We see it sometimes in BCCs and melanomas and other things. But it's a helpful thing to know what they're called. They're called rosettes. Another one there above the eyebrow, and that's what it looks like in the middle from close-up. Again, it can be anything. It can be even inflammatory. But when you look with dermoscopy, again, redness on the background, the hair follicles are white and dilated. And there is a little bit of pigment. You can see it towards the top there. So that's pigmented, slightly pigmented actinic keratosis. You can see the hyperkeratosis scaling here and scaling there. So that is a slightly pigmented actinic keratosis. Now, what about this one? What do you think? So this lesion, I'll help you. So this lady came and she's had this lesion for a long time, for about 18 months to 2 years. And it is not symptomatic. It's not tender. It does not bleed. So what does that make you think? You think, well, BCC, normally the typical history is it will bleed intermittently. It will form a crust. If it's SCC, 2 years, small size like this, I would expect it to grow bigger and quicker over 2 years' time. It will be tender. Tenderness is one of the clues for squamous cell carcinomas. So in this case, it's not always straightforward. Yes, we can see the hyperkeratosis here. There is some hyperkeratosis. It is a little bit red on the background, yes. You can't see follicular openings very clearly. It's just because it's overkeratotic. It's a lot of keratin on it. So this came through the teledermoscopy clinic. So I reported on this and I said, well, it looks like maybe a bit of sun damage, actinic keratosis, or something similar. I advised the patient to apply white soft paraffin or yellow soft paraffin, Vaseline, just thick, greasy moisturizer every day. And I'll bring her to see her in clinic in about 6 weeks' time. Even if it was a squamous cell, to wait 4 weeks or so is not the end of the world. So when they come usually after a few weeks, if it's actinic keratosis, that keratin will be dropped off and it will be much, much easier for you to see what's going on. And in this case, when she came, it's completely flat, red patch, and it was typical for actinic keratosis. So just a greasy moisturizer for a few weeks and then assess. So in this case, it was just hypertrophic actinic keratosis. Just a bit of moisturizer, thick, greasy moisturizer, not lotion or not cream, something very oily like yellow soft paraffin or white soft paraffin. Another lesion on the nose there, is it lentigo maligna? No. Why not? Why? Yes. That's it. So Nisa mentioned before the inverse approach, remember? The inverse approach for early detection of lentigo maligna. And if you apply that, does it have features of actinic keratosis? Does it have redness on the background? Yes. Does it have dilated follicular openings? Yes. Then by default, it's actinic keratosis. It's not lentigo maligna. So by exclusion, we excluded lentigo maligna by identifying the features of actinic keratosis. That's the inverse approach. It's one of my favorite approaches.
Left side looks like actinic keratosis, but the right edge, there's a pigmented part with angulated lines.
This one.
This part. Maybe there's a lentigo maligna there. That part, yeah.
In fact, this patient, yeah, I think I saw this patient years before the inverse approach, and I biopsied it. And I
take the biopsy from the left part?
I took the biopsy. Yeah, I took the biopsy, incisional biopsy from this edge, including. Yeah, we had a few cases of exactly that, actinic pigmented AK with lentigo maligna. I don't have the images here, but this case I did biopsy an ellipse throughout the middle part of the whole lesion. So over a third of the lesion is taken in the biopsy, incisional biopsy, not a shave, and it was just pigmented AK. And we treated with Effudex, and he never came back. I hope it was just pigmented AK. But you've got the biopsy. We've got the biopsy. And that is another one. So on the nasal ala, again, it's completely flat, slightly scaly. You can't tell until you feel it. But in this case, the redness on the background, dilated follicular openings, and it is a pigmented AK. This one's slightly more thickened, and another one that's even more thickened. You see multiple areas of actinic keratosis, typical, but this one is different, and this is what you see in a close-up. Dermoscopy really doesn't help me much because it's just keratin. There are some keratin plugs, some circles here. So the key for me is the history. So if it has been there for only a couple of weeks, growing quickly, it is tender on palpation, I would excise it without hesitation because it could be a squamous cell carcinoma. If it has been there for 6-8 months, it's not painful, not tender. I'd think more towards hypertrophic actinic keratosis. I'd just give them thick moisturizer, maybe Effudex for the other areas, and then review a few months after. So this is a patient, again, a lesion on the scalp, and that's what it looked like. And I couldn't see the erythema, what's going on, the details under this area here. And I just suggested using Vaseline, thick petroleum jelly. And 3 months later, repeated the photographs, and it's almost completely resolved. So sometimes all what they need is just a bit of moisturizer. In Bowen's, I think, again, we've seen multiple examples, but clinically, this is what it looks like, an erythematous keratotic plaque with scalloped edge or polycyclic edge. You can see the edge has multiple convex areas on the edge. That's the typical textbook presentation. Nisa showed us lots of nice photos of these. Again, these coiled blood vessels everywhere. They're described as glomerula and areas of hyperkeratosis. And usually they are long-standing. They would be there for a long time with no significant change. That's a close-up just to see the pattern of the blood vessels. Another example. We did biopsy this because this area, Nisa mentioned, we've got this sort of brown mass or keratin in the middle. I thought, is it early invasive squamous cell carcinoma? And it came back as just Bowen's. Another Bowen's that is slightly more pigmented now. You look, and we don't want to miss melanoma when we see these cases. This one is worse because the pigmentation is more worrying here. And you can see it's dotted, coiled blood vessels everywhere. Maybe whitish areas there a little bit. So when I see pigmented Bowen's like this, I always biopsy just to make sure I don't miss melanoma. But it was just pigmented Bowen's disease. Remember SCC, when there is invasion into the dermis, there will be more vasculature. It's a tumor, it's growing, it needs a blood supply to grow. So you will see more vascular structures in SCC, and that is the typical pattern of keratoacanthoma-like squamous cell carcinoma, where it's rapidly growing. And you will see the three things. The main thing is the central area, the keratin mass, which looks yellow-brown in the middle. And then there is white structures. White means keratinizing. So white means keratinizing. So there is this sort of whitish area there, and maybe pink-white in the periphery. And sometimes you see white rings or circles, and polymorphous blood vessels, so multiple patterns. In this case, lines here, and maybe more hairpin vessels towards the periphery. The hairpin is usually one of the early signs. When it becomes more invasive, they become more thickened, linear blood vessels. This one on the nose, it doesn't look much there, but dermoscopy, very nice white rings there, and the keratin mass in the middle, and maybe a little bit of vascular structures there. So that was proven in SCC. Another one, the same features, keratosis, white areas, and polymorphous blood vessels. And this one and this one. So this patient came, these three lesions at the same time, all of them were SCCs, and all of them were excised in one session. And that's a very nice photograph, just to show a side profile, to show the keratin mass with black dots and these linear blood vessels, coiled blood vessels, dotted blood vessels, and the white structures. So do I have one more minute, or? Yeah? So just to say, always correlate. And it doesn't make a lot of sense to me to see just a dermoscopic image and to say, what is this? Because you have to put everything together. As Nisa said, in the clinical context, you have to correlate. So this is a younger patient, and the GP treated for fungal infection and treated with different topical zoles, clotrimazole and ketoconazole, etc. It's not responding. And you think, is it eczema? It could be. Is it psoriasis? Maybe. Is it something else? Yes. So dermoscopy, sometimes, if you just see just this image without knowing the clinical picture, you will see red, pink background. You will see some white perifollicular white areas. Follicular plugging, yeah. So that's keratin plugging. And there is more vasculature than what you would expect in an AK. So that's typical for discoid lupus. Yeah? So it's not psoriasis, it's not eczema, it's not actinic keratosis, definitely. So you have to get all the information right. You need to see the clinical picture, duration, symptoms, etc. What about this one? Just if you look at the clinical image there on the left and the dermoscopy on the right, what is going on there? Oh, no. Oh, I showed you the answer. Damn it. Sorry. Oh, the other way. I'm sorry. Oh, I got it. I think I got it. Yeah, I got it. Yeah. So just to say, yeah. So here you are. So if you look at that, you think AK, right? Yeah. But again, without looking at the full picture, it's just excoriations. The patient has been scratching his forehead all the time. And this white areas is just reactive keratotic changes because of the trauma from the scratch. So that's just the patient with pruritus, just localized excoriation on the scalp. There is no AK. So just put everything in the clinical context. That's just to leave the last few images, just picture them in your head, AK, Bowens, and SCC. Thank you.
Thank you very much, Osama. That was fantastic. Kate's got a question. No problem.
One question from someone online. The question is, why blood vessels develop in keratotic lesions, particularly Bowens, as the epidermis doesn't have blood vessels?
So, so why we see blood vessels in Bowens?
Yes.
Well, that's a good point. I'll ask for everyone's contribution, but I think because of the dysplasia in the epidermis, that leads to some reactive changes in the upper dermis. And if you think about psoriasis, for example, we see these dotted blood vessels in psoriasis because of dilatation of the blood vessels in the dermal papillae. So I think my only suspicion is that because of the changes in the epidermis in Bowens, it's just dilatation of the blood vessels in the dermal papillae in the upper dermis. Oh, sorry.
Squamous cell carcinoma in situ has a brisk lymphocytic reaction, and that would induce dilatation as well.
All right. I think that's it. And thank you very much, Osama, and for that wonderful presentation. And we'll just keep that there, I think. Welcome back to Cliff. Now, this is the final session. Cliff's got a wonderful case study to share with us before we conclude. And we're running a little bit behind time, but you've got tons of time, Cliff. You can take the time out.
All I need is
that. You need this one.
That's the one?
Yep.
Thank you very much. Well, it's been a great day, and I've learned a lot of stuff today. So I'm very glad I came along to this session, eh? And now I'm going to talk to you about the terrible twins. So this young lady came along, 2009. We'll call her Leslie. Multiple nevi. Family history: father died of melanoma at 33, 1 week before she was born. And her mother's age 60 now. And I started looking after her in 2009, which is here on my journey. I was just starting to get a few more melanomas a year, getting more and more interested. I was doing full-time general practice, and I started recording everything on the SCAR database just prior to that. And then she turned up, and she was referred from my brother, who's a GP, this lesion of concern. So what do you think? Chaos or no chaos? Yeah. Eccentric structures area? I cut it out, and it was a nevus. Okay. Then I took a family history, and I said, do you have any other family history? Dad having melanoma? No. So no one else in the family? No. Do you have any siblings? Yes. A sister. How old is your sister? She's the same age as me. We came from the same egg. I said, well, send her in. Julia came in. And as she walked in the door, I saw this lesion on her knee. And you can see it's a lesion which extends away from that dark part to a lighter part, so it goes right out here. And you can see it's an asymmetrical lesion, it's chaotic. This is not skin coloured, it's brown, so it's an eccentric structuralist area. It's got some areas of thick pigment network where the lines are thicker than the holes that they surround. And so I excised it, melanoma in situ. And that was my introduction to these two girls. So there's the tally up the top. Leslie's a nevus, Julia a melanoma. That was all 2009. And I started monitoring multiple lesions, including some raised lesions. You don't monitor raised lesions if you think they might be melanoma, because they'll already be invasive. But when you get random monitoring, you can monitor anything. So this is one of the lesions I selected to monitor. And look what happened. February 09 to September 09, and when I took that second image and scheduled her for surgery, I didn't sleep for a couple of nights. I thought I've monitored a thick invasive melanoma here. Cut it out, it's a nevus. And all it is, I've squished it to one side with the dermatoscope. This is right back in my early days. So I made it look different by the fact that it wobbled. I took the second picture on a different part of the wobble to the first picture. So it was just a nevus. So this is a learning curve for me, managing these two girls. So there we got nevus, 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 nevus on the left with Leslie and melanoma on the right. Now, I saw this one. I thought, gee, I should have checked the buttocks before. And you know, these girls have been told they've got dysplastic nevus syndrome. And you know, with dysplastic nevus syndrome, you get buttock nemi. That's one of the features, right? And I looked at this and I thought, this is nasty. This is asymmetrical, it's chaotic, it's got thick reticular lines. So I cut it out, nevus. So there you go, there's the tally. Then I sent them to a dermatologist publicly because I thought I'm getting nervous, I really need some help here. And he picked two for me to cut out. And I hadn't picked either of these two, and that was one of them. So I cut it out, it was a nevus. And he picked another one, that one on the arm. Cut out was a nodular melanoma, Breslow 1.4. So I said to him, how did you pick those lesions? He said, I got a vibe. I said, what? He said, I got a vibe. I said, can you teach me how to get a vibe? He said, no, you're a GP. And anyway, that was, I thought about that. And around about this time, I met Harold Kittler, and he made the comment that a method that cannot be taught is barely a method at all. Right? So the vibe thing I discarded. Looked at this, because I spent hours looking at this lesion, right? And I worked out it had the melanoma, the cutaneous melanoma geometric sign, the angles. It was pretty symmetrical, it had a bit of grey in it, right? It was a lesion of concern because now I know no nevus looks like that, so it's a concern. A lesion of concern with the dermatoscopic, that's enough to cut it out on KS, please. So I learned a lot from spending probably 10 hours looking at that image, thinking about it. So the big melanoma means it was an invasive melanoma. So we got from 2009 to 2010, and we've scored 2 melanomas and a lot of nevi. So this is Julia, this is still 2010, and I looked at this and came to the conclusion I should excise it, so I did. It was a melanoma in situ. Julia was getting more than her fair share of melanomas compared to Leslie. And then this lesion. So I'd see these ladies every 6 months, and I'd see things, okay, I've got to cut that out. Nevus. There's the tally. Then I found this one. I thought, oh gee, I've missed something here. This is a raised nodular thing. We're up to 2014, nevus. And you see all the arrows there. All those arrows are things that I'm monitoring and checking. And there's the tally getting longer. And then Mum came in. She thought she would have a skin check. And so I looked at this lesion here, put it under the dermatoscope, angulated lines. All that white stuff's makeup, by the way. These girls wear so much makeup I can't even get it off. I scrub and scrub and scrub with the alcohol wipe, can't get it off, but that's all right. That was a melanoma in situ, lentigo maligna on Mum. So now we've got 3 columns. But that's the last time you'll see Mum's column because nothing else has happened to Mum. These genes came from Dad. And then we've got this one here, and I cut it out. It was a melanoma in situ. I think it changed, but I can't remember, but it was a melanoma in situ, but it still hasn't got much in the way of features. And I'm wondering, am I just cutting things out because I'm scared? So when I get to the end, I'll look at my number needed to treat and see if I've already done that. And then this one here. So this is called inverse network or negative network. It's supposed to be a clue. But what it is really is pigmented clods separated by hypopigmented lines, okay? Nevus. And you all thought that was going to be a melanoma, didn't you? I did too. So I must have, oh, hang on. I've go back a little bit. Yeah, okay. And in the meantime, I've put a DF there that I haven't shown you, the dermatofibroma I cut out. Now this is the one I showed you before, and I monitored that, and I cut it out, and that was still a melanoma in situ. This is random monitoring. So again, Leslie's had one melanoma, Julia's had 1, 2, 3, 4, and only one nevus excised. And this came up really rapidly, really rapidly. And I thought, oh, this is nasty. Size it, fibrous papule. Okay, so then this little thing on the posterior arm, I came from, oh, I thought, I mustn't have seen this before. It's got radial lines or pseudopods down there, or maybe it didn't have them before, but it has now. Melanoma in situ. Julia. So she's still scoring all the melanomas. Then this one, now this looked really nasty. This is evolved. These are the signs up the top are different. Nevus. Okay, and then this one. Well, this has got lots and lots of peripheral clods. There's something nasty going on here. Spitz nevus. Okay, well, it's a very asymmetric Spitz nevus, but I accepted that. And my dermatopathologists are really, really good. I selected them very, very carefully, and they share things with each other, because if I'm not happy about a sign out, I'll ask to see the slides myself. And at this stage, I was actually getting copy slides for everything. And I was happy that this was a Spitz nevus, so I didn't argue with them. And then this one here, that's a Molmax image from 2016. And I monitored this one over a long period of time, 2016, 2017, 18, 19, nothing going on. And then 2021, suddenly, wow, this has changed. Melanoma in situ. So was it a melanoma in situ all the time, or was it a congenital nevus? And these ladies don't have dysplasia. I think this is a melanoma arising in a congenital nevus, and it was certainly reported. And so here we're probably picking up a point in time where a melanoma is arising. It's still all on Julia's side. And then we have a look with the total body photography with detection, and I'm looking at this one up here. Tiny, tiny little thing. Wow, peripheral clods. Yeah, we're on the money here. Nevus. But still, have to cut that out. It's been detected, it's changing, and it's got peripheral clods, and this presumably is a growing nevus. But even if it's not, because we've done an elliptical excision biopsy with 2 millimetre margins, undermined in the fat, this person is safe. If we've done a shave biopsy, as you saw, whether a recurrent nevus comes back or a current melanoma comes back, if you do a shave biopsy, you cannot rely on the margin assessment with a shave. If the pathologist says the shave excision is complete, the pathologist is telling you something the pathologist should not be telling you, because they cannot assess the margins of a shave. Every margin on a shave biopsy is a close margin, whereas elliptical excision, only the middle one is a close margin. And you cannot assess the ends of a shave, only through the centre. So this is cut out, even if it's a melanoma, the patient's safe. And then we've got this one. Now this is really, really interesting, because you go back to the previous images and you see 2017, and then you see that same scar. This is 2022. And so you see the lesion has increased in size substantially. And this is detected by the photo finder with total body photography with detection. And we go back and look at the original images. And you can see there, here is the spot where it turns out to be. It's not there at all in 2009. And nothing in the dermatoscopy, nothing. This is a melanoma site detected by the software and by having previous images to compare to. Now, you might think this is all time consuming. It is, but 2 young lives are at stake. And it's fun doing this, right? It's fun doing it. I don't charge these girls anything because I was terrified they wouldn't ever come back because they're that sort of, they're very focused on lots of things apart from their melanomas. And so I just see them every 6 months. But this is an example of a totally featureless melanoma. And in this context, I think it's really, really important that we can diagnose those sorts of things. Look at the column now. And then this thing on the back. Now this, I thought, oh, this is nasty. Look at the polarizing Pacific white lines. Dermatofibroma. Look at the column now. And now the one you've seen, the one that my nurse picked up because she's just a good nurse and she's diligent and she loves her work and she does a really good job. People that love their work do a good job. And that's so important. The photo finder missed this, but she found it. And this could have completely undone everything I've been doing for these girls all that time. Breslow thickness 0.3, a totally featureless melanoma. So there's the journey. They've been on the journey with me. They still are. They started there and they're up to there and they're going strong. Tell me which ones are the melanomas. The ones at the top are all melanomas. The ones at the bottom are all nevi. Okay? The ones at the top are all melanomas, and some of those are completely featureless, and the ones at the bottom are all nevi, and most of those have lots and lots of features of malignancy. So there they are. In summary, 90 lesions managed over 15 or 16 years, 18 excised straight up, out of which were 5 melanomas, 72 monitored. Out of those, 4 melanomas, 8 benign, and 60 excisions spared. 30 lesions excised, 9 melanomas, the number needed to treat was 3.3. So for every 3.2 nevi excised, 1 melanoma. And I think that's not bad. And when Jim Muir tells you, Finbar, that photographic technology is a waste of time, you just remember these twins. Thank you very much.
Thank you, Cliff. There's a superb ending to a wonderful day, and what a wonderful case set that is to remind us all how it is. And as you say, we're having fun. It is fun, isn't it? This
Absolutely.
is really why we do it.
Absolutely.
That's what it's all about.
And that's why you're all here.
Yeah.
Because none of you will make a cent more from learning all this stuff because you don't get paid for treating skin cancer. You're here because you want to have fun. And that's great.
That's the most important thing. Any burning questions for Cliff? All right. Can I just bring the speakers down to the front just for the final goodbye? And any last questions you may have for anybody? Now's your moment. No questions. Good, nice photo. Let's get a. We do have a question. Yes. Ultraviolet for dermoscopy. Nisa.
Ultraviolet dermoscopy. UV dermoscopy.
UV. Oh, Lisa. I know nothing about it. UV dermatoscopy.
What's the question?
UV dermatoscopy.
Yeah, we have that just with DL5. Especially, it's a different technology, but it's very helpful for differentiating inflammatory skin disease, scabies, for example, for infectious disease. You can see the mite very clearly with the help of UV dermatoscopy. And for some seborrheic keratosis, it may be helpful, but for inflammatory disease, like, again, an infectious disease like molluscum contagiosum, it's very effective. If I have the images, I would show you, but for scabies and molluscum contagiosum and some seborrheic keratosis, it's really helpful. And nowadays, some dermatologists use it for delineating the surgical borders, especially for lentigo maligna. You can see the borders clearly with the help of UV dermatoscopy. But
Andrew, can you turn the lights
Casio's dermatoscope, we have 405 nanometers sub-UV mode. It's my favorite light, sub-UV mode. Again, you can delineate the surgical borders, vessel morphology, ulceration, crusts. It's very helpful. I think new technology, when we combine it with polarized, non-polarized modes and 405 and UV dermatoscopy, it's really very easy to diagnose some diseases.
Can I just add to that? If you look at Wood's lamp for delineating surgical margins, so we published a paper about 6 years ago for lentigo maligna. So it does show the margin very clearly. So now our current standard practice is before we excise facial lentigo maligna, we put them through UV light first to delineate the margin before we start the excision.
Yes.
Any recommendation or any opinion about the pigment booster button in DermLight?
The pigment booster button in DermLight. Who's going to talk
It's a
about
waste of time.
Yeah,
Don't
I don't
use
use it. I don't use it. It's a pretty colour, isn't it?
Yeah,
Doesn't help.
It's a pretty colour. Just makes the pictures look nice.
My colleague, Dr. Chin Huaibru, who's active in the Primary Care Dermatology Society, has created a video looking at all the different kinds. She's a fanatic. She's got about 20 different dermoscopes. So you look up Chin Huaibru, Whybrew, and you'll find some work she's done online quite easily, looking at different dermoscopes.
And she's the first author on the paper we did on the DermLight 30 that showed it was a Rolls Royce with a faulty airbag. She's the first author.
That was a Heine, not the DermLight.
Oh, sorry,
It was a
Heine.
Yes.
Yeah,
Absolutely.
DermLight's fine.
DermLight's a Rolls Royce.
Yeah.
It's a BMW. Right.
I've got a question.
One more question.
It's for you, Cliff. Do I need the microphone? Did those women have any genetic testing at any point?
No, they didn't have any genetic tests at any point, although they're probably positive,
You should have.
but it wasn't going to change the management at all. They haven't had any children, and so if it's not going to change the management, we don't spend the money doing the test. That's something in Australia we do.
I think they need at least, you need to do the BAT1.
Why?
Because other cancers, uveal carcinomas.
We're checking their eyes all the time. They're having the checks all the
Are you
time.
doing their breasts? Are you doing their uterine testing? Are you
Okay.
doing brain cancers?
Okay.
They need to know.
All right. Good points made and all very good and useful. Yes.
My question is, are you coming next year?
Are we coming next year?
I'm coming if they're coming.
Andrew, are we coming next year? Andrew decides.
Your friends, enroll early. There's only about 30 with about 10 days to go at one stage. So if you can support us and enroll early, if you do intend to come, it would make a massive difference.
They made the decision to come when they were going to lose lots of money unless lots more people came. So they put
We backed all you people and you backed us, thank you. But please network for us. We will. We'll get it on the website. We'll get organised. We are going to come back. It sounds like we'll go to London. We're most likely to come here as well. And Ireland's put their hand up as well, so it looks like it's a British Isles event. You never know, Wales could get interested. It could be a very interesting time, but we would love to come back. Do you want a one-day course, two-day course? Most two? The 2 days better, right? And this masterclass, how enjoyable was that? Pretty good? Yeah, so we'll try and do one in London.
I've got a question. Weekdays or weekend?
Weekends, hands up. Weekends, hands up. So this is different. Yeah. That's week. Friday, Saturday, Sunday, hands up. Yeah. And then weekdays, Thursday, Friday, Monday, Tuesday. Yeah. So that's interesting.
I think if you do a Sunday, people would like to finish maybe by 2, 3 o'clock.
Yes.
Because to make their way back home and get ready
Very
for
good.
work
It's good
next
thinking.
day, so.
It's the same in New Zealand. Our doctors want to be out in the weekend learning too, but they do want to finish early. So it's good. That is wonderful feedback. Are there any feedback from our esteemed speakers, presenters?
I think it was a fantastic day. I really enjoyed it. I learned a lot, of course, from everybody. And it was fantastic. I really enjoyed it, talking to my colleagues here in the audience as well. So it was fantastic. I really loved it.
Could I just encourage anyone who's not a member of the International Dermoscopy Society to join? It's free of charge. You can join online. They have a lot of wonderful resources, including on Facebook and YouTube, where there's a wealth of brilliant videos and we run a big we run a global conference every 3 years. There's one in October in Buenos Aires, Argentina, and there'll be another big conference in a European country. I can't say. I'm not allowed to say you which
he
one
whispered,
yet,
I know, but I won't say
It's
either.
going to be very good indeed.
Yeah, my lips are sealed. Okay, well look. Paris is not Paris.
And I can
Okay.
support that.
Well,
As
this is
the
it,
New
everybody.
Zealand
I want to
rep.
thank you, speakers and presenters, scientists, doctors, most wonderful people in the world for today and yesterday. And from us to you, it's adieu. Safe travels home. We'll take our time getting across the globe. Come in, we'll be back next year for sure.